शिखर साए में उगा नया सूरज फैला प्रकाश। विश्व चिकित्सा में आगे बढ़ के हम सबका गौरव देश का मान। जय जय विजयपुर जम्मू गूंजे देश विदेश में इसका नाम। जय जय विजयपुर जम्मू गूंजे देश विदेश में इसका नाम।
आशा से बढ़कर है समर्पण, सेवा ही अपना धाम।
शिक्षा से शोध की ज्योति रोशन करे हर आकाश। मिटे रोग खिले तन मन सेहत लाए हर मुस्कान। जय जय विजयपुर जम्मू गूंजे देश विदेश में इसका नाम। जय जय विजयपुर जम्मू गूंजे देश विदेश में इसका नाम। विजयपुर के हम सब मिलकर लिखेंगे नया इतिहास। मुश्किल राह भी रुक न पाए मजबूत कदम मोटल विश्वास। एक ही लक्ष्य एक ही इरादा स्वस्थ बने अपना देश महान। जय जय विजयपुर जम्मू गूंजे देश विदेश में इसका नाम। जय जय विजयपुर जम्मू गूंजे देश विदेश में इसका नाम।
इधर नहीं भाई, उस साइड उधर जाओ ना यार, उधर से जाओ।
असंख्य मन के सपनों को दे वक्त पर मिला
त्रिकुट शिखर के साए में उगा नया सूरज फैला प्रकाश विश्व चिकित्सा में आगे बढ़ के हम सबका गौरव देश का मान जय जय विजयपुर चंपू गूंजे देश विदेश में इसका नाम जय विजयपुर चंपू गूंजे देश विदेश में इसका नाम
आशा से बढ़कर है समर्पण सेवा ही अपना धाम
शिक्षा से शोध की ज्योति रोशन करे हर आकाश मिटे रोग खिले तन मन सेहत लाए हर मुस्कान जय जय विजयपुर जम्मू गूंजे देश विदेश में इसका नाम जय जय विजयपुर जम्मू गूंजे देश विदेश में इसका नाम विजयपुर के हम सब मिलकर लिखेंगे नया इतिहास मुश्किल राह भी रुक न पाए मजबूत कदम अटल विश्वास एक ही लक्ष्य एक ही इरादा स्वस्थ बने अपना देश महान जय जय विजयपुर जम्मू गूंजे देश विदेश में इसका नाम जय जय जयपुर जम्मू गूंजे देश विदेश में इसका नाम।
A very warm good morning to the respected dignitaries, esteemed faculty, and dear delegates. I, Dr. Saima Malik, Senior Resident, Department of General Surgery, AIIMS Jammu, along with Dr. Ayush, Postgraduate Resident, Department of General Surgery, AIIMS Jammu, welcome you all to Jakasicon 2026.
It's a matter of great pride and privilege for us to inaugurate this prestigious academic gathering. We extend a heartfelt welcome to our distinguished speakers and delegates.
Jakasicon has always been a significant platform for the exchange of knowledge, skills, and innovation. It brings together surgeons, academicians, and trainees, fostering an environment of learning, collaboration, and professional growth.
This year's theme, From Scalpel to Scope, beautifully highlights the evolution of surgery. From traditional open procedure to advanced minimally invasive technique, it serves as a reminder that while our methods continue to evolve, our dedication to patient care remains unwavering.
We'd also like to acknowledge and appreciate the relentless efforts of the organizing committee, faculty members, and everyone involved in making this event a grand success. With these words, we once again welcome you all and wish you a highly productive and intellectually stimulating conference.
We shall now commence session 1, breast surgery, an important segment of today's scientific proceedings. May I respectfully invite our esteemed chairpersons for this session. First is Professor Dr. Anita Dharman, Professor, Department of Surgical Disciplines, AIIMS, New Delhi. Professor Dr. Ratnakar Sharma, Professor and Head, Department of General Surgery, GMC, Jammu.
Dr. Rajni Bhardwaj, ma'am, Assistant Professor, Department of General Surgery, GMC, Jammu. Dr. Sanjay Dhar, sir, Consultant Plastic Surgery, GMC, Jammu.
Dr. Ajaz Ahmed Malik, sir, Professor and Head, Department of General Surgery, Skin Sora. Now we hand over the mic to the chairpersons to carry the proceedings of this session.
A very good morning to all of you. Welcome to this Jakasicon 2026. We're going to start the first session today. We're privileged to have all the people as chairpersons who have been already introduced to you. The first lecture in this session has to be the Granulomatous mastitis, the silent diagnostic dilemma. This is going to be presented by Professor Dr. Madhumita Mukalipai. Dr. Madhumita, please.
So a very good morning to everyone over here, and thanks to the organizers for inviting me over here. I'm Dr. Madhumita. I'm HOD surgery. I'm Dr. Madhumita Mukhopadhyay. I'm HOD General Surgery at Diamond Harbour Medical College. That's in West Bengal. So since I was asked to speak something on the topic of breast, I thought let's talk about granulomatous mastitis. It's a big diagnostic dilemma, and right now it is one of the most what can I say? It's a commonest differential diagnosis to a breast carcinoma. The rest of the topics in this session is on breast carcinoma. So this is the nearest benign cause, the benign differential diagnosis to a breast carcinoma. So granulomatous mastitis is a chronic inflammatory breast condition that was first described in 1972. I've put it rare in a question mark because right now it's not so rare, it's quite common. Granulomatous changes occur around the lobules and ducts of the breast, and because the etiology of this condition is not very clear, the diagnosis is made by exclusion. And it can be a heterogeneous disease with variable clinical presentation. The most common clinical presentation is a firm unilateral discrete breast mass. So if you think about the causes, we have the primary, the idiopathic granulomatous mastitis, IgM, and secondary causes like tuberculosis, sarcoidosis, polyangiitis, drug-induced, complications of diabetes, silicone-induced, and foreign body reaction. Now, if you think of those that in Southeast Asia, we have only two, the primary or the idiopathic granulomatous mastitis, and secondary, most exclusively is always tuberculosis. The treatment choice again varies. It includes corticosteroids, antibiotics, abscess drainage, multidirectional deep drainage, wide surgical resection, and even sometimes mastectomy. So, what without treatment? There has been a discussion that granulomatous mastitis can be left without treatment, will heal in a few years. Now, what about those few years? We have these patients with a breast mass suspicious of malignancy, with flaring up of symptoms, often an abscess, often a scar, often a sinus. So, what kind of a quality of life are we giving them if we do not go for a treatment? So, a treatment is definitely necessary. I'm just going to present two studies which we have done in our center, one on the tuberculosis part, another on the IgM part. And surprisingly, what we found initially was the treatment is almost similar. So breast tuberculosis, just in short, it's again considered a rare clinical entity, but now is quite common as are other extrapulmonary tuberculosis. It's most frequently seen in the women between 20 to 50. The main age group is around 35 years. Lymphatic spread by retrograde extension from the axillary lymph nodes is considered to be the commonest mode of spread. It usually presents as a lump, might also present with an abscess formation with discharging sinuses. It can also present as a tender nodularity. Definitive diagnosis is made by cytological studies, histology, or bacteriological cultures. Histopathologic findings include epithelioid granulomas with caseous necrosis. This caseous necrosis actually differentiates this from IgM. So we had a study of 64 cases. This was one of the cases initially presented with a large breast lump, slightly tender with an ulcer, which slowly healed with anti-tuberculous chemotherapy. So we had the 64 cases. The age ranged from 19 to 55 years, mean age around 36 years. The 31 to 40 years age group shows the highest incidence. Isolated lump was the most common presentation. As I said, others had a lump with an ulcer, lump with an abscess, lump with a sinus. These were other presentations. And the most common location was the upper outer quadrant, same as breast carcinoma. Axillary lymph nodes were palpable in 45 cases, were single, discrete, and mobile, most of them, and all of them disappeared on anti-tubercular chemotherapy. Now, 8 cases had associated pulmonary tuberculosis, while another 7 patients gave a past history of anti-tubercular chemotherapy, which was actually incomplete. Diagnosis was confirmed by FNAC and CBNAT, only CBNAT, or by histology. And the ultrasonography showed consistently heterogeneous hypoechoic masses. All these patients received antitubercular chemotherapy for 6 months as the usual. Among the 52 patients whose diagnosis was confirmed by FNAC, complete disappearance of lump was seen in 31 patients. And in 13 patients who displayed only shrinkage of lump, underwent a lumpectomy. So this was one of the residual abscess cavity after excision. Now coming to idiopathic granulomatous mastitis. Now, as it was earlier, it was said, it was thought that even if there is no caseous necrosis present, it usually is most probably in India is due to breast tuberculosis, and empirical ADD was given to many patients. And surprisingly, what happened was it was found that most of them healed. So it was thought that even usually granulomatous mastitis in a country like India, it is due to tuberculosis. But right now we know that definitely not tuberculosis, but this IgM is a separate entity, and the reason it healed with antitubercular chemotherapy was because of the drug rifampicin. So we had did a study on rifampicin, and these are the results. So usually IgM is a chronic, again, non-caseating inflammatory breast disease. Gestation, breastfeeding, hyperprolactinemia, autoimmunity, and obstruction of the lobules, along with infection with Corynebacteria and non-tuberculous mycobacteria, these are some of the causes. Since there is no standard treatment up to date, it's a big diagnostic dilemma, and antibiotics, surgical procedures, corticosteroids, immunosuppression with methotrexate, all have been tried in this. Now, what has been found was surgery ranged from drainage of collections to mastectomy. But in most of the studies, the recurrence rate was almost 50%. Along with this recurrence rate of 50%, we had the postoperative complications, including delayed incision healing, flap necrosis, hematoma, and a lot more that added to the morbidity. In the recent years, corticosteroids have been considered effective, but half of the cases relapsed. And the relapse was not just at the end of the treatment, just when you de-escalate the steroid dose, it again flared up. And the response, again, the recurrence rate was almost half almost 50%. As with that, we have the adverse effect of corticosteroids. The patient come with gain of weight. So usually the patient will come and say, "Sir, ma'am, you have started the medicine, but look, I've bloated up like this, and people are noticing me." So that's a big adverse effect. And secondly, we cannot give corticosteroids to a lot of patients. So that's also a drawback. So we come to the role of rifampicin. Now, rifampicin, how does it act? It inhibits the growth of most gram-positive and many gram-negative bacteria, including Corynebacteria and atypical microorganisms that may be involved. Secondly, it has got an angiomodulatory effect. So it downregulates angiogenesis. And thirdly, it's known to inhibit immune response. So we had this prospective study just post-COVID. We started this. It included 21 patients with IgM treated in our tertiary care hospital. All the patients were diagnosed as IgM by core biopsy. Breast ultrasonography was conducted prior to core biopsy in all the patients. Surgery in the form of abscess drainage was done in 6 patients. Now, among these 21 patients, 8 patients received rifampicin as a part of ATD. 13 patients received rifampicin as a standalone therapy, as 300 milligrams twice daily for 6 months. Now, initially, we had to give it as part of ATD because that was just a post-COVID scenario, and our hospital tuberculosis board was not willing to give standalone rifampicin therapy at that point of time. These patients were followed up monthly, and USU was done every 2 months till complete response was achieved. After that, follow-up was done once in 2 months. Now, all the patients were of reproductive age and had a history of breastfeeding. One patient has a functioning prolactinoma. The mean age was 29 years. None of the patients had a history of smoking, but some had a history of OCP intake. And the most common symptom was a tender lump, which was present in 95% of the patients. So this was the clinical scenario. The most common ultrasonographic finding was hypoechoic masses. So no serious side effects were reported to stop the treatment for any of the courses. And these were some of our findings. This was the initial case with a large lump with a nipple retraction along with a redness of the overlying skin, which later led to an abscess formation. The abscess and the ulcer later in the thing. And this was in December that we started rifampicin in this patient. Now, what we found was that initially when you start rifampicin, the symptoms do not go away immediately. The symptoms might even flare up. After 1 month, the condition subsides. Same patient in January and February, and the same patient again 6 months later, where the lump had completely disappeared, no nipple retraction except for the scar tissue. The another patient, similar findings, lump completely disappeared, only with scar tissue. This was a patient with a retracted nipple who could not breastfeed. She presented with granulomatous mastitis, again was treated with rifampicin with complete response. So all of our patients, this was another case with a healing abscess. This patient actually present with multiple episodes of abscess drainage, again was healed with rifampicin. This was a most recent case, still on rifampicin therapy, large breast mass, slightly tender, with an overlying abscess. Abscess was drained, a sinus was found. This was a discharge from the sinus. The patient is still on rifampicin therapy and she has almost, the lump has disappeared. This was the drainage which was received, the drain color which was received from the abscess. So if you talk about it, rifampicin, what we found was there was complete resolution, both clinically and ultrasonographic resolution of all the cases within 6 months. This was a comparison done in few studies, a big comparison. So if you go for surgical management alone, complete remission is around 90, but then there is again the recurrence. Steroids alone, the complete remission is less, recurrence is much more. Combination, again, we have a slight amount of recurrence, but if you go for rifampicin therapy alone, from what the studies say, we have a complete cure at the end of 6 months. So to conclude, our results indicate that rifampicin is effective in the treatment of patients with IgM with complete clinical and ultrasonographic response after 6 months and can be used as a solo standalone medical therapy. The study had limitation, definitely. It was a single-arm trial with a relatively small sample size, and we did not culture NTM or Corynebacteria. So further studies are required. Thank you so much.
Hello. Thank you very much for a good presentation. As advised by the organizing committee, because of lack of time, we'd like to have some questions at the end of the session. Thank you very much.
May I invite Professor Divya Dalia. She is professor in Department of Surgery at PGH Chandigarh. She'll be talking about breast cancer screening in Indian scenario.
Good morning, everyone. First of all, I would like to thank organizing committee for their kind invite, and they have asked me to cover breast cancer screening in Indian context. So, as we all are aware of, it is the leading cause of cancer-related morbidity and mortality worldwide, and 1/3 of the reported cases in 2022, they are from the low-income countries. Even the incidence is much more in the developed countries. Still, the mortality is very high in low and middle income countries. So what are the causes? It is the late stage at diagnosis because of the lack of awareness. There is late initiation of definitive management, and also when the management is started, it is fragmented. Also, in our country, we have younger age of onset as compared to the West. We have two peaks. One is at the age of in third decades and other is in the sixth decades. And also we have highly aggressive variants of breast cancer, that is triple negative breast cancer, in nearly 1/3 of the diagnosed cases of breast cancer. So the age standardized incidence of breast cancer in our country which was reported by Ministry of Health and Family Welfare in 2020, was 25.8 per 100,000 women. And lifetime risk of breast cancer in women is much high in urban women, that is 1 in 22, as compared to the rural India where it is 1 in 60. And the cities like Hyderabad, this incidence is even much more, that is 1 in 8 women can develop breast cancer in their lifetime. And the mortality is similarly proportionately high, 1 in 4 patients diagnosed with breast cancer. And the age distribution, as I mentioned, in various parts of our country, we have early peak in third decade. So the key is the early detection. And what are the prerequisites for early detection? That is the awareness and the screening to detect the cancer at an early stage. And we will talk about the awareness first. There is lack of awareness in our country both about this entity as well as the screening modalities available to diagnose it at asymptomatic stage or at an early stage. Also, we have fear of cancer in our population to accept that I am suffering from cancer. There is denial. Third is the cultural stigma which surrounds around the breast health. Also, we have patriarchal norms which often prevent women from seeking timely medical attention. Also, we have economical barriers both at the end of the government as well as at the patient. So now comes to the screening. What screening is? It is the examination of a healthy population to identify an undiagnosed disease at an early stage. Screening may find a cancer when it is very small, however, it can still miss a cancer. It all depends on the how aggressive variant the patient is having. If you look at this figure, if we think this is the screening time and the another spectrum is the another end. So if the tumor is fast growing, we may miss it between the two screening modalities. However, if the tumor is indolent tumor, we can still detect it at an early stage, which is mostly asymptomatic or at early age of presentation. So it all depends on the growth of the tumor also. So what are the available screening modalities? These are the mammography, ultrasound breast, clinical and self-breast examination. So mammography, it is highly sensitive and specific and gold standard for screening as a screening modality for breast cancer. And there are various countries where national screening program include mammography as a screening modality, and some countries like ours, we have guidelines. So various societies like American Cancer Society, NCCN, NHS, US Preventive Service Task Force, they have recommended mammography as a gold standard, which should be performed annually or once in 2 years. And the starting age is, majority of the guidelines accept is at 40 years. So as we discussed before, in India, only 1.6% of the GDP is allocated for the healthcare. So mammography-based screening is not feasible in our country. And the infrastructure is more limited even in rural and semi-urban India. Also, we don't have trained personnel to read those mammograms. So next investigation is the ultrasound test, which we can use for the screening. It is also very sensitive and specific if it is being performed by a trained radiologist, and it is a good alternative for younger population and women with dense breast. As I mentioned before, we have young women who are having breast cancer, and mammography is not a good modality for at younger age because of the density of the breast. But pitfall is again that we need a trained radiologist to read these mammograms as well as ultrasound. So the success and failure of screening program depends not only on awareness but also the available instruments and the trained radiologists to read those reports for us. Next comes the clinical breast examination in Indian context. There are various studies from Tata Memorial Hospital where they have performed clinical breast examination by trained healthcare workers, and they have followed those patients over 20 years. And they have come out with the results that it significantly downstages the breast cancer and it also reduces the breast cancer mortality in those patients. Also, there are studies from the Trivandrum where they have followed 14 years for these patients where they have subjected clinical breast examination by trained healthcare workers once in 3 years. So it is a standalone screening modality currently in our country, and it also have a low false positive rates as compared to the mammogram. Next comes the self-breast examination. It is not a recommended modality. However, it plays a vital role in educating women about their breast health. Newer tools are also on the way, but maybe in a decade time we will have them in our country. They are both cost effective and they are not dependent on good radiologist. So I will say still we have to depend on the breast examination to make our people aware of the breast health. So issues in India are it is the high cost of diagnostic tools and also the campaigns which has been organized by various societies or by the government of India. They struggle to reach to the underprivileged population of our country. Also, because of the younger or age of onset, high density of breast, mammography is not a good option to diagnose these patients. So the barriers are not only in the health system or education of the person. So what are the solution? Again, we go back to the awareness and to educate our uh, women about the breast health and breast examination. And what are the recommendations in India by the government of India? If there are national programs for prevention and control of cancer, which include breast cancer awareness and community training of healthcare workers for clinical breast examination. And those health workers, they also teach the women who visit to the primary health centers about the self breast examination as well. So the Ministry of Health has issued guidelines that the target population in our country is 30 to 69 years. And clinical breast examination should be performed every 5 years, and the WHO has recommended guidelines for low and middle income countries that 40 to 49-year target population only clinical breast examination is okay, and thereafter clinical breast examination and once in 2 years mammography should be done. So the take home message is screening is necessary, and which method it depends which part of our country we are living in. If we have access to the mammography, so the government of India has recommended mammography once in 5 years. So thank you all for your patience here. If there is any question, I am happy to take that.
Very nice talk, Dr. Divya. Now, we'll take up question later on in the session. Now, I'd like to invite Professor Dr. D.N. Sharma for his talk on brachytherapy in breast cancer.
Respected Chairperson, ladies and gentlemen, a very good morning. Thank you, Jakasicon, for inviting me and giving me the chance to share my views. I will be very brief. I just want to sensitize the surgical community about the role of the brachytherapy in the breast cancer. And it's not a new treatment. Way back in 1920s, the British surgeon Geoffrey Kane challenged the dogma of the Halstead, and he gave an option to the mastectomy that if you implant the brachytherapy needles into the breast, you can save the breast. And you can see this picture I've taken from the British Medical Journal, published in 1927. And as you can see, the radium needles have been implanted in the entire breast, axilla, superficial fossa, and into the IMC chain as well. So he was the first one to give the concept that the brachytherapy is an alternate to the whole breast. This is the standard treatment of the early breast cancer. If you do BCS breast cancer surgery, then the brachytherapy has a role. If you do mastectomy, then the brachytherapy has no role. And after the BCS, the radiation is mandatory. You can't avoid the radiation treatment once you do BCS. And it can be in two ways. One, if you treat the entire breast in more or less all patients, but some patients have a very good features, like they have a small tumor, they have BRCA positive, and they are lymph node negative, margin negative. So it's a very clean group with a small breast tumor, and there you can treat only the lumpectomy area and not the entire breast. So one is called the partial breast treatment, where you treat only the part of the breast harboring the tumor, and the other one is when you treat the entire breast. So these are the two ways you can give the radiation after the BCS. Now let's see the first example. How do we treat the whole breast, and where the brachytherapy has a role in the whole breast cancer treatment. Once you do the treatment to the entire breast by radiation, then you need to give the boost dose to the tumor which was located in the area, and this is called the boost brachytherapy. You can treat these lumpectomy areas for boost and escalate the dose by various radiation technique, but I feel brachy is the best way to boost the technique, because as you can see in the picture, if you treat the entire treatment by only the external treatment, then those pillars will be there over the heart, into the lungs, and the other areas as well. But if you do brachy, it is very precise and very accurate, and you do not need to treat the other areas of the adjoining breast. I will not go in details that how we do boost brachytherapy. This is one study we published from AIMS Delhi when I was there, and we treated 100 patients by the boost brachytherapy, and none of the patients had a recurrence. So our results were 100%, and the fire survival was 56%. This was published in February, and since the results were 100%, many of the colleagues questioned me that how can this be 100% in breast cancer? This is one problem here, that if your results are poor, people will appreciate. If you have poor results, poor country, poor resources, then nobody is going to raise a question on this. But if you have excellent results, then they will say you put the data and your data is fictitious and all kind of things. But this is the fact in front of you. And after this, there are many series from Western countries where the results were 100% in the breast cancer treatment. This is the second part of the radiation to the breast, where we treat only the part of the breast harboring the tumor, which is called the partial breast irradiation, or the APBI. And the patient has to meet all these criteria if we want to treat the patient by APBI. First, the tumor size should be less than 3 centimeters. Of late, I've been treating patients who have tumors like as large as like 4 centimeters because of the growing experience. And then age more than 40 years. Hormone receptor doesn't matter, whether positive or negative, it doesn't matter. Any grade of the tumor, focal adverse is acceptable. And if the patients are low negative, then they all will fit for the partial breast treatment. If the patient has no cavity or no clips, I know of late the surgeons do not leave the cavity, which is a reference for us. But then in that case, you have to apply the clips so that demarcates the area which was having the tumor, and so that we can treat the patient by the radiation to that area. Patient having positive margins, this is a relative contraindication, but sometimes I do take these patients for partial breast, especially they have other features, good features. Extensive DCIs, post-NSCD patients have N2N3 disease and multisense disease are all contraindicated for the partial breast irradiation. This is the philosophy behind the partial breast irradiation. One, that most of the patients will have a recurrence within a centimeter around the lump. So you do not need to treat the entire breast, just the centimeter around the BCS cavity. There are ample literature on partial breast irradiation by brachytherapy technique, so I will not go into details. But I will cite one article which was published in Lancet just 2 years back, and a good follow-up, like 10 years data. And as you can see, the patients treated by whole breast RT versus the partial breast RT. there was hardly any difference. So why treat the entire breast where you can get away with the partial breast treatment? There are 40 odd techniques of the partial breast radiotherapy, but for the ease of like demonstration or discussion, I've divided into 3 categories. First is the brachy-based technique of partial breast, which are like balloon, interstitial, where you can insert the brachytherapy catheter or catheters into the lumpectomy area, and you can get away with the treatment. The second category is the EBRT, which means the action beam radiotherapy techniques, where the patient just lies on the couch. Treatment is given from the outside, and it is very common for the patient, but the only problem is that it is not as accurate and as precise as the brachytherapy. And the third category is interpretive techniques, like we give the radiation treatment with the electrons or deep X-ray, there and then to the operation theater, and treatment is finishes there in the operation theater. Entire radiation, entire surgery is over in the surgical OR. But of all the techniques, in my experience and my opinion, the brachytherapy is the best technique, which is very, very precise, accurate, and very less time consuming. This is one technique of the partial breast radiotherapy, where you insert a balloon or the multiple catheters so as to cover the lumpectomy area and a centimeter around that. But this is not very popular because it is a disposable catheter, very costly, not available. The other technique is very, very cost effective, very simple. And this is one patient which we have treated at AIIMS Delhi. And as you can see, the multiple catheters have been inserted. This was during surgery. And then later on, after the surgery, we did the scan and the dosimetry and the treatment, like 4 to 5 days after the surgery, which is called, that is what is called perioperative brachytherapy technique. Various guidelines on the role of brachytherapy in the breast cancer, especially technicalities, but I will not go into details. We have our own recommendation from India, and as you can see, I was the one who wrote this article on the IBS recommendations on the brachytherapy in the breast, published just a year back. There are 2 basic techniques of the partial breast treatment or the brachytherapy in the breast. One is the perioperative technique, where you insert the catheters during the surgery and treat the patient like up to 2 or 3 days when the healing is more or less complete. And then the other technique is when is called possibility, when the entire surgery has been done, pathology details are there with you, so it's done around 3 to 4 weeks after the surgery. When you all complete radiological, clinical, and pathological data, so you can assign the patient for partial breast or the whole breast. There are few basic differences. This is the first technique of the brachytherapy in the breast cancer, which is called perioperative. And as you can see, during the surgery, we chip into the operation theater and we assess the tumors, location, dimensions, and then we accordingly insert the catheters. And as you can see, after the brachytherapy incision is over, we close the wound, and then we treat the patient after like 4 to 5 days from the surgery. This is the same patient where you can see the CT scan done after the brachytherapy, and we created dosimetry, and then we treated the patient. As you can see, excellent dosimetry, which means the dose is covering the entire BCS area and the lumpectomy area around that, but practically no dose to the skin, the adjoining lung or the heart. This is the second technique, which is called perioperative technique, positive technique, where the surgeon has closed the cavity, and then off late, as I told you, we do not find cavities, which are slightly difficult for us, but then in that case, you have to place the clips. As you can see, the 4 clips you can visible in the CT image, and this is the guidance for our radiation treatment. And based on the CT images, we insert the first stainless needles, and then we thread the catheters through these needles, and then we do the treatment right like half an hour, 1 hour after the brachytherapy catheter incision. There are various dose recommendations. ABS, which is American Brachytherapy Society, 34 grade 10 fraction 5 days. That means treatment is over within just 5 days. And the Jakasicon guidelines, European guidelines, 32 grade 8 fraction 4 days. That means treatment finishes just in 4 days. We at AIIMS has our own protocol, 35 grade 10 fractions 5 days. So this is our protocol that we finish the treatment in 5 days time. This is our own AIIMS in-house protocol that on day 0, that means day of the surgery, we do the white block excision or the lumpectomy, and then we place the catheters in the theater. And then on day 2, we do the CT simulation and planning. On day 3, we start the treatment, and which means like 2 days treatment. If the patient, by the time patient has the histological report. If the patient fits into the APY criteria, we go ahead with the APY criteria and treat for another 3 days. That is 5 days treatment. If somehow the patient is not fit for partial best, then we stop there and for 2 days, which means only the boost treatment with the 14 gain for vaccine. Thank you so much. Thank you.
Because of paucity of time, we might be taking questions in the end. It feels wonderful to be as a chairperson, sitting with other co-chairpersons, and a wonderful lot of team there in the audience. Thank you very much. May I have the pleasure of inviting the next speaker? It is Professor V. Senu. It's a very interesting topic. The topic is personalizing breast cancer surgery, introduction to individualized oncoplasty. And may I request you, sir, please be closer to the mic so that you're audible. Thank you.
Thank you, chairpersons, and good morning to all of you. And thanks the organizers for this opportunity. Now, the most important thing when it comes to oncoplasty is a shared decision making. I put this as a single slide initially because sometimes I see young surgeons on WhatsApp groups discussing that I could not do this, some person has done all that. So what is important is knowing the technique is good, but when you try to give it to a patient, then it has to be a shared decision making, and this has to be uppermost in the mind of everybody. Now, oncoplasty, as the definition is, basically you take care of all the tumor with good margins and also provide good cosmesis. Now, effectively, the oncoplasty can be classified into 2 types, the level 1 oncoplasty and the level 2. Level 1 is when the amount of the tissue which is lost is just enough so that you can displace the breast tissue as it is and try to gain symmetry and cosmesis. And level 2 is where the amount of the breast tissue lost is so much that you have to augment it with either a tissue which is nearby or a tissue which is little far. Now, these are the indications for oncoplasty. Like basic thing is whenever there's a large tumor and you do a conventional BCS, the cosmesis may not be good. And whenever you want a hidden scar and where the tumor is located. But more important for all of surgeons, as we know, is our teachers teach primum non nocere. It is important to know where all we should not do this. It should preferably be avoided in diabetics where the sugars are not under control, active smokers, age more than 70 years, and a low volume breast without ptosis. Now, these are the basic considerations. As I said, what are the tumor characteristics, where is it located, how far it is from the skin and the nipple-areolar complex, because these are important. You don't want a displacement of the nipple-areolar complex as compared to the opposite side. And also breast aesthetics and glandular deformity, density, because a dense breast, even if you mobilize in 2 planes, the tissue will still have good vascularity, whereas a fatty breast in an elderly woman, if you do a dual plane mobilization, then the cosmesis may not be good. And most important, as I've said, is patient expectations. Now, this is, I think, the most important slide, and which is what probably the organizers wanted me to speak about. Like nowadays, for every quadrant of the breast, there are literally more than 3 surgeries which can be offered to a patient, depending on a number of factors. So this is the important thing. Like you can augment the breast, or you can do a good oncoplasty in almost all patients who are suitable for breast conservation. Now, this is what I said, like if it is a superior quadrant tumor, if there is ptosis, then you can go for an inferior pedicle. If there is no ptosis, you can go for a round block, so on and so forth. So what I'm trying to tell you is that for every quadrant of the tumor, it is possible to do breast conservation surgery with good cosmesis. And aesthetics, and as all of us know that a small breast in a large framed woman does not look good, and vice versa. So this also has to be taken into consideration. And scars, the scars should be as far as possible acceptable. And some patients may want a hidden scar, so which can also be done nowadays. And as I said, ptosis, again, extremely important. When you look at the ptosis of the patient, it is a ptosis which decides which type of surgery you offer to the patients. And whenever you do breast conservation surgery with oncoplasty, the most important thing is when you compare it with the opposite breast. So like all of us know that in India, majority of the women do not want anything to be done to the contralateral breast, which is not the case in the West. So you have to see that the contour of the breast, the size of the breast, the nipple areolar complex, they all look almost similar. See, plastic surgery is nothing but creating an illusion. You will not be able to give everything picture perfect, but you try to give it as close to reality as possible. Now, glandular density, as I said, very easy to assess clinically and by mammography. And as I said, more fat, higher risk of fat necrosis. So, limit undermining, especially in the dual planes. Dense breast, it is a surgeon-friendly breast. And here, even if you undermine in both planes, the breast will still have good vascularity. Now, this is one of the things which has to be taken into consideration when you are doing something called as a therapeutic mammoplasty, where the position of the nipple, the width of the nipple areolar complex, the distance from suprasternal notch, and distance between the nipple and inframammary cutis. These are all the things which have to be taken into consideration when you are offering therapeutic mammoplasty to patients. Like as you can see here, like there are some standard numbers which are available in most books and also on the YouTube videos, which you have to follow if you want to give good cosmesis to the patients. Now, the next important thing is the conceptualized anatomy. So, this anatomy becomes extremely important when you are trying to do something called as the random pattern flaps using tissues in and around the breast to reconstruct the breast. So, these are the general principles I said. Skin incision, there is no definite rule. Extensive undermining is essential to facilitate reshaping. So whenever you do a volume displacement technique, the most important thing is to mobilize the tissue adequately, and preferably you do it in the subcutaneous plane but not in the prepectoral plane, because that will cause the skin to tether. So it's better to mobilize the subcutaneously and then approximate the breast first and then approximate the skin. Now, this is one of the procedures. Now, I'll go through quickly because Deepak will be talking more about this later. Like if there is a tumor which is in the center of the breast, then you can do something called as a donut mastopexy. And if it is just above the nipple areolar complex, you can do something called as a batwing procedure. And if it is a very large breast with ptosis, then you can do a superior pedicle based or inferior pedicle placed therapeutic mammoplasty. Now, these are the flaps which are commonly used, the myocutaneous flaps and the perforator flaps. Perforator flaps are the things which are used to replace breast tissue, which is about 30 to 40% loss. Whereas you use a myocutaneous flap, especially the latissimus dorsi flap, when you want little more tissue. So this is how it will look like if at all you have done a latissimus dorsi flap and you need large amount of tissue, more than 50%, then you can mobilize the latissimus dorsi muscle with the skin and then do the reconstruction. And there can be variations of the latissimus dorsi flap which are called as the mini LD flap or the muscle sparing latissimus dorsi flap. All of them give you good cosmesis. And this is another thing, when the deficiency is not much, you can do something called as a free fat transfer. Fat can be taken from the abdomen and then can be used to basically replenish the lost hollowed out part of the breast. Now coming to the perforator flaps, as I said, there are many perforator flaps. This is the LICAP flap, this is the ICAP flap. So different perforator flaps are there by which you can do good reconstruction to the patients. As I said, if the defect is in the lateral quadrants, you can use a LICAP flap. If it's in the medial quadrant, you can use a ICAP flap. And all quadrants, excluding the medial quadrant, you can use a TDAP flap. Internal mammary perforator flap is one of the flaps which can be used for the upper inner quadrant, which is considered as a quadrant which is not very surgeon friendly. So this can be filled up by using an internal mammary artery perforator flap. Like if a tumor is here, then this is the area where it will be difficult to fill it up. So you have to base it on the internal mammary artery perforator flap. Now, you can also use implants. You can also use implants. This is called as a prepectoral implant. And this can be used, which is used with something called as a Braxton implant. And this is a prepectoral implant with the latissimus dorsi flap. And this is one of the patients with a reduction, with a inferior pedicle flap. So it has been shown very clearly in literature that oncoplastic surgery is safe. The awareness about breast cancer is not there. So also is the awareness of oncoplasty. So it is all up to all of us surgeons to increase the awareness among patients and doctors about oncoplasty. So I conclude by saying that oncoplasty forms an important part of today's management of breast cancer, and it is possible to reconstruct every quadrant of the breast in every patient in an individualized fashion. Thank you.
Sitting next to me, let me invite Dr. Deepak Jha. It's another interesting topic, oncoplastic and oncosurgical safety. Where can we draw the line? So please draw the line. Thank you very much.
Very good morning to all, and many thanks for the organizers for this wonderful opportunity. Breast oncoplasty, as we can understand from the number of topics that have been given in this session, it's a very important topic and a very upcoming topic. And while the presentation gets loaded, I think maybe if you look at the wording of the topic given to me, where do we draw the line? A probable hint is where do we stop? So I might not be able to perform as per the expectation and might go in the absolute opposite direction. So we started with breast conservation surgery a few years back, game changer, no need to remove the whole breast, just do a little bit of WLE or contactomy and get an excellent result. But the problem was large amount of margin positive resections and very bad cosmetic results. And cosmesis is the most important aspect because bad cosmesis leads to a very poor social integration, low self-esteem, and the patient generally has got high dropouts. So that is why oncoplasty came into being, defined very early, but main first line to be drawn is here, that the first requirement of an oncoplastic surgery is that it must be absolutely safe. And aesthetic optimization is of secondary importance. I think often we tend to forget this part, that onco comes before plasty. So whenever you are planning an oncoplastic section, please do not forget that a margin positivity or a poor oncological outcome is never acceptable. Like sir has already said, we had level 1 and level 2 defined in 2010, but of late it becomes very difficult. How do you measure which is 20%? How do you measure which is 40%? So a better definition came into being was simply just divided into volume displacement or volume replacement. So if you have adequate breast tissue to cover up the defect, it's volume displacement. And if you need a flap, whether a free flap or a local perforator flap, it becomes volume replacement. Another new terminology is extreme oncoplasty, where even 2 or 3 breast surgeons would actually not consider the patient to for a candidate for breast conservation, but still you can find some way of using some flap with some integration with 2 or 3 flaps and be able to conserve the breast. So why the doubt? The doubt is because we believe in data, we believe in RCTs, and all the RCTs for breast conservation came for a very early tumor, essentially T1 and early T2 tumors. But in oncoplasty, we are always looking at larger T2, even T3 tumors. So that is why, pure scientifically speaking, we cannot extrapolate the same results of BCS RCTs to oncoplasty. And whatever studies we have are simply observational studies. So that is why I slight doubt in mind whether removing that much large volume of tumor and preservation of breast, is it safe? So when we are doing BCS, we get about 20 to 40% of involved margins. And all of these actually involved margins require a re-excision. Re-excision means invariable second surgery, delay in the adjuvant radiation, cosmetic results are often poor. So that is why oncoplasty comes into being. The whole USP of oncoplasty is we are able to remove huge amount of breast tissue, so automatically you get wider margins. There have been very less studies that have actually compared the margins, but we have about 8 studies that have made a direct comparison. The largest ones, like I'm showing them, they are about 1,000 patients each, and this is the De La Cruz study had about 5,000 patients of pooled studies. So overall rates of marginal positivity was 5.8 versus 8.3 and 10.8 versus 6% ratio. So it is all showing that even though these larger tumors, they can still be safely removed. So the next thing that comes, because the margin will automatically translate into local recurrence, and that is the outcome that we are looking at. But if we look at our studies, we are not seeing any isolated local breast recurrence. All of these cases usually have systemic recurrences, and isolated without even regional nodal recurrence or without systemic is very, very rare. Now, the expected rate was earlier said to be 1%, but I think it is falling even further down. Also, it is not the quality of surgery that impacts. TNBC breast cancer has got nearly double the rate of local recurrence as compared to a non-TNBC. The impact of systemic therapy, good radiation techniques have literally come down. The isolated rate have really come down. I have seen in the last 5 years only 2 isolated local recurrences. That too in a patient who absolutely demanded and was not a candidate for BCS. But whenever we see all these studies, all of these studies which are comparing the control group of BCS versus oncoplasty, the oncoplasty group invariably has worse tumors. The grade is higher, the nodal involvement is higher, the hormone expression is lower, and majority of the tumors are more closer to T3 or even T3 as compared to T2. And even then, your local recurrence rate and the overall survival is still comparable or even better in oncoplasty. So, like I said, RCTs we are never going to have, but whatever studies we have showing 2 years, 5 years, and 3 years local survival and overall survival, they have all shown good results and comparable with BCS. Even though, like I said, they had younger patients, larger tumors, poor grade, LBI, multivocality, LBI, and advanced stage. Even after all of these characteristics, oncoplastic breast surgery has performed very, very well. So, next important aspect is, because we are doing a much bigger surgery, our incisions are much bigger, we have flaps. So are we delaying the adjuvant therapy? So that again, the risk of post-op complication is definitely higher in oncoplasty. We have about 14% post-op complications that can be fight necrosis, delayed skin healing, seroma, or hematoma. But all of them have never delayed the RT. So even though the complication is slightly higher, but then it has not impeded your adjuvant therapies. Now, cosmetic outcome is the most important aspect of oncoplasty, because that is where it literally stands out from breast conservation surgery. So in all the systemic reviews, like I'm showing, your patient acceptance of oncoplasty is very, very high. The results are only 4.4% of patients have a poor acceptance, and even in cross studies at 2-year interval, which is the actual interval where we should assess the cosmetic, because by the time the effects of RT have completely resolved, 82% of patients were favorable for the cosmetic results they've got. Now, let's go back as to why and what kind of results that we get. So I'll just go through a few examples of what oncoplastic breast surgery can do. So this is a simple omega or a battering, and it is very useful for all tumors in your upper quadrants where you don't need volume replacement, and you get very wonderful small scar which is close to perioral, and in about 6 months' time, this scar is not visible even to the patient. For these patients, or if probably a good idea to do is in about patients who are 45 to 50 years of age. If you have even younger patient in her 20s, you can easily go for this round block technique, and this kind of scar virtually goes away in about 1 year's time. And I had a patient a week back where even I was struggling to find where the scar was. For central tumors, which is again very difficult tumors, we have this is a typical Grasotti flap where you remove the central NAC complex, and this panel of skin is used to reconstruct the nipple area. This is a option of a Limburg flap where we have removed a tumor which was around 12 o'clock and along with Pagets, and we have used a very small sliver of areolar tissue to remake the nipple, and this central area will get tattooing to the NAC back. This is your post-op results of this NAC, and another option is a simple rotation flap to cover up the central tumor. Now, when we talk about mammoplasties, this again a patient, 55-year-old, very large breast, a very small tumor around in 12 o'clock position for about 1.5 centimeters. So we did inferior pedicle mammoplasty. We removed all of this area, and the patient underwent a synchronization procedure as well. So very excellent results, and the patient was also relieved of the large breast size. Now, this is the options of light cap flap. This flap is based upon perforatus from the lateral intercostal vessels that come out in the 5th and 6th intercostal space. You can design this flap as per your need. It can be a horizontal flap, it can be a lazy S to reach up to nearly midline the breast meridian, and even better, you can raise it as a crescentic flap to fill up the defects. You can use it for nipple construction, you can use it for putting up the skin pedal where the volume loss of parenchyma is very less. So very, very, very nice one versatile flap. And this is the kind of post-op results that you get where from the front view or even from the lateral view, the scar is completely hidden and the patient's acceptance is very, very high. Another option is LICAP or MICAP, because these tumors, especially in the lower half of the breast, are very difficult and they lead to a pelvic deformity. So this is your MICAP flap and a very small perforator here on which this whole flap is raised. Just one, and this is an example of extreme oncoplasty, a very large phalanx, and this is a post-op result after a year. So not everything is easy. You have to be very, very sure what kind of surgery is required. You have to be very sure what is the patient's expectations. If the patient does not want a breast conservation, it is not, there is no shame in offering or doing a mastectomy even right now. You can have bad results. For example, this patient where the tumor volume was less, flap volume was more, so you can see there's a fullness in the upper pole. This patient where we got too confident and we closed the entire flap before we got the frozen, the skin was positive, so we had to again remove a good chunk of skin, and you can see that the breast is deviated laterally. And again, this patient, a redo phylloids, where we did not want to enter the axilla and do an LTAP, so we had to depend upon a LICAP, and you can see a depression that has formed superiorly, for which we had to do again a reshaping. So all is not good, all is not very easy. You have to be very, very sure what are the patient factors, the size of the tumor, location of the tumors, before you actually finally plan what is your plan going to be, because often there is not going to be any fallback options. So just to conclude, I'll probably give a new line to draw that every breast surgery is an oncoplasty, and this is going to be our starting point. Thank you.
Really a nice presentation. I compliment you, Professor Dr. Deepak Jha. I'd like to invite Dr. Naval Bansal for his presentation, Robotic MRL, a video presentation.
Thank you, organizer, for giving me this opportunity. Like Professor Sinu has said, that it should be decision making between the patient as well as between the surgeon. What it's just a technique, you can follow any technique. And probably this is the third presentation this month, because whenever there is a new technology, there is a lot of curiosity, especially among colleagues as well as junior students. So what exactly the robot means in breast surgery? So again, what I usually tell in my presentation, it's just a technique. Not every patient, not all patients are candidate for robotic breast surgery. I'll say you must know that there is a technique, and you should choose your patient appropriately. Choosing all patients for this technology may not be appropriate. So this was a conventional nipple sparing mastectomy which we were doing earlier. There are multiple of way of doing. You can go from a lateral mammary crease, you can go from a inframammary crease, or you can give a radial incision. So there are many options of doing conventional nipple sparing mastectomy. Then comes a robotic nipple sparing mastectomy. So there is a lot of I'll say curiosity going around about not only robotic, around the minimal invasive breast surgery. It includes endoscopic as well as breast surgery. So if I talk about the robotic breast surgery, how it's beneficial, definitely it gives a better aesthetic outcome. The complication rates, especially when it comes to the nipple necrosis, is lesser. But however, there is a long learning curve. The time consuming, that time taken for a surgery is long. There is a financial implication when we are using a newer technology. So, what all patients we can choose for a robotic, or I'll say any sort of nipple sparing mastectomy. We can do a prophylactic nipple sparing mastectomy for a patient who have a BRCA1 or 2 mutation positivity, or we can offer nipple sparing mastectomy, especially in a post NSCT patient or multicentric patient, in which the tumor to skin distance is, I say, more than 1 centimeter. Too close to skin are not candidate for any sort of nipple sparing mastectomy. So coming to my presentation, so we have a XI Da Vinci robotic system in our place, and I usually, there are multiple ways of doing. You can do with a gasless technique or with gas technique. I usually do with a gas technique, and this is a gel port, and the instrument, like I mentioned, it's a Da Vinci XI system. So this is how the gel port looks like, because this is not a very common available and not seen majority of the students. So it comes with a sleeve. Sorry. Sorry. So it has many components to it. So there is a sleeve, and this is a gel port, and it comes with a disposable trocars. So one end of sleeve goes inside and one stays outside, because there is no natural cavity. You cannot actually hold the gas inside. So this actually creates a entire closed system for the gas, for the pressure to build in. So coming to the technique. So this patient, has a multicentric CA breast. She is triple negative lady. She has undergone neoadjuvant chemotherapy, and she has shown complete clinical response. So this lady has undergone nipple sparing mastectomy. So this is how the position of the patient looks like. It's important to mark the boundaries, because once the entire breast goes up with the gas, the entire boundaries get lost. Actually, we cannot make out whether it is a medial margin or whether it is a lateral end of this thing. Second comes the marking. Usually, I go from a lateral mammary fold. I usually make 4 to 6 centimeter of incision, And through this incision, I usually make the flap thickness. Because once we are inside the cavity, we cannot actually palpate. There is no tactile sensation. You have to rely on whatever you are seeing. So choosing the flap thickness is very, very important. Then third steps comes the hydrodissection. I usually inject adrenaline saline all around just to make plane slightly less avascular. Then comes important step is creating a tunnels. All these small steps looks very, very tiny, but all these steps actually makes a difference, because now we are sitting on a console. There is we cannot actually palpate the flap thickness. So it's important to do all these things, because like I mentioned, the tunneling initially helps us in guiding which planes to follow. So this is how the assembly looks like. I usually use monopolar as well as bipolar. One is camera port and third is the assistant port. So this is the assembly looks like. You can start from a lower flap or upper flap. It's again the surgeon preference. There is no hard fast rule. So this is flap raising, just like a standard mastectomy like we usually do. You need to be in appropriate plane. So how you usually decide that you are going in a right plane or wrong plane? Again, first, whatever the tunneling you have done, you can see. There is no this thing. So the tunnel actually guides you. Then comes the ductal system. You can see this is the ducts that I am cutting close to duct. In earlier frame, you have seen the blue dye. That was the boundary of the upper flap. So again, you can see there is a lot of magnification. You can actually very well visualize the ductal system. So once I cut the ductal system, I usually enter the middle aspect. So again, I am dissecting the middle edge of the skin boundaries. You can see the appearance from outside. Again, your assistant should be very, very thorough, because the surgeon has no, I'll say, tactile sensation. Your assistant usually guides you whether the flap thickness is good or not. From the earlier, you can see there is a uniform lightning you can see through the flap which is coming out. Once I raise my end superior, inferior, and I mobilize from the middle end, again the last step is just to lift the breast probably from the muscle. Probably this is the most easiest part, because there is we are not scared of cutting anything, because once we are raising the flap vascularity should be very good. I think so. Entire dissection has been dissected. Entire specimen has been dissected out. Just a final bit which is remaining near the needle pole. Probably this is a perforator on the middle end. So bipolar actually helps us in retracting as well as coagulating at the same time. It's just like a simple mastectomy to my younger students who are here in the hall. Again, to re-emphasize, this is just a one technology. It doesn't says if you don't know robotic breast surgery, you are not a good breast surgeon. It's just one of the technology. Choosing appropriate technique, whatever is suitable for your patient, should be the goal, not just doing a fancy stuff. So, so this is entire mastectomy has been done. I usually do, if the sentinel or axillary dissection has to be done, to the same incision that I have made earlier. So this is a ICG, just to checking the flap vascularity. You can see there is a green coloration which says that the flap vascularity is good. So the entire breast has been dissected out. Around 650 grams of breast tissue has been taken out. The flat breast. So this is how exactly the nipple sparing mastectomy should look like. There should not be much of the breast tissue which should be remaining behind. Again, there are multiple ways of doing reconstruction. You can put a flap, you can do implant with ADM or many things. I usually put implants just below the skin flap. So this is how I usually do it. Thank you all, and any questions are welcome.
Thank you very much. Thank you very much, Dr. Naval. Are there any questions from the August gathering here? We're having 1, 2, 3, 4, 5, 6 speakers. Anyone can have any question to any speaker. All are here. We can have some interaction.
Sir, I have a question to Professor Sharma.
Yes.
Sir, suppose this is a very, very important aspect as a clinician. If you are having a T2, probably hormone receptor positive early breast cancer, which is a good biology, are you going for a this fast forward whole breast radiation, or you are planning for a partial breast radiation? So how you usually choose whether to go for a partial breast radiation or a whole breast radiation?
A good question. If it is T2 tumor, but size is less than 3 centimeter, nodes negative, and if the margins are negative, I will go for the partial breast. If the tumor is more than 3 centimeter, some patients are even up to 3.5 centimeter, 4 centimeter, I will still go with partial breast. Because if you see the recurrence pattern, even though there is a higher risk of recurrence in these patients who are margin positive and large size tumors, but this will still recur in that danger zone, not the actual breast, So up to 3.5, 4 centimeter, I will go with the
Sir, any
partial
advantage
breast.
of doing this partial breast radiation
Yes.
over the fast forward trial? Because
Yes.
at the time consuming is, I think, so 5 to 6 days only.
No, but this is if you're doing with the surgery, you're using the surgical time, because this is the time when patient is there in the surgical ward, or it's using that your time, So during that time, we can finish the entire brachytherapy treatment or the partial breast treatment, and patient goes home with surgery complete, radiation complete. This is one advantage, cost effective also. And third thing, the best advantage I think is that all the other techniques like fast forward, they will use the extreme techniques. So extreme techniques are its own inherent problem, because if the patient is lying down with the machine couch, during breathing or sneezing, the patient might move, then the breast tumor area might also move, because it's a small area you are treating, So if you miss the target with the breathing movements and the other movements, then you can miss the target completely. The other problem that you can, in some time, by all these motion artifacts, you can include the underlying lung, which is very close for especially deep tumors. You just have ribs, and then below that you have the lung or the heart, So these, dose to these organs have a long-term impact. They will not be visible or, manifest within like 1 or 2 months. After years, you will see the effect of the radiation to the endoid, the lung, and to the heart. So I would say this is one request to all the entire surgical community, that if the patient is fitting into the criteria, please compile your radiation oncologist to practice the partial breast rather than the whole breast.
Thank you, sir. Thank you.
Please, thank you, Deepak. Yeah, thank you. It was pleasure working with you at AIMS. Please.
So, what are the challenges you face while integration brachy?
Please introduce yourself, please.
So, Dr. Deepak Jha, what are the challenges that you face while integration of brachytherapy with all this oncoplastic and the volume replacement flaps that we have?
A very good question, because somebody who is doing the oncoplasty will have this question in mind. And I work these surgeons at AIMS Delhi, and most of them are doing oncoplasty. I think so nowadays it's more or less a trend to do oncoplasty. This has been a concern that if you give radiation by brachy or any other technique, then there is a healing concern, and it might affect the cosmesis and it might delay the further treatment as well. Especially brachytherapy, since you are integrating with the surgical time, like around 2-3 days after the surgery, starting the radiation, which might hamper the healing and it might delay the wound healing and everything, But often I've seen in my practice that for type 1 oncoplastic, it's not a problem. In fact, we have done a research, we have presented a paper in the ABS Miami conference, that for type 1 oncoplastic, where the mobilization has not been much, there you can safely practice the partial breast with the brachytherapy. And nowadays, with the help of the computer technology, when we insert the catheters later on, like second or third day, we do the CT scan. Every patient will have to undergo a CT scan for that planning dosimetry. And you can very precisely measure what dose is being delivered to the part which is operated, adjoining muscles, the overlying skin, underlying the lung and everything. So you can know how much dose is being delivered to the scar also. And accordingly, you can titrate the dose. So that way, if you know the dose being delivered to the scar, and if you start the treatment like 2 or 3 days after that, then it is fine, it's not a problem. Yes, type 2 oncoplasty might cause some problems because the mobilization of tissues has been like much more than type 1. But selectively, even for type 2, I don't mind, because the advantages of the partial breast are manifold. So, but these are some problems which the surgeon has to understand, and we have to also understand that not every patient has to be taken for partial breast. If the cavity distortion, the area distortion has been much, and it is not really identified that what area we need to treat, then of course we have to do the treatment after like 4 weeks from the treatment as a whole breast or like whole breast plus breast. But these are some of the real challenges. But once you do, these techniques together in a combined way with the surgeons and brachytherapists together, you will overcome all these nuances. But the idea is just to start these, practices to do oncoplasty and brachytherapy together. And maybe it's an area of concern because I've done some 40 patients also, and only 2 patients had some problem of the delayed healing and all that. But it's a good thing to think that can we combine oncoplasty and the brachytherapy together? Thank you.
Thank you. Thank you, Dr.
Thank you for generating interest in brachytherapy and the medicine for breast cancer. Really
Thank you, Dr. Sharma, for wonderful explanation and detailing. I have a question for Dr. Deepak. In one of the slides, you displayed the bat wing diagram. The tumor was quite higher up.
Yeah.
So up to what distance you consider for bat wing?
No distance. It is my consideration for bat wing is the age of the patient. If the age is 45, 50, I go for bat wing because bat wing kind of gives me a good access. The distance is not an issue. For example, when we are doing a nipple sparing mastectomy and we are giving an inframammary incision, so we are going all the way right up to the upper pole from that inframammary. So distance is not an issue. Main issue is cosmesis.
Technically speaking, bat wing is described for up to 4 centimeters away from neck. Other procedures are there for managing the rest.
So procedure choice, again, we never have like for this particular thing, you can only do this. As long as you are able to remove the tumor properly and give a good cosmetic effect, it's all right. Bat wing, what it does is because of the lateral veins, it gives you a very good access and gives you a very big area that you can raise a larger flap and you can easily close that defect by mobilizing large amount of glandular tissues.
In that diagram, you go through the subcutaneous plane and reach the tumor.
Yeah.
And in case the skin is very close?
Like I said, if you are doing a lot of NSMs, nipple sparing mastectomy, from there you are going from one end to the other end and raising the entire skin flap. So it is more like an extension of that. You have to obviously be a little bit careful as to what is the thickness of the flap that you are taking, but it is a very safe surgery. 4 centimeters, 6 centimeters, 8 centimeters doesn't make any difference. We can do a round block if we are cosmesis, we can do the same thing, but then access becomes very limited.
Thank you, Dr. Likubcha. It was a nice session on breast surgery, which has covered from benign to advanced oncoplastic technique to changing trends in breast surgery to robotics. So I must congratulate Dr. Naval for presenting a wonderful video on robotic MRM. But my question is, do we get any oncological clearance in case of lymph node yield? Dr. Naval, please.
Ma'am, I usually do axillary staging, whether it's a sentinel node biopsy or axillary clearance, through open technique itself, through the incision that I've made in the lateral mammary fold. I've not done axillary staging, be it through robotic, because I don't find any advantage. We can do it, but I have not done it.
Okay. So the disease is changing, trends are changing, but most of the thing we are learning that these are the most technological driven procedures.
Definitely.
Because already MRM has already proved that it has got an oncological benefit. Definitely. Ma'am, another question to Dr. Professor Madhumita. Ma'am, you presented on granulomatous mastitis. When you go for the core biopsy, because most of the time these patients, they present with the differential diagnosis of malignancy. So when you will advise that patient has to go for the core biopsy, because in your slides you have shown that you can go for directly the rifampicin treatment. So when you will advise for core biopsy, because patient must be apprehensive, you have to rule out the diagnosis also.
See, initially, whenever these patients present to us, other than the age factor, it almost mimics a breast carcinoma. So initially, we have to think of it like we have to rule out malignancy. Just as a triple assessment we rule out malignancy. So core biopsy is to rule out malignancy and prove it's a case of IgM. That's it.
after giving your therapy, after how long you are going to advise surgery if this lump is not regressing? Because we have seen so many patients, initially they respond to this prednisolone, but after a few weeks or months time, the lump is not regressing and the patient is apprehensive about that. So when you will advise surgery in those cases?
Those which are for tuberculosis, after 6 months of antibolus therapy, residual lump, you go for surgery. For IgM, that is the point actually. Initially, that's the reason we shifted to rifampicin, that usually we do not have any residual lump. But I would suggest, because since it's a benign condition, so if there is a residual lump, continue the therapy for a little more. Because in our study which we got, after 6 months of rifampicin, we did not get a single residual lump. Whereas in case of corticosteroids and all these things, there's a recurrence. So in corticosteroid therapy, usually what they do is, most of the time the victim is that they go for one cycle, relapse, second cycle. Even if relapses again after that, they think of surgery. A combination process. That's it.
Thank you. With the permission of the rest of the colleagues as chairpersons and the gathering here, I would like to have some closing remarks about these presentations. It has been the endeavor of all the surgeons, oncologists, radiologists, radiotherapists, and other people to have a good screening method, to have a better diagnostic workup, and then manage these patients nowadays, to have the aesthetics also into mind. And endeavor is always to have the best outcome of these breast cancer patients. Thank you very much. Thank you all.
I thank all our esteemed speakers for such enlightening sessions.
May I now request Professor Dr. Anita Dhar ma'am to felicitate Professor Dr. Madhumita Mukhopadhyay ma'am. May I request Professor Dr. Ratnakar Sharma sir to kindly felicitate Professor Dr. Divya Daiya ma'am. May I request Professor Dr. Ejaz Ahmad Malik sir to kindly felicitate Professor Dr. D.N. Sharma sir.
Professor Dr. Sanjay Dhar sir to felicitate Dr. Deepak Jha sir. I would now request Professor Dr. Sanjay Dhar sir to felicitate Dr. Deepak Jha. I would now request Dr. Ratni Madhav ma'am to felicitate Professor Dr. V. Seenu. I would again request Dr. Anita Dhar ma'am to felicitate Dr. Naval Bansal sir. I would now invite Professor Dr. Nisar Chaudhary sir Founder Chairman Jakasicon to felicitate our chairpersons. I request all the chairpersons to come in front. Professor Dr. Anita Dharman. Professor Dr. Anita Dharman. Dr. Rajni Bhardwaj ma'am. Professor Dr. Sanjay Bhai sir. Professor Dr. Ratnakar Sharma sir. Professor Dr. Ajaz Ahmed Malik sir.
We now move on to one of the most engaging segments of our program, the panel discussion. It's my privilege to invite our distinguished panelists of the session, Professor Dr. V. Seenu sir. Sir is Director Cancer Care, Breast and Endocrine Surgery, Medanta, Noida. Professor Dr. Madhumita Mukhopadhyay ma'am. Ma'am is Professor and Head, Department of General Surgery, Diamond Harbour Medical College, Kolkata. Professor Dr. Piyush Ranjan sir. Sir is Professor, Department of Surgical Disciplines, AIMS Delhi. Professor Dr. Shabab Lalit Angurana sir. Sir is Dean Research, Professor and Head, Department of Radiotherapy, AIMS Jammu. Dr. Naval Bansal sir. Sir is Senior Consultant, Breast and Endocrine Surgery, Fortis Mohali.
I now invite our esteemed moderator for the session, Dr. Paras Khanna sir. Sir is Assistant Professor, Department of Surgical Oncology, AIMS Jammu. I request sir to kindly moderate this session.
A very warm good morning to everybody. It's indeed a privilege to be here interacting with all of you. I have the unique privilege of having my friends here, of having my teachers here, and of having surgeons here in Jammu who I've worked with in the past close to a decade. Before we begin, actually, just a small WhatsApp chat I have had with one of the panelists. मतलब हमने ये panel game नहीं किया है, but this is a WhatsApp chat between me and one of the panelists in 2024. So we were in Shimla, and while coming back, Naval had a lot of wisdom to share with me. कि बॉस और 5-7 साल में लगता नहीं है कि बहुत ज़्यादा breast surgery हम करेंगे. And I kind of agreed with him. And we have literally had a bombardment of data asking the surgeons to literally step back. But I think as a surgical oncologist, we have a very unique perspective. We have the privilege to look at the disease first and not at the knife first. And with this thing in mind, let us now proceed. It's a privilege to meet Professor Seenu. So I've heard a lot about you. I've trained at AIMS. Never had the privilege really to meet you. Indeed an honor. Professor Madhumita, ma'am, it's good to know people coming in Jammu from all parts of the country and would love to share your input. Professor Shabab, he's been an associate close to a decade now at AIMS. So good to have you here. Professor Ranjan, good to have you here from AIMS, and my dear friend Naval. So let's proceed. Can I have a presentation, please? So somehow we always have that thing in the back of the mind that the more we use a knife, the more we are going to impact the quality of life. And
For the last more than 3 decades, a very big question mark on axilla has been really being the quality of life issues which arise from surgery. But is that the only parameter with which we should look at axilla and its management? So, in close to 3 decades, we have moved from the Halstedian concepts of a mutilating axillary dissection to a dissection which focuses only on level 1 and 2, moving to the sentinel, then removing only the clipped node in a patient who has preoperatively or pre-chemotherapy, the node has been marked with a marker, targeted axillary surgeries, and now we are discussing, do we really need to operate on the axilla? The data has been in front of us for like more than 50 years now. In fact, it was in the 1977, before I was born. So this is really a good thing to import when we think. 50 years ago, Fisher said that mastectomy is not superior to a conservative surgery. This is something which we should really go back and think, especially for my general surgery colleagues here, the younger PGs who are attending this session. A mastectomy is not essentially superior to a conservative breast surgery. This question was answered more than half a century ago. And we have a 30-year data which has taken us from the classical EBCTCG meta-analysis, which talked about preventing local recurrence to add to survival. And then at the turn of the century, we had the landmark ECOSOC Zoo 11 study, which talked about whether we really need to supplement axillary dissection after a good sentinel procedure. Just a few slides. I have to go back. Sorry for this lag. But anyways, if we just focus on the last part of the conclusion, this is Fisher talking about his study in 2002. So we're getting a good temporal play of the data, and he says that the findings fail to show a significant survival advantage from removing occult positive nodes at the time of initial surgery. So even in 2002, from a data which was collected and concluded in 1977, there was this argument that are we really doing the best for our patients by doing an axillary dissection? The meta-analysis, the classical meta-analysis by the EBCTCG group talked about preventing local recurrences to add to overall survival. So that classical dictum we had that आपको 4 recurrence save करने हैं एक 15 साल पे survivor को achieve करने के लिए. This was what we were taught when we walked into our trainings. And this data again has stood test of time. But it was challenged for the first time at the turn of the century when in 2011 this publication came out that in a select group of patients, is it mandatory to do an axillary dissection when the sentinel biopsy is positive? Mind you, this data came after close to a decade of sentinel happening, not only in breast, but in lot other solid malignancies, let us say penis and other groin malignancies. But specifically for the case of breast, this data came after close to a decade's worth of work. The randomization proved that the local recurrence rate was not significantly different in the group which was observed even after sentinel positivity. But the key aspect of these studies were the false negative rates. How do we get over the false negative rates? And then there was the maturing of the radiation data. And that is why, sir, I would want you to bear in with your opinion, especially the Amaros, the Otosar, and the Synodar, and other trials, which talked about how the advancement in axillary radiation or advancement in radiation per se was affecting axillary treatment and was challenging the alpha position of surgery when it came to surgical staging of the axilla. A crowded slide, but what I want everybody to focus here is that in the primary endpoint, which was either the overall survival or the axillary recurrence, there was no difference. These landmark studies were basically focusing on a select group of patients who had smaller tumors, were clinically node negative, but then they were achieving comparable results and with good median follow-up too.
As this discussion progressed, as the data was accumulated, the question arose: can we go about omitting SLNB altogether? And here we have trials which are running in the continental Europe, or in Nautilus trial which is going on in Korea, which is focusing on using just an ultrasound to categorize the axilla as CN0 or CN plus, and then taking the management forward. We have the intergroup trial, the huge Dutch trial, which took in a lot many patients, and then the Sinovac trial, which challenged whether variability in interventions, limited representation of high-risk groups, and certain statistical considerations. These are the question marks raised on these trials. Are they of sufficient weight for us to question as oncologists that, okay, axillary dissection still needs to be supplemented in a case of positive SLNB? So before we move to the panel discussion and the questions, I had this interesting study to share. This study talks about the fact that where is the metastasis, where is the systemic metastasis? I think Naval pointed out, Deepak also pointed out, that the challenge in breast is the systemic recurrence. So where is this recurrence coming from? Is it coming from the primary tumor, or is it actually coming from the lymph node? And do we have this continuity that tumors which metastasize primarily from the tumor behave differently from tumors which metastasize from the node? Do we really have a study? Thankfully, this study of 16 patients of receptor positive breast cancer evaluated precisely that, with a detailed genomic signature, that where is the metastasis coming from? Is it coming from the primary tumor through a hematogenous route, or is it coming through the lymph node? Is it a direct spread from the lymph node? And there were some amazing findings. Despite the fact that we would normally expect a larger tumor to give rise to a metastasis systemically, which is a normal course of event. In the course of direct spread from the lymph node, the tumors were low grade. Despite being low grade, they showed a tendency to spread. So 25% of the cases were through the lymph node, 75% was from the primary tumor. And these 25% of cases were of low grade nature, but they performed poorly. So a patient whose metastasis is coming from the lymph node will perform poorly when compared to a patient whose metastasis is coming from the primary tumor breast. So this also raises a question. When we question axillary dissection, should the only parameter be quality of life? Or are we really missing categorizing our patients when it comes to choosing systemic therapy? Another aspect which I would like to touch in our discussion is, ma'am, what happens if the proportion of lymph nodes is very high, like 1 out of 1 or 2 out of 2 sentinel are positive, as against 1 out of 3 or 2 out of 3? Is it the same? Should we categorize all these as sentinel node positive, or should we really bring a tier, separate them, that 1 out of 3 is absolutely different from 2 out of 2? And what bearing does it have on the choice of systemic treatment for us? Majority of our practice is shifting on account of TNBC and HER2 positive to a neoadjuvant profile. So majority of our practice is our patients are going to receive neoadjuvant chemotherapy, and a good percentage of them will become axillary node negative. We have high quality data now arguing that, okay, these patients should also be offered only sentinel. And we are already discussing ahead of them. This data has been matured for more than 3-4 years now. And we're talking that if we can decrease the false negative rate by specific techniques, which are, luckily we have a lot of surgeons on the group, I think 4 surgeons and 1 radiation oncologist. So we can take a viewpoint on how our surgical techniques is helping us avoid the false negative rate. And this is how we are going to de-escalate, not just surgery in the axilla, but how do we de-escalate treatment of the axilla? What role is radiotherapy playing? What role is modern imaging playing? And what role is the upcoming molecular diagnosis and liquid biopsies? How is it going to impact our management of our patients? So now I would like the panel to enlighten us step by step on why SLNB. Madhumita ma'am, if you would take that question, that what has been your perspective on how SLNB has come about? So why SLNB?
See, from the initial, the historical point of view, it was that SLNB is the first node. So if that is positive, it's the theory was on whether it goes stage by stage. The first node first, and then it goes to the others, right? So from that, from the recent studies and from what people are doing right now, see, I come from a hospital where we do not have facilities for a lot of kind of this targeted axillary dissection. We don't have those facilities. But definitely in West Bengal and Kolkata, where you do have facilities, what they right now the thing is that if the patient was clinically N0 after NSAT, if do an SLNB, if positive, go for axillary dissection. If not positive, do not do it. That was the term. And for those who are initially node positive, but clinically node positive, for those patients, they said that the FNR, when they compared it, they found that the FNR was too high, around 12%. So they said that at that point of time, you cannot do SLB and just stop at that. So that is the thing we still followed. I'm telling of my state. That's it.
Ma'am, in fact, in your answer, you kind of encompassed the entire presentation. But Sinu sir, sorry, what has been your perspective? How have you seen SLNB come into our surgical practice? How have you seen it evolve? I trained in 2009 at AIIMS. That was a time when we were just moving in from general surgery. We were doing a lot of axillary dissection. और हमें तो ये सिखाया जाता था कि आपने वेन के नीचे और दोनों पेडिकल्स के बीच में सब कुछ साफ करना है और उसके बाद लिम्फेडिमा बाद में देखेंगे जब होगा obviously, but that is where we started to mature. That is where we were taught that this is not what you're supposed to do. Sir, I would like you to please briefly encompass how you have seen SLNB come into your surgical practice for the betterment.
Yeah. See, basically, I had the opportunity to work with Professor Giuliano way back in 1999. So that was a time when actually we had designed the Z11 trial. So at that time, the sentinel node which was done was by only a single dye technique, and Giuliano used to do by blue dye technique with which I was trained, and whereas Craig and Alex, they used to use the radio tracer technique. So it started
as
that
a complementary. Were the radio tracer being used with the methylene blue or separately?
No. Initially, when it started, Alex and Craig at another center, they were using radio tracer, whereas Giuliano's group, where actually Don Norton is the person who has started sentinel node biopsy for melanomas. And how it started is very interesting actually. John Wayne Cancer Institute is a center for melanoma referral in whole of America. So they used to see some melanomas which are there even at the umbilicus. Once there is melanoma at the umbilicus, we know that umbilicus drains into both groins and both axillae. So if they had to do a prophylactic lymph node dissection, they had to do 4 prophylactic lymph node dissections, which had a lot of morbidity. So that's how Dr. Morton tried to see where the lymphatics go. So initially injected the charcoal. And then he found that out of this, it was going only into one of the group of lymph nodes. And then he started using all dyes, including methylene blue. But at that time, they found that isosulfan blue is the best dye to be used because the molecular size of the isosulfan blue was bigger than that of the methylene blue, and bigger particles are taken up by lymphatics. So that's how the sentinel node started. That's why the John Wayne was very strong in using methylene blue, isosulfan blue as the. But once sentinel node started, there was so much of the isosulfan blue went out of stock. So many sentinel nodes were being done. Then people started looking at patent blue violet and then methylene blue, which in a randomized control trial, we showed that it is as good. So it started with single dye technique. And it was basically that, at least in the blue dye, identifying the blue lymphatic was very important, which we traced it to the blue node. But then other centers came up and said, why can't we use both together? And Alex and Craig started using even blue dye from then onwards, whereas Dr. Giuliano till 2004 or 5 was just using blue dye. So this is how it started. So in the same time in the Europe, they started using the patent blue violet.
Sir, as you pointed out, this aspect where the dye was combined with the tracer and a dual dye or a dual method was envisioned. Did it come about because there was a higher false negative rate?
See, whenever you try to stretch something which has been adopted or identified to be used for one particular thing. When you try to stretch it and use it in another situation, then naturally you find that there is a deficiency, so you try to do that. And after that, in England, they started saying not only blue or hot, and even a palpable node they added.
Yeah.
So the current definition of sentinel node is a blue, hot and blue, or a palpable node. So yes, what you said is right. And this false negative rate of 10% has come from nowhere. Where has it come from? Because the standard dissection which is done for modified radical mastectomy was level 1, level 2 clearance. So the level 1, level 2 clearance has a false negative rate of 10%. So that has been taken as the gold standard. So whenever you talk of sentinel node false negative rate, you compare it with that 10%.
Absolutely, sir.
So all of this, as you said, like it has been done just to refine the technique and reduce the false negative.
Not only that, for oncological equipoise, we need to demonstrate that we have at least matched the standard. And that is how this 10% came about.
But in the bargain, if you do too much dissection, remove 8 nodes, and then say that lymphedema rate of sentinel node is as much as that of axillary lymph node dissection, well, that calls into question the discussion. No, like I should not dig around and see. Sentinel node was a very elegant concept. Just see the blue dye, tract, going to the blue dye, or put it hot node, remove it, go back. Anything more than 10%. But since like you started, you don't want to have a more false negative rate, so you try to feel, you remove more tissue around it. So that's why in the later the studies, the lymphedema rate in sentinel node and ALND has almost been found to be similar. Actually.
So we'll stick with this point of yours. We'll go to Professor Ranjan. So as Sibu sir pointed out, that when we tend to be aggressive or we don't want to create or have a high false negative rate, हमारा axillary clearance 5, 6, 7, 8 नोड तक पहुंच सकता है. So what is your take on this? The drawback, as sir pointed out, is lymphedema. But is there something else also when we talk about oncological equipoise? When we try to take out extra nodes, is there something else we want to achieve oncologically?
Actually, first I'll go back to sir, what sir was saying. So it's such an elegant procedure. Just follow the lymphatics, identify the node based on the tracer used or the isotope used, and then pick up the nodes. Right? In pre-chemo, we used to take out 2 nodes probably. In post-chemo, now they say dual tracer and 3 nodes. But if you go back to the earlier studies, the Almanac trial, they mentioned there is 5% chance of lymphedema with SLNB, proper SLNB. But if you increase the number of nodes to say 5 or more, the chance increases to more than 15%. So this is what you're saying. So first, we are targeting that limited number of nodes. Yes, we can avoid lymphedema, the major dictator for doing SLNBs. Yeah. Oncological, it has been shown that yes, you can stage the disease, but survival is not dependent on the clearance.
Before we move from quality of life issue from lymphedema to the final, the benchmark of survival, is there something in between? Does a higher number of sentinel node help us achieve something in terms of decision making for the patient?
Yes.
What would be those scenarios?
10, if you have taken 10 nodes, that means you've taken done an adequate dissection. But again, everything is not that simple. 10 nodes from where? Whether you have left a higher echelon node, which sometimes skip metastasis can occur. So all these things should be taken into account. And going back to some of the trials, actually, I am talking about those trials, it's no less than blasphemy because everyone is falling left and right.
Yeah.
So if you deep dive into those trials, the initial trials, they were looking at only micrometastasis. If there is macrometastasis, no trials were there earlier. Then Synodar, they considered macrometastasis as well.
ITC, isolated tumors.
Yeah. Then earlier trial, of course, the recruitment criteria of mastectomy was included, but 90% of the patients were undergoing BCS.
Yes.
Now in BCS, mandatorily you are giving radiotherapy. And in the 2 tangent, 1 tangent includes the lower third of the node.
I have to stop you there. You'll have to leave something for my radiotherapy colleague to come in.
All these data are fallacious, you know. You need to customize according to your need, your patients.
So if I can paraphrase what you're saying is that the initial idea for Sentinel was to pick up that one node, like Professor Madhumita pointed out, ये पहली node है जो वहाँ से drain हो रही है, pick it up and then you can start taking it micrometa, ITC है. That is how things evolve. Naval.
everything is molecular now. No decision we take, even from surgery point of view, it comes after we have molecularly subtyped the patient. Does that work in the Excel also?
Yes, I think what you are trying to ask, at least we need 4 nodes to decide whether we need to give a abemaciclib or not.
Excellent point.
So that's
Please
why
elaborate.
sometimes, like you were asking why we are taking out more nodes. I think so. When we start doing sentinel lymph node biopsy, the fear among majority of the surgeon who start doing sentinel lymph node biopsy that he doesn't want to miss any positive nodes. So that's the first fear. Definitely, as you become more mature, again you want to decrease the false negative rate, and at the same time definitely park meters whether you are going to give a ribociclib or a abemaciclib, again depends on the number of the lymph node that you have dissected out, because for abemaciclib 3 or more nodes are criteria. For ribo you can start with the 1 node positivity definitely. But again, what I feel about the sentinel lymph node biopsy to my colleagues, because we work in a not a ideal scenario, because when we see a patient we usually come across ultrasound reports which hardly mention about nodes, or they mention about nodes also, but they are not very specific that these nodes looks positive or negative.
How do you ensure, how do you take that decision that your patient's axilla is CN0?
Yes, that's very important aspect, because sometimes a patient walks into our clinic with the ultrasound reports which is from outside. You cannot say patient that this report looks bad. You have to make your decision based on that ultrasound itself, or you can go for a PET scan or whatever the protocol, institute protocol. So it's important to have a dedicated radiologist who actually says that this is actually N0, not N1. I just tell few days back, I operated one of my younger colleagues' mother. The ultrasound was done, and it hardly mentioned about nodes, and probably the nodal status was N0 disease. We did ultrasound, probably it was a low risk disease, ER positive, PR positive, probably the low grade tumor. So even the PET didn't pick up any lymphadenopathy. But when we went in, it was up to level 3, it was positive. So actually, calling N0 based on the imaging again takes lots of guts. You need to have a good radiologist who actually mentioned there is a loss of fatty hilum, the cortical thickness more than 3 mm. So very few radiologists are there actually who actually comment. And especially about post NSCT, like we talk about N1 disease, how we are sure that it's a N1, it's not N2, because how we can be sure that we are dealing with less than 3 node positivity, because majority of our patients are a higher disease burden. We actually cannot make out whether it's N1 or N2 to start with.
I get that point. Madhumita ma'am, at your place of practice in Kolkata, do you also rely just on the ultrasound, or do you go forward and get a PET study done, or maybe a PET fusion with an MRI to be categorically sure about the axilla? Do you go to that extent, like Naval is pointing out, that we have our own stumbling blocks with ultrasound and clinical examination when it comes to determining CN0 status?
See, if you think of Kolkata as such, there's a cost issue, there's an availability issue, but wherever it's available, they go for a PET, definitely.
And would it be a plain PET? But Naval pointed out that he is having trouble even with PET, pointing out a good disease burden. Would you go for a fusion study with a PET MR? Is that done at your center?
I don't think things are available in such a way over there, but definitely a normal PET.
Normal PET. Professor Sinu, what would be your take? How do we determine for sure that we're talking about CN0?
See, I feel that ultrasound is an adequate investigation, but as Naval has said that it is provided you're working with the same radiologist every day, and you go and see the pictures when the ultrasound is being done. Why I'm saying this is that lot of times, like nowadays with so many investigations available, the clinical examination is going into background. Like recently I had one patient, a palpable lymph node, ultrasound done, ultrasound guided definitely showed reactive lymphadenitis. And at surgery, that palpable node was the sentinel node and it was positive for metastasis. So what I'm trying to tell is that clinical examination is paramount. And if your mammogram says that the lesion is only 2 centimeters, but clinically you feel it is more than 2 centimeters, always go by the clinical hunch rather than go by the images, because images just tell you what it is. But as a surgeon, you know that that this could be malignancy. So I think ultrasound is enough, as Naval has said, coming back to this, but provided you see the ultrasound along with the radiologist.
Perfect. So we need an ultrasound, we need a radiologist who's invested in the case. And if I could just summarize these 3 findings, it is a surgeon or an oncologist, as it is a responsibility to be sure that our patient is clinically no negative axilla, and we should rely on our clinical and ultrasound findings. A single dye method is perfect, but we should be ready for surprises, as Naval pointed out, that with the best of investigations, if the patient is not fitting into that tight clinical definition of a low risk type, we can be surprised. Professor Shabab.
Another thing, sorry.
Yes, sir.
I read another patient, PET scan showing multiple mediastinal nodes and level 4 axillary node, very small tumor, ER positive, PR positive, no internal mammary node and no axillary node. So in this situation, again, you can't go by PET. By PET, if you go, then you have to do a transbronchial biopsy. Whereas it doesn't sound to logic.
In that situation, would you agree the kind of tubercular load that we have in our clinical practice? Would you not consider those nodes with a pinch of salt?
Yeah, tuberculosis is one thing, and this sort of mediastinal nodes, which are basically bilaterally symmetrical and all, there are other causes. Like my patient actually had sarcoidosis. So in such situation, you have to be very careful. Like clinical examination and clinical evaluation is paramount. That's what I want to tell all the youngsters. Don't just look at the image and say, okay, PET scan shows this. No, it could be reactive lymphadenitis, it could be tuberculosis, it could be lymphoma, it could be totally unrelated to the disease which you are treating.
I would like
just want to add something. So you're talking about a very early breast cancer, T1, T2, and 0. So is there any indication of doing a PET CT scan in these patients otherwise?
So would you, okay, I'll put this question, answer it in the question.
I will not
Let us say it is a HER2 positive or a TNBC patient. What would be your
it's as per the guidelines, it is not recommended to do a PET CT scan, even if it is a triple negative breast cancer or a HER2 positive breast cancer.
So for
type B.
Completely taken.
So what I'm
any
trying
of the
to tell you
surgeons want to differ with sir's opinion, pre-menopausal young patient, triple negative.
Paras, it's not my opinion. Sir, it's not my opinion, it's there in the guidelines.
No, sir, I'm saying, can there be a difference of opinion by the surgeons?
Yes, I totally differ to you what you are saying, sir. Right? Actually, it's a institutional practice. Wherever we go, this is a very hot topic, whether to go for a PET or not. I'll say why we are very strong opposition of getting a PET scan done. In 2B, there are 3%.
I am totally not against the PET.
In stage 2A, there is 3% of chances of a distant metastasis. That is the data. So sitting in a private sector, not in a private sector itself, inside a institution also, I have seen patients who have a metastasis with a T1 lesion. And how will you explain that patient?
Sorry, let's not talk about anecdotal instances.
Yes.
Sir's point is very clear.
So it's an institutional practice, sir. Usually in our institution, we go for a PET in all patients. But again, like you said, the guidelines are just to guide us. We need to individualize our approach, like Dr.
And for the sake of the presentation, I would like the discussion to focus on the fact that we are trying to determine just the nodal negativity of the axilla. The broader point which you are raising, sir, is correct. That let us follow the guideline when we are trying to stage the patient. But when we are trying to offer SLNB and going further to argue that we may not even need to do an axillary dissection after that, we need to be very sure that the axilla is negative. And then we talk about that very sure status. Fine. So where do we move from clinical examination, ultrasound? What is the next thing?
So you have a patient who is hormone positive, T1 and T2 clinically.
Luminal.
Luminal type A. Fine. C1, clinical T1 and T2. And you have a PET scan which is showing micrometastatic disease in the axilla. So what do you do?
Excellent point. That is what we would come into. So this patient on PET has a cortical thickening. And the ultrasoundologist is invested in with the patient with us. He says, boss, इसकी cortical thickening है, fatty hilum loss नहीं है, लेकिन PET के अंदर थोड़ा सा uptake आ रहा है, SUV value 2.1 है, और primary की value 7 है, 50% से कम है. क्या ये patient, Professor Sinu, आपकी नजर में, is this patient axilla negative, CN0 or CN plus? We are going to request ultrasound guided FNAC also.
Yeah, we do an ultrasound guided FNA in such situations.
Precisely the point. So that is, we are making every attempt to categorize a patient as axilla negative.
What I am trying to put here is that the guidelines clearly mention that PET is not indicated. The reason being the chances of false positivity. Just listen to me. So you have a clinically positive disease which is T1 and T2. The ultrasound is the best modality to find out whether there is a disease See, you're talking about the loss of fatty hilum. You're talking about the cortical thickness. Which investigation is going to give you a better fit? And see, it's not about you, it's not about me, it's not about a private institution, it's not about AIMS, it's not about any government hospital. Every patient is important and they have to be treated and respected the way the guidelines are mentioned for. This is what I'm trying to emphasize. We're trying to do an investigation which will not fetch you anything except for creating more of confusion and more of investigation than to come to whether it is disease or not. Like Dr. Senu said, he had a PET CT scan done in the patient and the media scan notes came out to be positive.
That is a problem we will continue to face with granulomatous
I fully agree
So,
with
and
you.
anecdotal, you cannot go for doing a PET CT scan for finding out an odd patient who comes up with an unusual presentation.
Sir, completely agreed. Completely agreed. Rather, I would vouch for the fact
If
that
you're considering, if you're
one-
considering a patient for a sentinel lymph node biopsy and you're doing so many investigations, you're just confusing yourself also, and you're confusing, and you will be taking,
my
decisions which are not going
perspective
to
on
be helping the patient.
Your point is very well taken, sir. I think this discussion has to move forward now. Ma'am, do you want to
Just
pitch in?
one thing, I totally agree with what you're saying, but the argument for this was that ultrasonography is definitely the best way, but that's operator dependent.
Yes.
That was one point which was.
Show you my PET CT scan reports, which are reported at PGI, which are reported at AIMS Delhi, which are reported at Medanta, which are reported at Rajiv Gandhi Cancer Hospital, Gangaram Hospital, Tata Memorial Hospital. Each interpretation is individualized. So that's why we say that if you want good doctors, there have to be good training, there have to be good, thorough knowledge sharing.
Sir,
so qualities, ma'am,
sir, I have to interject here
so
as a
it makes a
moderator, sir,
difference,
please. Esteemed panelists, please. I think had we had a nuclear medicine team here, they would have been so happy with somebody arguing for them and against them. But for the purpose of this discussion, let us just move forward, sir. I want your opinion specifically on what DN sir also touched in his presentation. Post SLNB RT, we have successfully done a post LNB. I'm sorry, I'll request for some more time if the organizers permit. Post LSB RT, whole breast radiation versus partial breast radiation. What is your take?
So, as part of your standard procedure, like in sentinel lymph node biopsy, how many lymph nodes you intend to remove at that point of time?
So we don't make an intention to remove. We go in, as sir pointed out, we remove the blue node, we remove the enlarged node. We are lucky if the number reaches 3. Otherwise, many a times my harvest is between 1 to 3, sir. My average harvest would be around 2 plus.
So I start with, suppose you do a sentinel lymph node biopsy in a patient's clinically T1 and T2. I'm not talking about the molecular type, right? I'm just taking it as T1 and T2. Right?
So let me just paraphrase. We're talking about luminal, upfront surgery, T1, T2, node negative, sentinel.
I'm not taking any molecular type, because if we start the molecular type, then your Z0011 triad, then that also comes into question mark.
Yeah, absolutely, sir. All trials are very small cohorts, but broadly speaking, what would be your take?
So I'm just coming to that only. Suppose you have removed 3 sentinel lymph node biopsies, lymph nodes, right? So 1 is positive. Fine, after BCS, because obviously it's a clinical T1, T2 lesion. You're going for breast conservative surgery in any of the forms, and you will be doing a sentinel lymph node biopsy. So you remove 3 nodes. The first scenario is you removed 1 node which is positive, 3 nodes, 1 is positive.
1 by 3.
Take it 1 by 3. So I give whole breast radiation treatment.
What is your argument in favor of whole breast radiation?
No, I will go for whole breast radiation treatment.
Whole breast, okay, whole breast radiation.
Obviously, BCS is there, no? After BCS, it is universal that you have to give whole breast irradiation to these patients.
Okay, sir.
Right? APBI and fast forward I can discuss later on, because it's again a huge topic.
No, sir, we're not going there. I'm asking, okay, let me just break this question again.
So sentinel lymph node 1 is positive, I give whole breast irradiation, whole breast.
Would you cover the dissected axilla apart from the...
This is what I'm coming to that also.
Yeah.
Now you have a scenario in which there are 2 nodes out of 3 which is positive.
Yes, sir.
I still go ahead with whole breast irradiation, no axillary radiation.
No axilla till 2 by 3. Okay. What would be your criteria to irradiate the
I'm just
dissected axilla?
So I'm coming systematically. You need remove 3 sentinel lymph nodes. In the first scenario, there was 1 lymph node which was positive. So I'm treating the whole breast, because it is universal, you have to do that. Right?
Agreed.
Now in the second patient, you have 2 lymph nodes which are positive. So I'm treating the whole of the breast. In the first case, in the second case, I'm not treating the axilla, I'm not treating the supraorbital nodes also, I'm not treating the internal mammary nodes also, right? Now you have another patient in which there are 3 nodes removed and 3 are positive.
Yes. We are still technically N1, and now in this scenario, 3 out of 3, you would like to cover the entire template.
Right. So ideally, what I will do as a radiation oncologist, I'll send the patient back to you. That kindly go ahead and do an X-ray dissection for this patient.
Sir, now this patient is referred to you, Dr. Sinu. It's 3 out of 3, luminal, T1, clinically N0 when you took up. Sir is saying that since the harvest is now 3 by 3, please do a completion. What is your take, sir?
I will do the completion.
You will do the completion. Is there any difference with any of the surgeons? So 3 out of 3, we are going ahead and completing the axillary dissection. Whether we have done a frozen and we do it right away, or whether we get histopathology report and then we do it. What are we trying to achieve here? We're trying to check whether our patient has an upstage to N2 or not. That would be very important. Does this also influence your choice of systemic treatment, sir? This nodal harvest, 1 by 3, 2 by 3, 3 by 3, does it influence your choice of systemic treatment? Now, I'll briefly alluded to it because that is where the molecular thing pitches in. Whether this patient is a luminal positive, and would you like the CDK inhibitors to come in? At what stage?
Now, for adjuvant treatment, you need to see the molecular type.
Yeah.
You need to see the other pathological findings also. Whether it is
No
grade 2
adverse
or grade
factors.
3.
No adverse factors.
Fine. So, if it is, and what is the molecular type?
Molecular type is luminal A, sir.
Luminal A?
Yes, sir.
So, if it is pre-menopausal, I'm going ahead with systemic chemotherapy for these patients, even if it is 1 node positive.
Yeah.
If it is post-menopausal with 1 or 2 node positive, probably I will go for oncotype DX, genomic profiling in this patient. And if the risk score is more than equal to 25, then these are the group of patients who will again benefit with chemotherapy. Otherwise, if it is less than 25, post-menopause patient, all will go for only adjuvant hormonal treatment plus the radiation, which I already mentioned.
So, age of the patient
and
is very important.
these are standard guidelines. There is no gray area in this.
Sir, if there are no gray areas and if we do not pursue those white and gray and the area in between, we are never going to change our treatment recommendation. They are going to remain in 1977. We have to explore the areas in between to come to a point where we start questioning whether we are over treating our patients or not. And with that thing in mind, and since we've already taken the favor of the organizers, sir, since you're touching it, could you just explain how taxes and specifically Alliance and NCPP 51, these trials, where axillary radiation is questioning the whole point of doing a surgical axillary staging? Coming from a surgical moderator with surgeons on the dais, I would want you to touch on these points. How taxes, Alliance and NCPP 51 is challenging the fact, do we really need to surgically stage the axilla? And I would like the surgeons to bear in. And this would be my last question. I'm sorry we have exceeded time limit.
See, Paris, if you ask me as a radiation oncologist, I will definitely want every patient to undergo X-ray dissection. The reason is my areas of the target volume for radiation, the axillary and the regional areas, It's not only the axilla which I have to address when I treat patients with radiation treatment for the breast cancer patients. I have to see the supraclavicular areas also, the infraclavicular areas also, the internal memory nodes also. Now, if there is 1 to 3 nodes positive, I treat the axilla. If it is more than 4, I treat the axilla also, I treat the supraclavicular nodes also, I treat the internal memory nodes also. And the second thing is, till date, there is no evidence that you can replace axillary dissection by only radiation treatment. So these trials are on, the results are not there. You have to wait for that before you categorically start practicing. Yes, I can admit axillary surgery in this patient, and let me just go ahead and do axillary radiation for these patients.
Thank you, sir. Sir, since we have to conclude, your brief points. This last question that I have raised, and the sir has beared upon the fact that he would want axillary dissection to be done to take that decision. We still don't have mature data. But when we are talking of that 65-year-old, HER2 positive lady who has no other adverse factors, has a small lesion, are you still inclined to operate on the axilla? 65,
as it stands today, yes, but there is scope as the type of patient you are putting. Probably we can get away by not doing anything to the axilla.
Not doing anything as in not staging at all, not even doing the sentinel?
Yeah, if it is a less than 2 centimeter tumor, like in the future I'm saying, but I don't want to be an adjuvant surgeon, Like surgeon has this habit of kicking himself out of treatment of breast cancer. So we design trials where our role becomes less and less. And yes, like as it stands today, yes, sentinel node biopsy for this patient. But in the future, if the data shows that the probably not doing anything to the axilla does not alter the survival or the locoregional recurrence, maybe.
Professor Madhumita, just anything last month.
Till now, surgery, definitely.
I just want to add, the molecular type of HER2 positivity, you cannot take away the natural biology of the disease. It's an aggressive disease. You need to address the axilla. And the other thing is, if the patient is suitable for doing an MRM or a breast conservative surgery, why can't she undergo the the axillary dissection also?
So the whole point of the...
I'm so sorry to interrupt everybody at this time. I'm extremely sorry, but we are exceeding far of our time. We have an inauguration coming up that will go ahead.
Thank you so much for being so
Thank you so much to all of you.
Thank you so much for bearing in with your opinions.
I would request our chairpersons to stay back and felicitate Dr. Parathyroid, sir. I would request our chairpersons to stay back and felicitate our moderator for the session, Dr. Paras, sir. I would request Professor Dr. Roopwani, sir, HOD Skim Sora, to felicitate our esteemed panelists for the session. Professor Dr. V. Sinu, sir. Professor Dr. V. Sinu, sir, to be felicitated by Professor Dr. Roopwani, sir. Professor Dr. Madhumita, ma'am. Professor Dr. Madhumita, ma'am. Professor Dr. Piyush Ranjan, sir. Professor Dr. Shabab Lalit, sir. And Professor Dr. Naval Bansal, sir.
Moving ahead, we now begin session 2 of the scientific program, and that's endocrine surgery, focusing on precision and evolving surgical techniques. It's my honor to invite the esteemed chairpersons for the session, Professor Dr. Divya Dhaiya, ma'am. Ma'am is Professor, Department of General Surgery, PGI Chandigarh. Professor Dr. Rauf Fani, sir. Sir is Professor and Head, Department of General and Minimal Invasive Surgery, Skim Saura.
Professor Dr. Ramkaran Chaudhary, sir, is Professor, Department of General Surgery, AIIMS Jodhpur. And Dr. Sudhir Sharma, sir, is Consultant Nuclear Medicine, State Cancer Institute, Jammu.
So without wasting much time, I would like to invite Professor Azaz Malik for his talk on redefining thyroid surgery at SKIMS Srinagar. And as we are getting late, so in that context, we will not be taking any question now. Maybe at the tea or lunchtime, we can discuss any query if we have with the speaker. So, Professor Azaz Malik, please. I think he is not here. So, as Dr. Sunil Chumbar is not able to make it for this meeting, I would like to invite Dr. Piyush for speaking upon my experience with parathyroid surgery on behalf of Professor Chumbar.
Good morning, chairpersons. And at the outset, I would like to thank the organizers for having me here. So I'll be speaking on behalf of Professor Sunil Chumbar. So why there is so much of fuss whenever we talk about parathyroids? Apparently, it looks like a lymph node dissection, only go inside and take a small tissue. But if you believe me, no other surgery do millimeters define success as profoundly in parathyroid surgery. So that's the beauty of this surgery. And what is the uniqueness about the glands? Although they are small sized and they are at least 4 in number, that means the number can be variable. And there is no fixed location. It can be in the mediastinum, behind the esophagus, in between the two carotid artery, internal and external. Then it is very, very difficult to differentiate intraoperatively because it is very similar to lymph node and other tissues. Even at times we are not able to differentiate between thyroid nodule and parathyroid whenever we are inside. And obviously it is close to vital structures in the neck, and there is a lot of physiological derangements with this mini monsters, you can say. So that is why we need localization. Earlier, formal bilateral neck exploration used to be done, but at our center after 2006, we could localize the gland, particularly in primary hyperparathyroidism. We could make a small incision and take out the gland. So this was the change. There was a paradigm shift then. Of course, for localization, the basic ultrasound, basic investigation we need is a neck ultrasound, and it should be coupled with a system scan. Then if the findings are discordant, or ambiguous findings are there, or multiple glands are there, we are not able to locate, ectopic gland is there, we go for 4D CT. In some centers, there are choline PET, which is used. Of late, we are using contrast enhanced ultrasound, a newer modality. We use contrast in ultrasound for better localization. And in rare cases wherein we are going for redo surgery, that means there is a recurrence after surgery, we are not able to localize from where exactly the hormone is being released, we go for invasive selective venous sampling. It's rarely done. So coming to ultrasound, we find a hypoechoic area lateral to the gland. They have got a well-defined margin, and the peculiar thing and unique thing is a polar sign. That is the vessel, the polar vessel you can identify. It's always better for the sake of postgraduates if we start doing neck ultrasound, first try to identify the thyroid, and over a period of time you will be able to pick the parathyroids, also abnormal parathyroids. Now coming to the system scan. So what we use is
dual pressure, dual phase, not dual pressure. It's a technetium system UV scan wherein the images are taken at different intervals. So because of the presence of mitochondria inside the parathyroid gland, they take up this tracer and it is hyper functioning. You can see every function, you can see the uptake, very stark difference between from the thyroid tissue. And after some time, the thyroid tissue, the tracer fades away, but it's still there in the parathyroid, the abnormal parathyroid. So what you can check, even sometimes multiple glands, or at least you can see, yes, this is the gland of the 4 which is hyper functioning, right? That means it's a abnormal gland. So 4D, again, same, we are using contrast for this, but we are taking at a different interval. And here, again, the gland will be hyper enhancing, and after some time, there will be washout. So what is the difference from a normal CT scan? It's all the same, but time is taken as the 4th dimension because there is gradual decay of the contrast from the gland. So it is done whenever there is discordant findings, multiple glands. At times we have 20% chances that multiple glands are there, even in non-syndromic cases and in redo or reoperative cases. So here you can see non-contrast image. The first one is a non-contrast image. There is the gland we can see anatomically, but there is no uptake. Now there is enhancement during the arterial phase, the second phase, and there is washout. So this is how we identify. Choline PET is used again in discordant lesions, very rarely available. So what are these? These are like GPS. So when you start from Jammu airport, you can see all blue, but when you reach here, it takes more the time you anticipated. So similarly, they have shown you in 2D images, yes, this is the point where you are going to reach, but how to reach and what you have to do once you have reached, because not always you reach the proper area, the appropriate one. This is a real incident. The guy was following the GPS signal and he was in the bed of the river. So you need to go back to your original skill set, that is 4 gland exploration, that is bilateral neck exploration. And in focus, if localized, you can just go there. Now, once you have reached there, how you differentiate between the parathyroid, the lymph node, and the fat? So, what we do is, first, just to reach that area, you need to discuss the preoperative images with your nuclear physician, nuclear medicine guy, and radiologist. You have to be in the subplatysmal plane, and most of the time you will find the parathyroid just behind the thyroid. So mobilization of the thyroid lobe is required, and you may have to ligate the inferior thyroid artery also just to lift the thyroid. Then handle the tissue. Once you've identified, handle the surrounding tissue. Dissect the parathyroid later on, right? And there is always a feeder vessel going to the parathyroid. Take care of that, and a proper hemostasis should be there, because if the field becomes red with blood, you will not be able to see the smaller glands. So landmarks you are all quite aware of. So most of the time, the upper one is quite fixed in position. It's the lower one, because of the different embryological origin, it can vary in location. So mostly if you are in near the cricothyroid junction, right, just anterior to the recurrent laryngeal nerve, if you have dissected out, if you can see the nerve, so you'll find that. Problem is with the inferior one. You can just see here, it descends along with the thymus. So if it assumes an ectopic location, it's the thymothymic ligament, that is in the anterior mediastinum or lower part of the neck. And it can go anywhere, behind the esophagus, in the mediastinum, between the aortopulmonary window, anywhere. So these are the possible locations of ectopic parathyroids. So most common is thymothymic ligament, but it can go anywhere. And whenever you fail that you are not able to see, go back to the localization methods you have used. You can call your seniors. So these are some of the differences between the parathyroid gland and lymph node or fat. So
There are a lot many differences, but practically what is useful is take some water, saline water. If it is fat, it will float. And lymph node, just touch it, press it. You can just feel the consistency. And you cannot just palpate the parathyroid gland. It's very soft. If you palpate, it's very soft. There is a test called squeeze test. And so whenever you fail, some slides are not working here. So whenever you fail, it's not just failure. It's time to reorganize and rethink. So what you do, go back, discuss, and do additional imaging like 4D CT if you're not done, pulling PET if you're not done. Again, ultrasound. You can call the radiologist to the operation theater. Okay, and do an intraoperative ultrasound, because most of the time they will see in their room, their office. But if you try to follow them, follow the gland inside the OT, it's very, very difficult. So, and in OT, you have spent say 1 hour, you are not able to locate, just stop. Do not continue. Close, talk to the patient, and again re-image, discuss. Before doing that, you can take, if you're dealing with an inferior gland, take thymic tissue also. Most likely you will get the parathyroid inside the thymic tissue. Now, if you have found a gland, perfectly fine. Post-operatively, you have done the PTH, it is not coming down to the baseline. Again, wait for some time, few weeks. Again, do the same, what I discussed. So what we do at our center, the usual stuff. Any patient who has hypercalcemia, bony pain, fatigue, nephrocalcinosis, we check for vitamin D and PTH and calcium phosphorus. And then we proceed. So just to summarize, gone are the days. Again, I had some pictures, I don't know what happened. So gone are the days where there was a dictum, only localization technique you need is to localize a parathyroid surgeon. But with good localization techniques like MIB scan, PET choline and 4D CT and good ultrasound, now the time has come is to identify the parathyroid team rather than the surgeon. So with this I conclude. Later we can have the questions. Thank you.
Thank you, Dr. Piyush, for the excellent presentation. Now I call upon Professor Ajaz Ahmed Malik, who is former head of endocrine surgery and head general and minimal invasive surgery, SCIMS, and he has really redefined the endocrine surgery in SCIMS, and he will be talking about his experience.
A very good morning to the August gathering, respected chairpersons. At the outset, I thank the organizing committee for giving me the opportunity to present this evolution of thyroid surgery at SCIMS. I'm happy to have you all here. Thyroid has been one of the important organs that most of the general surgeons now are trying to forget. But because of the evolution of endocrine surgery and its dissemination all around the country and outside, there has been a special interest in managing such disorders in different ways, right from the open surgery up to the minimal access approach. Initially, it was thought that thyroid would never be operated because it would carry a very high mortality. Now the era is right from the conservative approaches up to the endoscopic, and the Robotic gives. Cocker is considered to be the father of this thyroid surgery. There has been evolution over different centuries. Once we have reached to the present century, where the minimal access approaches and other approaches have come into play. What are the major indications that most of you must be knowing here for postgraduates? Authoritative thyroid nodule and intermediate nodular thyroid cancer and MNG, even a gravis, and the patient preference as well. There has been continuous progress in differentiated thyroid cancer management. Nowadays, people are trying to opt the option of a hemithyroidectomy over a total thyroidectomy. There are different studies that are in literature. The traditional local thyroidectomy definitely has a nice advantage that there is an excellent exposure which is suitable for all cases. And but there is a visible neck scar, which is very large. In countries like Korea, it's a bad omen to have this scar, and it's very difficult for them to get even the marriage possible. Our work in respect of, with respect to thyroid that has occurred over decades at SKIMS has come into play right from applying the open surgery, large scars using sutures, then coming to clips, then going to sutureless thyroidectomies, and then doing a lot of research on these thyroid subjects, having some good publications in literature. These are our landmark publications of sutureless thyroidectomies, or comparing the suture with the conventional thyroidectomy, or with or without drains, or having a lateral approach to attack the thyroid, especially in reoperations, and then the genetic studies that have come into other journals. Our landmark publication, which has recently come in Indian Journal of Surgical Oncology, as a hemithyroidectomy, a safe bet for the differentiated thyroid cancer, PTC. These are our open surgery techniques that we have adopted for a long period of time, having various thyroidectomies and the neck dissections. And now evolution has been towards the minimal access approach, where minimal invasive video-assisted thyroidectomy up to an endoscopic, robotic, and transoral approaches have come into play. MIVAT has been introduced in 1998. This is a video-assisted one. Then transoral thyroidectomy, I think about this, Dr. Anita will talk to you about, as they are doing it in AIMS. There are various approaches that have been adopted in robotic thyroid surgery also. Now, endoscopic thyroidectomy using a laparoscopic approach is basically an access where cervical, axillary, breast, or retroauricular approaches. And it has an added advantage of having a hidden or remote scar with a better patient satisfaction. And disadvantages are it's little technically challenging and has initially an increased operative time. These are the various approaches that are being done below the neck, including the ABBA and BABA approach, bilateral axillary or axillary bilateral breast approach. Current trends that have been imbibed in various studies, we can know the emphasis on scars and minimal invasive approaches is there, and thyroid surgery has evolved from high-risk open procedures to safe, conventionally, cosmetically unfavorable techniques. Patient selection is definitely an important factor. We have been doing this, I introduced this procedure in 2025. We have done 30 cases at SKIMS. This is the demography which I can describe to you. Our experience has been the complication profile in our study was no different from those reported in the literature outside. Skin chymosis has occurred in one patient, which was spontaneously absent after 2 to 3 weeks. One unusual neuropraxia occurred in excessive abduction of arm because of axillary nerve neuropraxia, which again got treated within 2 to 3 weeks. None of our patients had, in our study, any voice change or hypocalcemia, and operative time has been initially longer, but later on we have achieved a shorter operative time. We observed good patient acceptance of this endoscopic thyroidectomy. In our society, there was a need for applying this surgical procedure in our society because DTC being now diagnosed at a very young age, type 2 in females who are yet to get married and have a better quality of life. Our center is also a part of the international multi-institutional trial assessing health-related quality of life outcome after endoscopic thyroidectomy. I introduced it last year. And there is an evidence in literature right from 23, 25. Most of such studies are saying that it is advantageous, but still larger future studies are needed in order to have a commendable necessary outcome, which procedure is better. We have also done a modified, we used, what I have done is I have used conventional laparoscopic instruments and are extended after GI surgery. I have extended this laparoscope into the neck and tried to find the possibility of doing a thyroid surgery. These are little modified approach. Malik's technique we have already got accepted in Robotic and this minimal access journal. It is going to publish in the month of July. This is one of the approaches, one of the good videos that I have selected for you people. to watch. We used, first of all, we have to create a subcutaneous tunnel just from the anterior axillary fold at 2 places. We use a 10 mm for the working port and 5 mm for your another port. Then another port we use from the areola superiorly, whether it is on the right or the left side. This is the tunnel which we have to make. We have to remain, very important, we have to remain just above the muscles, pectoral muscles. The space is extended into the neck. This is the left hemithyroidectomy you are watching. We're trying to make the exposure of 2 heads of the sternocleidomastoid, the clavicular and the sternal end. And now we try to enter the neck. And here you can see these are the strap muscles. This is the internal jugular vein that you can see, and medial to this, medial and posterior will be the artery. We have to be very careful about that. We try to separate these strap muscles. These are the deep strap muscles, sternothyroid and thyroid. We try to go posteriorly and inferiorly and try to localize the most important structure. That's the parathyroid fat pad that will give us the localization of the parathyroid, and also the recurrent laryngeal nerve, very important. Especially on the left side, it is more liable to get injury as compared to the right side. So we have to be really careful and try to take the bed off. This is the internal jugular vein and the common carotid artery. You can see here, very nicely and slowly and steadily, we have to follow the posterior bed. Try to go to the superior pole also. This is the inferior area. This is the parathyroid fat pad. That is the trachea. And these are the inferior thyroid vessel pedicle. We have to have a capsular approach here. Try to avoid the injury to the parathyroids and the nerves, which is of primary importance in any thyroid surgery outcome. This is the upper pole dissection. You have the space of jaws or the space of reeds. Most of the postgraduates must be knowing here. We try to see the superior parathyroid, take it back, and try to reach superiorly, avoiding the external branch of the superior laryngeal nerve. That's very important. We have to be very careful that we go to the tracheal side where we find the isthmus. Now this isthmus is also resected. To have a hemithyroidectomy, the plane of your harmonic has to be parallel to the trachea in order to avoid any injury to the trachea. That you have to be very careful. Go from superior, posterior, and inferior approach. Try to do the isthmusectomy totally. I think this is a warning signal. There are still 2 minutes. So this is the recurrent laryngeal nerve that you can see here. So you can see this is the recurrent laryngeal nerve exposed. That is the parathyroid. This is the dividing the Bailey's ligament. That is the most important area which we have to keep in mind, because here the nerve enters the larynx. This is the preserved recurrent laryngeal nerve exposed. This is the last bit of thyroid you can see here in the isthmus. This is a left hemithyroidectomy, both the lobe as well as the isthmus, and exposing the trachea. Now this is the residual area which we have to expose here. This is the trachea, recurrent laryngeal nerve with the superior parathyroid and the inferior parathyroid. This is the JB gene that we use just to avoid the hematomas and other complications post surgery. This is specimen, and this is the follow scarless thyroid surgery. Thank you all. Any questions are welcome.
Thank you, sir. Excellent presentation. We can have the questions and answers at the last time. Thank you, sir.
Thank you very much.
So next we will invite Professor Anita Dhar, and she is going to speak on endoscopic thyroidectomies. Read your presentation. So welcome, madam.
Good morning. I gave my presentation at 8:30. There was some technical issue. So to carry on with the debate of Dr. Malik has already set the ball rolling. Thank you, Dr. Malik. You have already introduced the subject, and most of my talk is already over. And I'll just add few things because I was given time of 15 minutes. I don't know how much I still have.
Varun, duplicate.
So I'll just pass on these slides. So we already know about this great person who decreased the mortality from 40%. Every person who would go for thyroid surgery would come with a mortality of 40%. And suddenly it decreased to 0.5 with his intervention and the technique he used, and got a Nobel Prize for this. With the major still provided to many patients, because we know the tumor burden and large size tumors which we have, we can't offer minimal invasive to everyone. So from this, we have come a long way to the minimal invasive surgery for thyroids. And as it is, the history, already Dr. Malik has told you, I will not waste my time on this. This is the whole timeline where different approaches have been, the idea behind is to have minimum scar on the neck. That is the primary goal. People don't want a big scar on the neck. And second, of course, is safety and better visualization. Endoscopy with normal instruments, and then we moved on to the robotics with a better visualization, high definition visual impact has played a big role. These are again various techniques, different approaches, different access points, and the idea is to take scar away from the neck, whether it's in the axilla or breast or posterior to the at the mastoid, diagrammatically, or to the no scar technique, leaving no scar visible on the body from outside. It all started with the minimal invasive video assisted thyroidectomy with just 2 centimeters, 2.5 centimeters. It was a very big attraction when surgeons from Germany came and demonstrated this technique when I had just joined AIMS in 2003, 2005. So it was a big attraction that time. So we have moved a long way. I don't think now anyone is doing this because we have better methods. Posterior axillar or auricular root, more happening with the ENT surgeons. They even go with the robot from that side. It doesn't use gas, and they just lift it with the better visualization with the lighted retractors, and the scar is again hidden. It has big problem because we can't see the opposite side. Only one side is visible. Then we shifted to breast and axillary approach. It can be unilateral or bilateral and different indications. I'm going to skip all this. Prerequisite in the beginning is we did choose to remain less than 40 ml volume or 4 centimeters. But over a period of time, as we now are doing it for last 10 to 15 years, and the technique has moved on with the experience to the bigger sizes, to the total thyroid and larger volumes. I'm going to skip all this. The ports are placed, the video that I'm demonstrating, it has central symmetrical view on both the lobes. The vision is centered like in an open thyroidectomy. We as surgeons who are trained with open thyroidectomies allow this view because this gives us exactly the book picture of what we have been trained for the open surgery. And access for both lobes, access for the nodes, everything can be, it's a feasible thing. We started with the hydrodissection earlier. Now we have stopped using this because of the blind technique that was following it, making the ports and all blindly. So we are doing it with a modified technique of under vision, raising the flaps now. This is the initial picture. This is the marking, 2 fingers down, another marking from the clavicle downwards, both axillary and the breast, plus making a thyroid notch here and having a decent area going beyond the actual line that we are making it from the axilla to the thyroid cartilage, so that we make good space. If you have a thyroid, big, large thyroid, you need a good room to work with the instruments. And we do initially use some xylocaine and solution. And this is the port placement. And this is the first view after the 4 ports have been placed. This is the lit, the lantern type of a view. And this is the honeycomb view when we place the endoscope for the first time. And here is the video demonstrating how we raise the flaps and introduced all the ports. So this is the 4 port placement, 2 at the axillary, anterior axillary line near the deltopectoral groove, and 2 at the breast areolar junction. This is the opening of the midline that exposes the gland. This was little larger gland, and this is a demonstration for total thyroidectomy. Since the volume is large, there are people who use sutures, they use hooks. This is the retractor that is used in bariatric surgery also, and we made use it in the thyroid. And since the volume of the thyroid was too big to handle. This is the inferior polar dissection. And then going to the superior pole, exposing while lifting the thyroid, exposing the recurrent laryngeal nerve, taking the thyroid off. This is the tubercle of Zuckerkandl. We know the landmarks that we have to follow. We find the nerve just below it. And with the large thyroids, we do have this tubercle also is big, hypertrophied, and we have to lift it. This demonstrates the parathyroids and the recurrent laryngeal nerve on the right side. And then we make the use of the instrument to pull out, hold the isthmus, and the opposite lobe comes out of its bed. And the dissection again, it's a replica of the right side left side that we do on the right. The inferior polar and looking for the nerve. And once the nerve is demonstrated, you can see a nice view of the nerve, and dissection remains above it, and dropping the loose tissue, which has the parathyroids and all, away from the capsule. This is the root of the nerve that we follow, keeping ourselves above the nerve and taking away the tissues adjacent to it. This is disconnecting the Berry's ligament and the isthmus. The whole trachea is visible and the gland has been separated out completely. We use a glove bag for the retrieval of the specimen and close the midline. And we use a drain to finish the procedure. So after having good experience and simultaneously, actually we started using the vestibular route also. The modifications have been many. People have gone through the base of the oral cavity, through vestibule, combination of oral and vestibule. But now most of the techniques are modified and settled now only to the vestibular part. And since the oral base or the floor of mouth gave a lot of complications, and this technique of Toetua has the vestibular approach, only 3 ports are used. And again, we have to choose our patients. The chin has not to be too big because finally you are working over the chin. You have to choose your patients. But most of the Indian structure of face is not having too big chin. So we are able to handle it. And also to say that in male, sometimes the thyroid cartilage is quite prominent. So that has to be considered and kept in mind when you're introducing the trocars inside. You can destroy the thing. These are the markings. Can I have some time? It's been 15 minutes. So this is the packing of the mouth, marking just above the frenulum, and the lateral ports are placed lateral to the canine. So we avoid this mental nerve. We have to be careful about it. And then the creation of the flaps. Midline 10 mm port, 2 5 mm ports on 2 sides. They are headless ports because the space is less. So this is the first view when we introduce the scope. Creating the flaps again, and now we have seen these are the platysma, and we have opened the midline raphe. The trachea is exposed here. Again, this was quite a good volume thyroid. Hemithyroidectomy is planned here. This is the superior polar. Sometimes the part of the muscle insertion is disconnected. The sternothyroid muscle here, because sometimes it overrides on the superior pole. So this helps us to get completely onto the point. After managing the superior pole, we go to for the dissection. There was a small nodule at the isthmus also that is taken along with the specimen. And lifting and disconnecting the isthmus using harmonic hair. This is completely lifted from the trachea, and now we have to look for the recurrent laryngeal nerve. It's a top-down approach. So we're looking for the recurrent laryngeal nerve. I'll request you to give me 4-5 minutes, please. Once the recurrent laryngeal is seen close to the trachea, we lift the thyroid medially over the trachea and see it laterally also. You can see it, the nerve is seen nicely here. and the whole course of the nerves can be visualized in few seconds. And again, take care of the parathyroids that are all along this track. And then the whole gland is separated out. Inferior polar dissection is done, and the hemithyroidectomy is completed, placed in the bag and retrieved. No drain is placed, and there are certain people who modify this technique by placing the port through the axilla if the gland size is too big. But to do a complete nodes type of procedure, you take it out from this. This is the recovery of the patient, and no problems, no distortion of the chin, nothing. The shape is maintained. This is a modification recently published paper where the submental technique has been used, avoiding the oral. There are people who consider it as infected root, and because the oral cavity is entered, but that is not true. None of our patients had any problem, and this is a modification just to for academic reasons. This gives advantage of the vestibular and also being very close to the gland, the advantage of minimal invasive thing also. So we are doing now minimal invasive thing for with robot also, and we are done till now almost 40 patients, and again a very good vision, huge magnification, and under vision we place all the ports. And the technique basically remains the same, only the instruments are different. This is a case of total thyroidectomy for PTC. Visualization of the nerve. The parathyroids are seen very well. The nerve is seen, and you can preserve and do the needful. I'm just moving it a little faster because of the time constraints. You can see the opposite recurrent nerve and the parathyroid very clearly and protected. Then superior polar dissection and separating the gland. Regarding Baba and Toitwa, we had done a randomized trial and we found they were almost, the results were similar, but the time taken in for doing Toitwa was less, and the patient satisfaction was much more with the Toitwa, the vestibular, because it leaves no scar, and since the tissue dissection is very precise and short, they are happy. We did voice analysis in the beginning, and about 20 cases, there was no changes. That is a concern because voice is a concern. And this is another case. This minimal invasive surgery does make a difference. We had this patient who had the thyroid nodule and also had an ectopic thyroid, mediastinal ectopic. And conventionally, this would have been an approach where retrosternal thyroid, if present, would have had a sternotomy and a big scar. But we did here Baba and also the VATS. This is the first look at the introduction of the endoscope, VATS, and this was the Baba. And this is the result we have. I just leave you with this slide. This is an overview of all the techniques that are established and the plus and minus of advantages, and this easy techniques for all beginners and all is no doubt the Baba technique, and we should begin with this technique where it gives exactly the same view, same image for practicing as in the open surgery. So it's definitely going to help for the beginners. Thank you.
Thank you, Dr. Professor Anita Dhar. It was an excellent presentation. Now I will invite the next speaker. He'll be talking on focused parathyroidectomy. The session is over. So if you like, we can continue the discussion or during the lunch break.
So we can invite a couple of questions, interesting videos and interesting field into thyroid surgery. Two quick questions from the floor, if any. So my question to Anita Dhar madam, you showed the videos in which you were using that ligature device. Do you think in the closed space you find the ligature to be a safer device than a harmonic, because this harmonic have this hot bread that can damage the vascular structures or like that. So it's your routine to use always this ligature.
Hello. Between ligature and harmonic, I don't know. I'm very happy with ligature. And though it has little thicker tip, but I do manage with it. Harmonic is good, but it generates a lot of heat. You have to be very careful when you are very close to the parathyroids and the nerve. So that has to be something very thoughtful whenever you are doing surgeries. That's true for all parts of the body, but especially the neck, where the whole space is so crowded and you have very important structures adjacent to each other. All energy sources have to be used carefully.
Thank you. Thank you. So we will close the session.
Thank you everyone for such enlightening sessions. May I request Professor Dr. Divya Dahiya ma'am to felicitate Professor Dr. Piyush Ranjan sir. May I request Professor Dr. Divya Dahiya ma'am to felicitate Professor Dr. Ejaz Ahmed Malik sir. May I request Professor Dr. Rauf Fani sir to felicitate Professor Dr. Anita Dhar ma'am.
I would now request Professor Dr. Ajaz Ahmed Rathar sir, Chairman Jakasicon, to felicitate our chairpersons for the session. Professor Dr. Divya Dahiya ma'am. Professor Dr. Rauf Fani sir. Professor Dr. Ramkaran Chaudhary sir. Professor Dr. Sudhir Sharma sir.
We now arrive at a very special and significant moment of this conference, the inaugural ceremony of Jakasicon 2026. May I have the honor to invite Dr. Sushma Bhardwaj, Associate Professor, Department of General Surgery, AIIMS Jammu, and Dr. Suneha Kumari, Assistant Professor, Department of General Surgery, AIIMS Jammu, to kindly start the proceedings of the inaugural ceremony. Thank you.
Hello.
A formal beginning to our coming together of knowledge, experience, and surgical excellence. On behalf of the organizing committee, it is my proud privilege to extend a warm and heartfelt welcome to all our distinguished dignitaries, respected faculties, and dear delegates. I request our chief guest, President, Association of Surgeons of India, Professor Dr. D. Maruthu Pandyan sir, to please come on the stage. Our guest of honors, Director AIMS Jammu, Professor Dr. D.N. Sharma sir, and our guest of honor, Professor Dr. Madhumita, who is also serving as Treasurer ASI. Chairman Jakasi, Professor Dr. Ajaz Rahmat Rathar sir, Secretary Jakasi, Dr. Harvinder Singh Bali sir, Organizing Chairperson of Jakasicon 2026, Dr. Maria Kapoor ma'am, and Organizing Secretary, Dr. Varun Dogra sir.
Now we commence the lamp lighting ceremony with our dignitaries. Ma'am, sir, please join us for lamp lighting.
I request everyone to please stand for ASI anthem.
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा
الله لا إله إلا هو الحي القيوم لا تأخذه سنة ولا نوم له ما في السماوات
एक ओंकार सतनाम करता पुरख निर्भव निर्वैर अकाल मूरत अजूनी सैभम गुर प्रसाद जप आद सच जुगाद सच है भी सच नानक हो से भी सच abide with me fast falls the eventide the darkness deepens Lord with me abide when other helpers fail and comforts flee. Help of the helpless, Lord, abide with me.
Thank you. Now I request everyone to please be seated. Now it's my warm pleasure to invite on the stage Professor Rofani sir to kindly present the bouquet to Professor Dr. Marthu Pandian sir. I also invite Dr. Shamasul Bari sir to kindly present the bouquet to Professor Dr. D.N. Sharma sir. Now I request Professor Meeta Gupta ma'am to kindly present the bouquet to Professor Madhumita ma'am. Now I request Professor Dr. Dinesh Rao sir to kindly present the bouquet to Professor Ejaz Ahmed Rathur sir. Now I request Professor Ravinder Sharma sir to kindly come on the stage and present the bouquet to Professor Dr. Harvinder Bali sir. I request sir, Dr. Ravinder sir to kindly stay on the stage and present the bouquet to Dr. Meria Kapoor ma'am and Dr. Varun Dogra. Now I request Treasurer ASI, Professor Madhumita ma'am, to garland Professor Dr. Marthu Pandian sir with ASI President Medal. Now I request Professor Sanjay Kumar Wasim sir, who is a governing council member of ASI, to garland the Professor Ejaz Ahmed Rathri sir with Chairman Jakasi Medal. Now it is our pleasure to invite Dr. Meria Kapoor, Organizing Chairperson, Jakasicon 2026, to give welcome address. Ma'am, please.
Atithi Devo Bhava. Guest is God. Good afternoon. Namaste. Respected Director Sir, Dr. D.N. Sharma, President ASI, Dr. Marthu Pandian, Treasurer ASI, Dr. Madhumita, President Jakasi, Dr. Ijaz Rathar, Secretary ASI, Dr. Harbinder Singh Bali, Honorable Deans, Associate Deans, Principal Nursing College, my senior faculty, dear colleagues, senior residents, postgraduates, undergraduates, nursing officers, the paramedical staff, and everyone who's the part of AIMS family, a very warm and hearty welcome to you all. It's my great privilege to honor and welcome all of you to this prestigious gathering, Jakasicon 12th, a surgical conference that brings together mind, skill, and vision. The theme of this year's conference, Scalpel to Scope, beautifully reflects the evolution of surgery from traditional open position to the precision and finesse of the minimal invasive techniques. It symbolizes not just technological advancement, but also our commitment to continuous learning. Standing here today is particularly emotional for me. Since we started our journey 1.5 years back, and what began as a vision has now grown into a vibrant, dynamic, and dedicated unit. It has truly been a remarkable journey, which was, although filled with challenges, teamwork, growth, and countless milestones. This conference would not have been possible without the unwavering support of my dedicated surgical unit, Dr. Sushma, Dr. Varun, Dr. Julie, Dr. Suneha, my senior residents, my postgraduates, nursing officers, and all the paramedical staff who has worked relentlessly day and night to make this program a big success. To all our guests who have traveled to be here, I hope you not only gain enriched academic experience, but also enjoy your visit to Jammu, the city of temple and rich heritage. As we come together under one roof, may this conference not just be a meeting of mind, but celebration of dedication, compassion, and the spirit of healing. Once again, I welcome you all with great warmth and gratitude. May Jakasicon 12 not just be a success, but a memory to carry forward with pride. Thank you.
Thank you, ma'am, for this warm welcome message. Now I invite on dais Dr. Harvinder Singh Bali, sir, who is the Secretary of Jakasicon, to give the annual report.
Thank you. Dignitaries of the dais, my respected teachers, friends, and students, welcome to AIMS Vijaypur for this annual conference. At the onset, I must congratulate the organizing team led by Dr. Maria and Dr. Varun for taking up the challenge to getting this annual conference at AIMS Vijaypur, which I just started, I think, 1.5 years back. So it was a challenge, even we thought a number of times, to whether to give the opportunity to the organization of this AIMS Vijaypur, but they are going to put a very good show. Dr. Varun has been in constant touch with me for the last 6 months. We have been discussing all the small details regarding to get this conference through and make it a huge success. Regarding the Jakasi, our organization, after overtaking the reins of Jakasi in 2024, first under the chairmanship of Professor Walsalim in 24-25, and then under the chairmanship of Professor Ajaz Rathar, it has been our endeavor to take these highly special modalities to the doorsteps of the common people of the state, which consists of many inaccessible areas in both Kashmir and Jammu division. We have organized annual conferences in the peripheral hospitals of Anurag last year, 2025 Jakasicon was held here. We had conducted midterms in Kupwara, Kathua, Doda, Baramulla and Rajouri districts last year and this year also. A number of camps were held in the far-flung areas of Aknur, which is at the line of control, and the border areas of Kupwara, Kishtwar, Banihal, Ramban, Bandipur. We have done number of BS camps in different parts of the state. A number of blood donation camps have been done under the Jakasi. The membership has also increased up to the 475. These are the permanent members of Jakasi representing a part of ASI. We have achieved a lot, and lot needs to be done. As the new executive will take over the charge of the conference, I wish them all the success. We will be with them both at Jakasi and ASI. Wishing Jakasi 2026 a huge success. Long live ASI, long live Jakasi. Jai Hind.
Thank you, sir. I now request Chairman Jakasi, Dr. Professor Ajaz Ahmed Rathar, sir, to address the gathering, please.
President Association Surgeon of India, Dr. Maruti Pandian, Honorary Secretary Association Surgeons of India, Dr. Madhumata, Executive Dean AIMS Jammu, Dr. Dayanand Sharma, Dr. Bali, Harvinder Singh Bali, our Honorary Secretary. Then we have with us the organizing secretary of this conference, Dr. Varun and Dr. Maria. Senior members here, a member of the Jakasi, Professor Nisar Chaudhary. Then we have Professor Munir Khan, my teacher and guide in the audience. Professor Ajaz Malik, ex-former directors, deans, present heads of the departments. Dear faculty members, Assalamu alaikum and a very good morning to all of you. And in fact, it's a great pleasure to welcome you all on behalf of the JK chapter of the Association Surgeons of India in this annual conference being organized at AIMS Vijaypur, Jammu. As surgeons, we live in an era of remarkable advances and knowledge explosion, where conventional surgery is being replaced by the newer techniques, be it the robotic, precision, the artificial intelligence, and minimal invasive surgery. So we have to keep ourselves abreast with the latest technologies and latest techniques because Otherwise, we will be redundant. Because in surgery, what was new yesterday becomes obsolete tomorrow. So these conferences also act as the platforms where we can refresh our knowledge, to know about each other, know about the newer techniques, and also we meet our old friends and colleagues. Dear friends, the greatest advances in surgery will lie not only in our operating rooms, but in our hearts and conscience. Let this conference be a reminder that while technology may define the future of surgery, ethics and empathy will always define the surgeon. In today's era of rapid technological advances, when the newer procedures are replacing the surgery, human touch remains irreplaceable. Our scalpels may have become sharper and our monitors may have become smarter, but the moral compass and compassionate heart of a surgeon must remain constant. As we deliberate in this conference, let our discussions and discoveries be guided by these principles, that is empathy that humanizes medicine, ethics that dignifies it, and professionalism that glorifies it. In an age of commercialization and increased medical legal scrutiny, maintaining patient trust is of paramount. We must reaffirm our commitment to the principles of beneficence, non-maleficence, autonomy, and justice. Technology should enhance, not replace, the human touch which defines our profession. Equally important is empathy, the ability to see the patient not as a case or diagnosis, but as a fellow human being in pain and uncertainty. Empathy is what transforms sickle into healing. A gentle word, a reassuring touch, and a few extra moments of listening can ease more sufferings than a scalpel can ever do. Let us never be so busy that we forget the person beneath the drapes. When we have entered the field of surgery, we are not drawn just by the challenge of the craft, but by the call to heal. Our patients entrust their most precious gift, that is life. So they come to us not merely seeking a procedure, but seeking an understanding of assurance and hope. And alongside of empathy stands ethics, that's our moral backbone. And in the era where healthcare is increasingly commercialized, where choices are influenced by cost, competition, and convenience, ethics reminds us of our sacred duty to act always in the best interest of the patient. Ethics should live on our daily decisions, in the honesty with which we explain the risks, in the humility with which we admit the complications, and in the integrity with which we choose what is right over what is profitable. Let us remember the words of Sir William Osler, who said that a good physician treats a patient, but a greater physician treats the patient who has the disease. As leaders and learners, we must foster a culture that rewards compassion as much as competence, integrity as much as innovation. Let the surgical training program not include only techniques and technology, but also conversations about values, communication, and ethical dilemmas. Let mentorship extend beyond the operating rooms, guiding young surgeons to balance the precision with humanity. My dear colleagues, in the world racing ahead with machines and metrics, the surgeon's true strength always lies in the human touch, the ability to comfort before we cure and to care when we cannot cure. One of the foremost issues confronting us today is widening gap between technology and accessibility. While urban centers boast cutting-edge facilities, in the rural areas and peripheral institutions, we still are lagging in the basic surgical infrastructure. Bridging this gap is not just a policy challenge, it's a moral responsibility for all of us. This is how the platform of Jakasicon was created by the founder leader, our Dr. Nisar Chaudhary, who is here in the audience, way back in 2009. In this platform, we have the surgeons from the rural areas and from the urban areas who discuss all the problems at one place and the solution to that problems. Now, The well-being of the surgeons themselves is another challenge which deserves attention. Burnout, stress, and work-life imbalance are real challenges that we can affect performance and patient care. Supporting our colleagues, especially young trainees, is essential for sustaining excellence in the field. So ASI has come up with the plans of social security scheme, which gives a guarantee for your future when you are old. So we all must ensure the proper participation and encourage the participation in these schemes. Then second, we have many programs. ASI has introduced it for young surgeons, fellowship programs, quizzes, competitions, training, even sponsoring outside the country also. So we must, as senior faculty colleagues, try to involve most of the postgraduates to make them an asset member so that later on they become the life member of the association. I express my sincere gratitude to Dr. Varun and Dr. Maria, who have done tremendous hard work during this all the period for making this a memorable event and for the superb hospitality. I fail in my duty if I don't express the contribution of our former chairman Jakasi, Professor Iqbal Salim, who has done a lot of hard work to increase the stature of this platform, and how I can forget the contribution of our treasurer, Dr. Shamsul Bari, who has been kind enough to lend money to all the organizers during all the conference, and that too without any interest. Dr. Bali needs a special mention because of his busy schedule. He always is involved, conducting the meetings, Zoom meetings and other events, so which has been doing gracefully. Professor Basin our EC member, has always been a man behind them, right, and guiding them in the proper way. I think Varun must be disturbing him day in and day out. When I hand over my charge of Chairman Jakasi to Dr. Nasib Chand Digra, I hope his vision and wisdom will help the Jakasi to progress and flourish under his chairmanship. Dear colleagues, this conference is not just a meeting, it's a platform for introspection, innovation, and inspiration. Let us use this opportunity to learn, to share, and to collectively shape the future of surgery. With these words, I once again welcome you all and wish this conference a great success. Long live Jakasi, long live ASI.
Thank you, sir, for those kind and inspiring words. Next, I have the honor to invite on the dais the National Treasurer of ASI, Professor Dr. Madhumita Ma'am, to please address the gathering.
Respected dignitaries on the dais, respected dignitaries of the dais, and to all members of Jakasi. It's my proud privilege to be addressing this august gathering over here. And I'm overwhelmed by the hospitality that I've received over here. Thank you all so much. I still remember that day when, Dr. Maria, they all started, was very enthusiastic, and they started this AIMS Jammu. And I'm so happy with the progress they made, and a huge congratulations to the whole organizing committee of AIMS Jammu. It is a wonderful experience and a very nicely organized conference. Last year, when I had come to Anantnag for the Jakasicon, I still remember the then chairman, Dr. Salim, had said that the Jakasi is a small body. So whenever you think of the best chapter award, think of points like we should not be competing with the larger chapters. This year, our president, Dr. Maruthu Pandian, has shortened down the chapter points. So I'm sure this year Jakasi will get the best chapter award. Actually, the ASI is very proud of Jakasi. It's like a shining star. And be it in academics, be it in social service, Jakasi is always leading from the front. I'm really, everybody is really proud of this state chapter. And there's one more thing I would like to say is that our strength lies in our membership. The more we unite together, the more we are together, the more we prosper. Now, we all know that the Association of Surgeons of India is 40,000 plus members strong, and it's the second largest surgical society in the whole world. But again, the word comes second. We should strive to be the largest surgical society. Then that can be done if each one of us, we make a strive that each one of us will make one more new member. If each one of us make one more new member, we will definitely become the largest surgical society. See, India has got more than 1 lakh surgeons, but not even half of them are ASI members. Please reach out to your friends who are not members, to your friends, your colleagues who are there with you. Please encourage them to become members, and each of you please make one more new member. And that way we will prosper, we will be united. Long live ASI.
Thank you, ma'am. And I think of all the speech that we heard, the shining star are the 2 words that we are never going to forget. I hope we make you proud in the future too, ma'am, and we keep shining and our star never goes into a black hole. You know, we always keep shining. Thank you, ma'am.
Academic association creation are brainchild of very few people. And as far as the J&K chapter Association of Surgeons of India is concerned, it came into existence in year 2009 with a meager strength of only 35 surgeons of J&K, which is now a strong body comprising of more than 600 surgeons. Jakasi is a duty bound to thank and extend its gratitude to the doyens who have brought the association to present life. The first and the foremost senior surgeon without whom the birth of Jakasi could not be possible is our beloved founder chairman, Professor Nisar Chaudhary sir. I now request Dr. D.N. Sharma sir, Dr. Marthu Pandian sir, Dr. Madhumita ma'am to felicitate Professor Nisar Chaudhary sir. I request Dr. Professor Nisar Chaudhary sir to please join us on this stage. Sir was succeeded by Professor Rakesh Rao sir. As the sir is not well, I request Dr. Professor B.S. Pathania sir to kindly receive the felicitation on his behalf. Our third chairperson, Professor Tariq Azad sir, is also not present here. So I request Professor Subhash Abrol sir to kindly receive the felicitation on his behalf. Our fourth chairperson of Jakasi, Professor Fazal Pare sir, has not yet arrived. So I request Professor Ijaz Ahmed Malik sir to kindly receive the felicitation on his behalf. Now I invite Professor Dr. Sanjay Kumar Basin sir, who is a presenter, governing council member and pioneer of Jakasi, to come on the dais to receive the felicitation. Now I invite our immediate past president, Professor Iqbal Salim Mir sir, to receive the felicitation. As the sir is not here, I request Dr. Shamas Ulbari sir to kindly receive the felicitation on his behalf. Thank you, sir. Now I request to everyone to please be seated. There are few lifetime achievers by virtue of their intellect, hard work, dedication, and devotion to the cause for which they are born. And it is the duty of generation next to recognize their services and befittingly felicitate them. Jammu and Kashmir, chapter of Association of Surgeons of India, which is one of the chapters of ASI, which itself is the second largest surgical body in the world and first largest body in Asia Pacific, is duty bound to felicitate the achievers. This time, Jakasi has decided to honor two stalwarts for their exceptional professional services to mankind, and first among the two is Professor Dr. Munir Khan sir, who is the founder member of Jakasi and remained in a leading position at national level and has served as ex-HOD of GMC Srinagar. Sir is also the sponsor of Professor Mahmood Khan Oration. The second pioneer and doyen is our revered teacher, first MCH Pediatric Surgery from Jammu and Kashmir, a guide to so many generation of surgeons, ex-principal GMC Jammu, HOD Surgery GMC Jammu, and ex-member Jammu and Kashmir Public Service Commission, Professor Dr. Goswami sir. To please request sir to please come on the stage and receive his award, prestigious award. So I request Professor Dr. Sunil Gupta sir to kindly join on the stage and to receive the felicitation on his behalf. So request all dignitaries to please be seated.
I would now request Professor Dr. D.N. Sharma sir, Executive Director and CEO, AIMS Vijaypur, to please address the gathering.
Since morning, I realized that the program is very tight and very busy. And I've also learned that the surgeon's time is very precious. So I'll be very brief and I will not take much time. Respected dignitaries on the dais and senior colleagues, senior surgeons in the audience, my faculty colleagues from the AIMS Delhi, esteemed faculty colleagues from AIMS Jammu, delegates, students, ladies and gentlemen, very good afternoon. I, as the director of AIMS Jammu, welcome you all to this scientific program. Thank you, Dr. Maria, for organizing this event and to entire team of surgical disciplines. Thank you, ASI and Jakasicon in particular for having faith in us that we can hold this program. So thank you once again for giving us this opportunity. Thank you entire organizing team for very efficiently organizing this event. And I'm sure next 2 days you will enjoy this program and you will have a comfortable stay. I'm aware that the surgeon's contribution to the medical science, since I've been partly involved in the surgical treatments in my subject. I'm an oncologist, radiation oncologist precisely. I wanted to become a surgeon. I did my house open surgery, but I narrowly missed surgery, so I couldn't become a surgeon. But I always, I always feel that yes, I should have become a surgeon like you. And when I joined the radiation oncology, because when I didn't get the surgery, so I joined AIMS Delhi in 1994, and I had that frustration of not being a surgeon. So I tried to extract that surgical portion from my subject of radiotherapy, because we have a small component of surgical acumen in the radiotherapy called brachytherapy. So I tried to extract that solace in that brachytherapy, which is the surgical component, and try to develop it also. I learned the technique of brachytherapy from many centers worldwide, principally the Ohio State University in USA, and then Harvard Medical School. So I had 2 trainings, and then I tried to develop that subject. This subject was not very well developed in India, so I tried to change that practice of that brachytherapy in our country. When I joined AIMS Delhi, my mentor realized that I had that surgical nag in me, and he realized that I had some surgical traits in me. So once in a party told me, D.N. Sharma, if you want to become a good brachytherapist, you have to behave like a surgeon. So I asked him, sir, what do you mean by that? He said, to behave like a surgeon means you have to talk like a surgeon, you have to walk like a surgeon, you have to eat like a surgeon, and you have to drink like a surgeon. So I did not take the last component very seriously, and probably that's the reason I couldn't become a surgeon. But anyway, I had the pleasure of working with some of the stalwarts of surgery at AIMS Delhi, and half of my growth as a professional is because of my good surgical backup from the surgical departments. Dr. Sinu, my senior colleague, is here. Dr. Anita Dhari is here. I worked several times. We did the brachytherapy of the breast together, sarcomas, and other sites, And I learned many things from them. So thank you very much for Dr. Anita and Dr. Sinu, sir. And I had other colleagues as well in AIMS Delhi who helped me in developing this subject, because this was a subject which was not very well developed in our country. So I realized that how important the surgical training in my subject is, and therefore I always try to disseminate that surgical aspect of the radiotherapy to my community. Our community is developing and catching this subject a little faster now. So just to cut the story short, I'm always thankful and grateful to the Surgical Society for helping me out in my professional career. I'm also grateful to some of the senior surgeons who are sitting here, and I'm really impressed that even at this age, their interest in enthusiasm has not died down. So I salute you, sir. It's really thankful to see you. I'm sure next 2 days you'll enjoy the program, and if there's some shortcomings, please forgive us. We are a new institute, we are just like 2 years old in terms of clinicals. So our team is very dedicated, our Dr. Maria and her team. It's a very dedicated, very young team. So I'm really thankful to them for organizing this event, of course with the support of the Jakasi and ASI. And I hope you have a comfortable stay for the next 2 days and you enjoy the center as well. Thank you once again.
Thank you, sir. Sir has been an inspiration, a guidance, and a rock for us throughout the planning of the conference. So thank you again, sir, once more. I now introduce Professor Dr. Maluthu Pandian, sir, President, Association Surgeons of India. Sir is currently serving as Dean, Government Rajaji Hospital and Madurai Medical College, Madurai. Sir has served in Tamil Nadu and Puducherry chapter of ASI in various capacities and positions for past 16 years. Under his leadership, Tamil Nadu and Puducherry chapter won the Best Chapter Award for the year 2016. Sir has served as Honorary Secretary of Indian Association of Endocrine Surgeons for 4 years and won the Best Section Award for 3 times continuously. It is my honor and privilege to invite him to address the gathering.
Good morning to you all. Respected guests of honor and director of this institute, Dr. Sharma ji, the honorary treasurer, one of the honest treasurer, and my close associate, Dr. Madhumita ma'am, the chairman of Jammu Kashmir chapter of ASI, Dr. Ajaz, sir, and Secretary Jakasi, my good friend Dr. Aminder Singh, the organizing chairperson, Dr. Kapoor madam, and the organizing secretary, Dr. Varun, and the founder, chairman of this Jakasi, Dr. Chaudhary sir, and National Executive Committee member, Dr. Sanjay Basin, my good friends in endocrine surgery and faculties here, Dr. Anitha, Dr. Jas Malik sir, senior members, colleagues, and my dear students. At the outset, I should congratulate the Jakasi and the Department of Surgery, AIMS Jaipur, for having invited me to this conference. First of all, I should say a few words about the director. I appreciate his academic interest. I have gone through his throughout his lecture on his topic. I was sitting there. Many of the administrators, many a time they'll be sitting in the chamber and doing all administrative work, and I could see him as a pure academician getting this post. Thank you, sir. And Jakasi organizing team. Many a time the organizing chairman will be a male person, but the Jakasi has entrusted the job of organizing chairman to madam, who has done excellently in selecting the venue. I have gone through the entire scientific content. Everything is nicely organized. I should congratulate the organizing team. And as far as National ASI is concerned, as Madam Madhumita said, we have got more than 40,000 members in our fold. The main objectives of our association is, first is academic one, mainly for junior colleagues and young postgraduate students. I am so happy the regional referral course, RRC, which will select the top 12 candidates, postgraduate students in India by a 4-stage test. First 2 online examination and 3rd and 4th is physical clinical examination test, wherein 12 candidates will be selected and they will be awarded not only with the cash award but also having the chance of visiting the international surgical societies. And many a time I could see the northern states and northeast states students are performing well, and for the past 2 or 3 years I could see them achieving that best student in India. So I should again congratulate the Jammu Kashmir team for stimulating their students to participate in this RRC program. Likewise, we are now conducting this ASI time weekly, once every Wednesday between 9 to 10 p.m. With the experts sharing their knowledge, how they are doing their simple procedures. For example, even small circumcision, all must be knowing that it should be done with the use of bipolar diathermy. Monopolar diathermy should not be used. I don't know how many of you are agreeing with me. That sort of small skill training will be shared by the experts during the ASI time. So we have got an endoscopic training program again for younger colleagues, mainly for postgraduate students. In the headquarters Chennai, we have, with the help of Olympus people, we have got an endoscopic simulation training center. Again, it's a 3-stage program. First online exam, because students will be selected. They will undergo 1 or 2 days training in simulation center at headquarters Chennai, and then they will visit the Center of Excellence, who are doing more than 20 or 25 cases per day. So like this, there are a lot of academic programs are designed by ASI for the students as well as younger colleagues. So in addition to this year I have formulated, with the help of our Vice President Dr. Parathyroid, a few more new initiatives, like uploading some of the surgical videos in our website, as well as module development for some of the commonly done surgical procedures, like safe cholecystectomy, safe appendicectomy. We have formed a committee under our academic director, Dr. Rajagopal Senai, wherein the module will be prepared and it will be presented to all the state chapters and sections, which will again be propagated to all the younger colleagues. Likewise, this year, many of our surgeons forget their own health. So to remind them to take care of their health, a new initiative in the form of Healthy Surgeon, Healthy Nation, wherein small exercises, how to keep their mental strength and physical strength, and how to improve their social connectivity with other people. We have designed one framework for that initiative, which will be again sent to the state chapters. I request the state chapter office bearers to implement in their region. So like this, social welfare activities are also going on well. We are conducting many free surgical camps. I used to go regularly every year with my friends from Madurai to one of the places near Dehradun. Annually, there will be a free surgical camp. I used to go there, stay there for 4 to 5 days and operate 30 to 40 cases there, and then return back to my place. So such free surgical camps are being regularly conducted by our national ASI, like that free medical camps and blood donation camps, which are all going on regularly. And this year, as a new initiative, we have started this tree plantation program. Thanks to Dr. Julie, the treasurer of this organizing team, for having arranged for my request quickly for that tree plantation program, which we are going to have after this inauguration program. And my request to younger colleagues, postgraduate students, of late I could see many of you are neglecting the part of clinical examination of the patients. So I was really upset, because many of the students, even in my place also, they are treating only the paper, not interested in seeing the patients. That should be continued. Clinical examination is the first way of treating the patient, which you should never forget that. Then only your investigation, everything comes. For example, I did one small papilloma for a patient, a 40-year-old lady, under local anesthesia. She was daycare surgery only. But for that patient, when I was giving that advice of discharge, antibiotics, analgesic, everything, in my absence, one of the junior colleagues who went there and saw the report of that patient, in that urine deposit pus cells 4 to 5. He noticed 5 pus cell is big disease in the renal system. Started writing all urine culture, ultrasound abdomen, CT, everything. So without asking any question to the patient, whether you have got any urinary symptoms like body micturition or hematuria or fever, nothing was asked. Just seeing the pus cell one is getting increased, he started writing all investigation. That sort of attitude should not be there. That is my humble request to the young postgraduates. Be ethical, be honest. I was amazed to see the word patient first in your institution. That was really catchy. You must always be. So I always, for the past 35 years, I'll be always for the patient only. See, even I will give my phone number. I don't want them not to get disturbed by them and all. I always give them my phone number. I will communicate them very freely. So that sort of attitude should be there. That's why that catchy word still remember in my heart for the patient, and patient is the first. So like this, academic as well as social welfare programs are being conducted regularly. I request the Jammu Kashmir chapter of ASI executive committee members and the organizing team, everybody to implement all our new projects that are getting initiated. And with these few words, once again, I congratulate the organizing team and the Jammu Kashmir chapter of ASI for having arranged such a nice ambience. Really amazed. Such a huge residential complex on that side, and I have seen many aims. Even in Madurai, it is now being constructed, but I don't think such a huge complex is anywhere in India. So with this few words, once again, I congratulate the entire team. Thank you for the invitation. Long live ASI. Thank you.
Thank you, sir, for reminding us that patient first is the phrase to remember whenever we are in the clinics, and also reminding us to take care of our own health along with taking care of the patients. Thank you, sir. Without your blessings, the conference would never have seen the light of the day. I would now request Dr. D.N. Sharma, sir, to please felicitate our chief guest.
I now request Professor Murthu Pandyan, sir, to felicitate our director, Professor D.N. Sharma, sir.
I now request Dr. Pandyan, sir, and Dr. D.N. Sharma, sir, to felicitate Dr. Madhumita, ma'am.
I now request Professor Murthu Pandyan, sir, Professor D.N. Sharma, sir, Professor Madhumita, ma'am, to felicitate Chairman Jakasicon, Professor Ejaz Ahmed Rathod, sir. I request all our dignitaries to kindly felicitate Professor Dr. Harvinder Singh Bali, sir.
I request the esteemed dignitaries to felicitate the organizing chairperson, Dr. Maria Kapoor ma'am, and organizing secretary of the conference, Dr. Varun Dogra sir. Sir, ma'am, please be seated. I now invite Dr. Dogra sir to please give a vote of thanks.
Good afternoon to all of you, respected dignitaries on the dais, our Honorable Chief Guest, Professor Dr. Maruthu Panjan, President of ASI, our guest of honor from ASI, Professor Dr. Madhumita Mukhopadhyay, a guest of honor from our own AIMS visit to Jammu, Professor Dr. D.N. Sharma sir, our Director and CEO, Chairman of Jakasi, Professor Dr. Ejaz Ahmed Rathar sir, Honorary Secretary Jakasi, Dr. Harvinder Singh Bali, and my organizing chairperson, Dr. Maria Kapoor. Dignitaries of the dais, all the deans and associate deans, all the office bearers of Jakasi, executive members of Jakasi, distinguished faculty, delegates, ladies and gentlemen, a very good afternoon to all of you. On behalf of the organizing committee, it gives me immense pleasure and privilege to propose this votes of thanks on this memorable academic event. At the outset, I express my deepest gratitude to our Honorable Director, sir, for not just gracing the event, but also becoming a part of this scientific extravaganza. Sir, your guidance has been instrumental in success of this Jakasicon 2026. I would extend special thanks to our President of ASI, Professor Dr. Maruthu Panjan, for graciously accepting our invitation and for being present with us today. Sir, your inspiring presence has added immense prestige to this conference, and your words of encouragement will continue to motivate us for days ahead. I also extend our sincere thanks to our guest of honor today, Dr. Madhumita Mukhopadhyay, for joining us and enriching this occasion with her presence. Ma'am, we are truly honored by your support and your good wishes, ma'am. We are also deeply grateful to the entire team of Jakasi, all the office bearers of Jakasi, the GC members, the EC members, for their valuable guidance and encouragement. Thank you to all of you. My special token of gratitude to my family at home, my mother, my wife, my father, whom I lost 3 years back to an MI, my family at work, my department of general surgery, including our head, our faculty, our residents, our nursing team, and all my staff. Without their support, this event might not have seen the light of the day. Truly, thank you to all of you. I convey my heartfelt appreciation to all the distinguished faculty, speakers, moderators, chairpersons, and panelists who will be sharing their knowledge, expertise, and valuable insight throughout this conference. Your academic contribution have made and will make Jakasicon 2026 scientifically enriching and immensely rewarding for all participants. I thank all the delegates, residents, postgraduate students, and participants for their enthusiastic involvement throughout questions, thoughtful questions, and active participation. Your energy and engagement will make this scientific conference meaningful. My sincere thanks goes to the organizing committee, scientific committee, faculty coordinators, volunteers, intern doctors, media team, IT team, security staff, transport and accommodation committee, guest house support team, convention center support team, and other support staff whose tireless efforts, dedication, and teamwork ensured a smooth conduct of this conference. What we see today is the result of countless hours of planning, coordination, and commitment by a wonderful team. I would also like to thank our sponsors, partners, our well-wishers for their generous support and cooperation, without which this event would not have been possible. Last but not the least, I express my gratitude to the hospital administration and institutional leadership for their constant encouragement and support in hosting Jakasicon 2026. If I missed anybody, I am extremely sorry. I hope I have not missed anybody, but I thank all of you in whatever form you're associated with us. I thank each and everybody. Thank you very much.
Now I request you all to stand for national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
We will now break for lunch. I request everyone to head to the dining area. Coloproctology workshop will begin at 2 p.m. and Hall C. Thank you.
On the stage for a group photograph. Kushal sir, sir, आप
Sir, smile, sir.
Cameraman smile.
स्कूल बैग ये ना अब मैं 2 घंटे कैंडिडेट सबमिट कर दूंगी तो बाकी जस्ट उस बैंक ना किसी में भी रह सकती है एक बार जो सामान निकालो ना इमीडिएटली जस्ट उसका दूसरे आ जाए नहीं वो भीड़ होती नहीं है
So check it.
हाँ उसी गली जाओ उसको ज़्यादा आगे नहीं जाना मैं उसको आगे नहीं जाना उसी गली में चाहिए मैं कॉलेज कर हाँ उसी उस दिन हम वाले हाँ हाँ मैं याद अंदर उसी टेबल में
आ जाएंगे।
आराम से बैठते हैं बैठना है इसी बिल्डिंग में गोल गोल की तरह नहीं एक बार इसमें देखो कि चल रहा है हाँ यार ब्रेक का टाइम
We again welcome you all with renewed energy and enthusiasm. Now we'll be starting the session 3 of scientific proceedings. For this, may I have the honor to invite our esteemed chairpersons for this session, Professor Dr. Ejaz Ahmed Rathwis, sir. Sir is Professor and Head, Department of General Surgery, SKIMS Medical College, Bemina. Professor Dr. Raj Rishi, sir. Sir is former Professor and Head, Department of General Surgery, GMC Kathua. Professor Dr. Neeraj Kaul, ma'am. Ma'am is Professor, Department of General Surgery, Sri Mata Vaishno Devi University. Dr. Shyam Gupta, sir. Sir is Assistant Professor, Department of General Surgery, GMC Jammu. Dr. Gulzar Ahmed Bhatt, sir. Sir is Consultant General Surgeon, Department of Health.
Good afternoon, everybody. I welcome all to the second session, post-lunch session. And now we have next speaker will be Dr. Sushan Suran, who will be, on behalf of Professor Asori, will be discussing on robotic surgery, robotics in general surgery. So, Dr. Sushan. Good afternoon, everyone. First of all, I'd like to thank the organizing committee of Jakasicon 2026 for inviting me here to present the topic. So I'll be discussing the role of robotics in general surgery. So for the past 20-30 years, laparoscopy is the main armamentarium of a general surgeon, but with good comes some bad, and laparoscopy definitely has some limitations, being limited range of motion, 2D vision, highly trained assistant is required, and definitely a long learning curve. So for innovation, the robot came into picture, and since its inception, the Da Vinci system, it has evolved from Da Vinci to Da Vinci S, then SI, then XI, And then currently the latest is Intuitive Da Vinci System 5. So what robot offers to the patient and the surgeon? To the surgeon, it offers enhanced precision, flexibility, controlled movements during the operation, easy access to hard areas like the upper GI or the pelvis, better visualization, 3D vision, and increased range of motion, less fatigue and discomfort compared to laparoscopic surgery. For the patient, it has got reduced risk of infection because mainly of standardization of sterilization procedures, minimal scarring, reduced discomfort and pain, shorter hospitalization, reduced blood loss and transfusions, and faster recovery and return to activities. So I'll be briefly covering the spectrum of surgeries, what we have done in AIIMS Delhi in the past couple of years, be it colorectal, hernia, hepatobiliary, bariatric foregut, adrenal and endocrine, and gastrointestinal solid organ dissections. So I'll be going through video presentations. So this is a video of an inguinal hernia where we did a TAPP procedure. As you can see, what we are seeing here is basically a 2D vision. But trust me, the surgeon sitting in the console sees that in 3D, and sometimes the dissection is so easy and so fast that we hardly require even energy devices sometimes. So as you can see, the flap is taken down, the pseudosac is being pushed, the medial dissection is getting completed with the use of blunt and sharp dissection. This is the dissection of the cord structures. The peritoneum is being pushed down to place the mesh. The radius and the Bogro space is dissected out. Further, the lateral dissection is being completed. This is the vas being dissected. As you can see, the cord structures, the 3D mesh is being placed. Sometimes we do fix the mesh, sometimes we don't, depending on the surgeon's preference. This is the mesh being placed with adequate medial cover. Here we are fixing the mesh. And finally, the closure of the flap. The greatest advantage which I feel is the endosuturing with the robotic system, because the range of motion, the degree of freedom it provides really makes the suturing easy. So another case, this is a case of a primary ventral hernia. What we did was a Taruk. We took a lateral approach, reduced the contents, and marked the incision site for a lateral entry in the rectorectal space, taking down the peritoneal and posterior rectus sheath complex, reaching up to the midline. Once the midline is reached, through the upper end, we do a crossover because the linea is, fat is there. So once the crossover is complete, adequate dissection is complete, and the opposite side dissection is complete, we close the defects of the anterior rectus sheath, and then the peritoneum. As you can see, we are closing the peritoneum now, and then finally placement of adequate sized mesh and closure of the flap. We had a fair bit of share in terms of bariatric surgeries also. The robotic platforms provides specific advantage to the surgeon and to the patient also, because the abdominal wall is thick, the surgeon fatigue is quite less, and definitely this leads to lesser pain to the patient also. So following the surgical principles, gastrolysis is being done, the greater curvature is fully mobilized using a vessel sealer, as you can see, up to the fundus. Once the gastrolysis is complete, we insert a bougie. Very quickly mark the conduit, you can see the bougie being inserted. And this robotic platform, Da Vinci Xi, is AI enabled. So this is the first stapler. It is the green stapler we are using because the tissues are thick. If we are using other size stapler, it might not fire. Subsequently, the other further staplers are the blue sized cartridges. Once the sleeve resection is complete, we look for leak and hemostasis. So we had done few front duplications also. So surgical principles being the same: gastrolysis, mobilization of the greater curvature and fundus using a vessel sealer. We can use 3 arms with the 1 assistant laparoscopic port, or even 4 robotic arms. So the pars flaccida is opened, the right and left crus are being dissected and freed. Care is taken not to enter the pleura and not to injure the vagus nerves. So once the pleura is freed, we are doing the posterior chloroplasty using simple silk sutures. Care is taken not to make the chloroplasty too tight, leading to post-operative dysphagia. Once this part is complete and the adequate mobilization of around 5 centimeters of the esophagus is done, wrapping is being completed. The wrap should fall on the esophagus, not on the fundus. That care has to be taken. And to prevent wrap migration, at the last we fix the wrap with the crura. As you can see, we're fixing it here. So suturing is really easy with robotic systems. So for resident training, also we are doing robotic cholecystectomies. The benefit we have is clearer dissection sometimes, and the vessel sealer is so good we can sometimes take down the cystic artery without using any clips. Hemolock is being placed and the dissection is complete. We also perform some radical cholecystectomies for malignancies. So you can see there is some adhesion with the gallbladder, but if you enter the right plane with the 3D vision, the dissection is very clear and bloodless. So adhesiolasis is being done.
Dr. Shah, can you conclude, please? Time is over.
So we have done a few radical cholecystectomies, and upper GI surgeries also we did, like proximal gastrectomies, thoromobilization, taking down the lymph node, following the surgical principles, oncology clearance is being done. And finally, the resection is done. Similarly, we did some total gastrectomies with reconstruction also robotically. Whipples also we did, surgical principles being the same: mobilization of the stomach, duodenum cauterization. As you can see, taking down the vessels and creating a retropancreatic tunnel. Then dissecting the hepatoduodenal ligament, deletion of CVD, resection of the stomach, taking down the GDA, and finally we did the choledoco hepaticojejunostomy robotically and further reconstruction by a mini laparotomy. We did some lateral pancreaticojejunostomies also using endoscopic ultrasound in double layer fashion. Some colorectal procedures like APR and rectopexies. The advantage is the excellent visualization of the dissection plane, so preventing the hypogastric and pelvic nerves, taking down the vessels, the rectopexy. Again, dissection is very clean and clear. Mobilization of the rectum and placement of the mesh. We did some adrenals also. This was a case of myelolipoma. Lateral inferior superior dissection being done first, and at the last, the adrenal vein is being clipped and the specimen is retrieved.
Thank you.
Thank you, Dr. Sushant, for your wonderful presentation. I think we'll take the questions at the end of the session. So I invite next speaker who does not need any introduction. He has been the teacher of teachers, my teacher also. In 1987, he has taught me surgery when I did not know ABC about the surgery, none other than Professor R.K. Chungu. He's one of the pioneer surgeons of laparoscopic hernia repair in the state. Dr. Chungu, sir.
Good afternoon. In this post-season session, I don't have a scintillating presentation. I just have a humble presentation to make, one about a hernia, inguinal hernia. We all know that inguinal hernia constitutes 75% of all hernias of the abdominal wall, and about 1/4 of men in their lifetime will have a disposition to develop an inguinal hernia, less common in females. And world over, this is one of the top 3 surgeries done globally, and around 20 million groin hernias are repaired annually all over. Surgical techniques now have rapidly evolved ever since Bassani, Edward Bassani, proposed his first successful reconstruction of the inguinal floor. But there are still reports people go to do other surgery. They operate in open, they do open surgical repair. And I want to take your attention to one of the recently developed, does this work? Sorry. One of the latest 2025 paper, which says that despite significant progress, no universally superior technique exists, and therefore need for alternative techniques. This hernia has been known from times antiquity, and the treatment was based on 2 things only: the swelling and its complications. And Hippocrates coined the word hernias for it. Over several centuries, so the knowledge of the anatomy and other structures of inguinal canal and around it paved way for, including the one with, I need to mention, the famous English surgeon, Dr. Ashley Cooper, who introduced the pectineal ligament, named after him, and the transversus fascia. The importance of both of these paved way for further modification of earlier techniques, which were very vague. Initially, there was one Marcy repair, which was done in only children. The closure of the internal ring was there. But the first definitive surgery was done by, or put forth by, Eduardo Bassani in 1890. And this, he thought, is the final in the surgery of inguinal hernias. Half a century later, Earl Schultes developed his method of these were basically ligamentomuscular repairs. Same person, he modified, the earlier was a single layer, this was a 4-layer repair, and had very good results in so far as complication and the recurrence was concerned. So another repair after this, soon after this came into being, known as Cooper's hernia repair or McVeigh's hernia repair. Main aim in these all hernia repairs, tissue repairs, was herniatomy, herniorrhaphy, hernioplasty, etc. So Bassani's and Schultes, they were the best repairs till this time, and the Schultes repair was claimed to be the best. These techniques, the tissue repairs, use sutures and develop because of a ligamentofacial form of repair. Repair done was under tension. This led to high scarring and therefore recurrences. And this gave rise to the next concept, the concept of tension-free repair. And this tension-free repair concept gets a breakthrough in 1994 with Irving Lichtenstein realizing tension-free repair by realizing prosthetic material bridged between the inguinal ligament and the muscular portion, and we overlapped the inguinal extra-inguinal epidural over it. The Lichtenstein technique with the only placement of flat mesh is still the standard type of treatment in open hernia repair. However, the anatomically Lichtenstein method was placing the mesh on wrong side, like the problem was here, while as the actual problem was in the preperitoneal space, in the peritoneum, and we were all suturing or placing mesh here. So actually, the mesh was needed to be placed here. We are placing the mesh here. So affixing the mesh behind the parietal defect in the preperitoneal space, therefore, was the only way of ensuring intra-abdominal pressure to keep it in the required position, even when it was not fixed. We go by Laplace's law. So subsequently, some further repairs were introduced, like the one which was conceptualized by Lichtenstein himself in 1968 and popularized by Rutkov and Robbins. This was a patch and plug technique in which the hernial sac was reduced and a plug of the prosthesis was put inside. In fact, we still do if somebody wants to get it done. And the rest of this all repair was the way we did the Lichtenstein's repair. The another repair was introduced by Gilbert. This was a PPH, Prolian hernia system, PPS, which envisaged placing of dual mesh, bilayer mesh, in which it had two components. One, the superficial one, which will remain in where Lichtenstein placed his mesh, and the lower one, smaller circular one, which will go in the preperitoneal space, connected by a connector. We would cut this connector and let the cord structures come out through that wound. This is exactly what it looked like. This is the deeper part in the preperitoneal space, and this was the Lichtenstein placement of the mesh here. We visited this place and got trained in this, and we were using it for quite some time. Now, all preperitoneal spaces, anterior approach, in the way they did in preperitoneal abdominal, transabdominal, most of the open hernias preperitoneal were done through the abdominal wall, or posteriorly the anterior one was either put transinguinal or extrainguinal. Transinguinal, we used to open the inguinal ligament, place the mesh, stitch the mesh, while in the extrainguinal place situation, what we did is we made a small incision besides the inguinal canal, not invading the inguinal canal, went into this space, preperitoneal space, and placed a special mesh which would expand and become a stay in the place. So the other one was the posterior approach. This was done in large hernias. I think two more minutes. So in that posterior approach, we opened the abdomen, remained preperitoneal. We did not open the peritoneum and placed a large mesh, the Stopa technique, and placed a mesh in front of behind the pubic bone. So now the open mesh methods were Lichtenstein, preperitoneal, combined, and GPRs. But the problem with these meshes was that we used to invade the inguinal canal or go anteriorly. We would go through the abdominal wall. So one more thing here, we established at this time that the mesh, placement of mesh is important, and mesh decreases the complications as well as particularly recurrences. So it was divine that accidentally there's one girl who in 1982 stumbled on an inguinal hernia while doing laparoscopy for some other purpose, and in which this thing gave rise to the development of a transabdominal preperitoneal tap, which was discovered by or introduced by Arabi in 1982, and Furzel is TEP, which is transabdominal, extraperitoneal recurrent. Is same as what we did in Kugel's lateral to inguinal wall. We went into the thing. Basically, when we do laparoscopic surgery, we have to take care of five triangles in the inguinal region. The direct triangle, the indirect triangle, the femoral triangle. Actually, this, when we sit in the abdomen within the abdomen, and I'll take just 2 minutes. I'll see. This, we said this is anterior abdominal wall seen from inside. So we have to ensure in all laparoscopic procedures that we cover the Frischard's space, which is bounded medially by the lateral border of rectus, inferiorly by the Cooper's ligament, laterally by the iliopsoas, and above by the curved fibers of internal oblique and transversus abdominis. This is the first field of a transab tap. This is what we should understand in a tap. Recognize inverted Y, and go ahead with, like, this will be a direct hernia, and then, so there was a little controversy about whether to do tap or tap. Tap, people said that it's easier to learn and you can see the other side at the same time. But if a operating team is fine and you have the facilities available, you can do tap or tap. The idea is that the tap, the processes should stay in place, and it should not get folded below, especially, or any other side. It should fit nicely. This is Professor Wittner, the conceptualized proponent of TAP, having done more than 13,000 taps at the time of this photograph. And now we have LAP ETAP, extended view tap. The principle of this step is that the preperitoneal space can be reached from virtually anywhere in the anterior abdominal wall, and preperitoneal space in the lower abdomen is continuous with the rectorectus space as an tap. So then there was another controversy which is going on still, whether to do the open or lap. Consider the postoperative pain, recovery speed, and the chronic pain, laparoscopic procedures are best. But one has to see the other things, like when the surgeon has sufficient experience in their respective technique, laparoscopic and Lichtenstein techniques have comparable results. About 75 to 80% in some Western countries do only open techniques, open hernia repairs, because of two things: financial problems, and because the reimbursement in government hospitals is not done. And then there are few reports that the laparoscopic and Lichtenstein repairs are same, comparable. And we have a recent publication from our own institute, wherein it has been established that the Lichtenstein tap are almost similar. One last thing that I want to emphasize upon is that the subsequent failure of repairs is much dependent upon other things like obesity, smoking. Everybody knows it, but surgeon is the biggest factor in avoiding the recurrences, particularly. So it has been seen in a large longitudinal cohort study that it is easy to develop. That's how I said, this is the last one. It's easy to develop learn and develop and get less complications in an open hernia than when a hernial surgeon, the endoscopic surgeon, doesn't have enough experience. More the experience, lesser the problem. Then we have the robotic surgery now again, we go to the last slide, that is the best repair is the one which works best in the hands of a surgeon. One should not be egoist that I know everything and I can do anything. When the first successful surgery on this was done by Eduardo Bessini, so he warned every surgeon not to go beyond his method of repair because he said that his repair was the best. And ever since, after that, after 4 years before today, 15,000 publications appeared in PubMed on even hernia alone. And only future will tell what we have in store for hernia. Thank you.
Thank you, Dr. Chandu. It has always been an honor where your teachers like Dr. Changu, Dr. Pathania are speakers and I am their student chairing the session. Our next speaker is Dr. Professor B.S. Pathania. His topic is tips and tricks for performing IPOM Plus. Welcome, sir.
First, I extend my congratulations, gratitude to the organizing chairperson and the entire team for executing this conference seamless and academically enhancing. And I feel honored to be part of it. Now, these times, you must be seeing that boundaries of operations are being pushed by innovations. And many frontiers are coming. But the most important thing is, before we adopt these methods, the fundamental factor should be safety. So I'm going to tell you how to perform safe IPOM Plus in my talk. If you see this slide, there are so many methods of doing ventral hernia, intraperitoneal, extraperitoneal. But you should be doing this repair according to indication, patient needs, and you should be able to convert from one method to the other. And all these methods which I have shown you, at least you should know 80 to 90% of the method. Now, all these methods, 6 principles we follow. So basically, we are closing the defect, we are using larger mesh, we are using less fixation, we are using subplate placement of, and minimal invasive technique is preferred. At least you should also optimize all the pre-operative conditions so that you have a good outcome. Now, IPOM Plus, there are so many methods which have come to repair. IPOM Plus has sets a benchmark for reliability, durability, and can be picked up by any surgeon because it is easily reproducible. So, but it is best suited for 5 to 7, even 8 centimeter, depending upon compliance of abdominal. The circumstances there are circumstances even in ETAP that you have to convert. Suppose there are a lot of regions, your space is not existing, retrorectus. You have no other method other than IPOM Plus. Secondly, if you have a tear in the posterior rectus sheath and you can't suture it, the method left is IPOM Plus. And of course, when you have a complication, even in ETAP, you have to convert to IPOM Plus. And then, of course, if patient has a lot of risky problems, so you have to finish the hernia fast, IPOM Plus comes to your rescue. But there are certain contraindications, larger defects, and all those which have been depicted on the slide. The message that I want to convey to you is, please don't treat ventral hernia primary and incisional. They are entirely different. In incisional hernia, you have to cover the whole incision 5 centimeter on either side of incision, the mesh, the larger meshes are required. You don't treat incision hernia as a primary hernia. And you have to be very, very careful in incision hernia as well as the adhesiolisis, and related complaints are bound to occur in incision hernia rather than primary ventral hernia. So there are reasons for covering the whole scar, because if you cover only one defect and leave the scar, patient will come back to you with recurrence, because it is a scar which is defective. So you cover the whole scar. There are many references, and there is one reference in our study also in PubMed we have published, and they said you must cover on either side of scar, the whole. Preoperative, selected patients, smaller defects, you do CT, because CT or MRI, whatever, you know the defect, you know the contents, you know the adhesions, so you are wise enough with this investigation. And risk factors have to be optimized, whether it's diabetes, immunosuppression, or hypertension, those have to be taken care of. Of course, smoking and obesity has to be taken care of. And these are the usual set. Laparoscopic set is required. You might require for transabdominal fixation epidural needle or a suture passer. And of course, the energy source is always harmonic, because we don't use monopolar cautery. And it is always done under general anesthesia. The patient remains supine position with the arms tucked on the either side. And depending upon location, there are difficult, the assistant and surgeon, depending upon location of the hernia, they stand on the side of the patient. And this is the position which we give. Assess to abdomen. Now there are many methods of assessing inside the abdomen. You can use a closed method, very needle. You can use open method. You can use optical entry. It all depends upon whatever the facility or the expertise you have. Port placement you always do in such a way that the distance between them is 10 to 15 centimeter. You always maintain triangulation, and you should have a good ergonomic access. Now, when you are putting port, please see to it that you don't injure the epigastric vessels and their branches. So you have to be 5 to 7 centimeter away from the midline so that you walk. Now, the most important thing is adhesiolisis. This is the step which is the most important step. And there are many maneuvers which will help in adhesiolisis. If you are facing upper, then you have to remove the falciform ligament. If you are down, you may have to remove the umbilical ligament depending upon location of hernia. Pressure on the abdominal wall by the assistant will help surgeon in adhesiolisis. You should do sharp dissection with scissor, avoid. And if you have to use energy source, use bipolar or use harmonic. Don't use monopolar cautery to avoid injury. And you should remain, when you are doing adhesiolisis, please start from a virgin area. From the interior abdominal wall, go towards the defect. And then you should also know that working in a good ergonomic position is very important. So don't hesitate in putting additional trocars if required. And after you have done adhesiolisis, please don't forget to examine the gut during and after, so that you have not created any enterotomy. Now, if by chance there are difficult adhesiolisis, what to do? So what you have to do is you make a limited conversion, separate do adhesiolisis, and then go ahead with your other repair. And these are two hybrid methods. Either you do it afterwards putting a laparoscope, or you do it first and then enter with laparoscope. So to avoid, if by chance there is enterotomy, I'll just take 3 minutes more. So if there is anatomy, there's no contamination, you can put mesh. But if there is contamination, please don't push. Do primary closure and shift the putting the mesh after 2 to 3 weeks. So this is how you, if you have injured, remove the redundant fat from the defect, You can measure the defect. CT has guided you what is the size of the defect, but you can measure it on the table. Putting the instrument from inside and marking it outside is the better method. And then you have to close the defect. So if you close the defect, you can use these delayed absorbable suture, or you can use even barbed suture. And mesh is always composite mesh. The visceral side is covered, which disappears after some time. You can't use proning mesh, simple. So you have to use composite mesh. The all literature, clinical evidence, clinical trials, they say composite mesh, least deviations. So you have to cover the defect 5 to 7 centimeter. You have to take oversize because that will prevent migration of mesh in the beginning and later. The orientation of mesh is center or corner, and when you are putting mesh, please see to it that you change the gloves before you enter the mesh. And lightweight meshes up to 3 centimeter, 30 centimeter can be put through 10 to 12 trocar. And fixation of mesh, you can use tacks only, you can use tacks and suture, transabdominal suture, but literature says the least recurrence is 0.7% if you combine tacks and transabdominal sutures. So I will not touch this. So post-operative care, you have to take care of everything. And these are the pitfalls. Pain has to be avoided by suture pain, by not strangulating the tissue, just snugly, just tighten it snugly. Don't tighten it too often. So key benefits always there. Conclusions, they are supporting IPOM plus, and this is the small video. So this is the Palmer's point. Mostly we prefer this on the left side. You can use right side also, depending upon location of hernia. So after this, I come to diesel-lysis straight away. So the trocar triangulation. This is now diesel-lysis being taken care of. So my assistant is pushing from outside, and I'm using harmonic. And sometimes, even you can enlarge the defect. If there is problem in the diesel-lysis, you can enlarge the defect. And so after this is recurrent hernia, that's why you can see the suture there. So after you have done that, and see that if you want to keep tissue on the gut, keep tissue on the gut from the abdominal side, rather than going very near the. So this is being closed by PDS, delayed absorbable. So after you have closed, the needle can be retrieved by a loop made by an epidural needle, and we will take this in the loop and drivel the needle outside. Why this needle being? Because I have gone from outside inside, suture, and then bring it out. So now this is the orientation of the central orientation of the mesh, the composite mesh. So this is how you roll it from both sides, so it is easy to insert. So you push it through this thing, and then you put the mesh and fix it with tacks, absorbable tack, and transabdominal sutures. This is our own method of transfixing with the loop in epidural needle and the PDS suture in there. Thank you very much.
Thank you, sir, for simplifying such a tricky procedure. The next speaker is Professor Nazir Ahmed Wani. He will talk on IPOM and the management of recurrent incisional hernia. his experience at JMC.
Good afternoon, everybody. This is a topic which I have already presented in Jakasicon. So I'm sorry that the logo of Jakasicon to Calcutta is still lying there. So this is regarding management of recurrent incisional hernias. As you all know that any incisional hernia which has been done by open or laparoscopic surgery, whether you have put a mesh or not put a mesh, if it recurs, it is called a recurrent incisional hernia. So incidence is around 20%. If we follow these patients, 25% is the recurrence for after 5 years, and it increased to 10 years to 32%. So even if you follow grade A recommendations of these guidelines, European guidelines, using the mesh. So what are the technical challenges? These patients usually have, technically they are very difficult to repair because there is already a previous mesh, anatomically disturbed, and there are a lot of adhesions to the abdominal wall. So what is the choice for us in these patients? Choice depends on many factors. One is how much is the hernia size in the recurrence, what was the location of the hernia, type of previous repair, intra-abdominal adhesions, of course, patient comorbidities, surgical preference, and surgeon's preference is the most important one. That's why there is a selection bias. We don't have various RCTs to draw a clear-cut conclusion how to manage these patients. So what are the options left with us whilst we manage these patients? There are 4 options which are with us. One is either we can go for open only repair or lap IPOM plus. Second is we can go for open Real-Stopa, or we can go for ETAP, RS ETAP. Or another is laparoscopic subcutaneous only mesh repair. So always the trend is in the modern era that we should go for laparoscopic repair because it has definite advantages: minimal access surgery, decreased wound events, decreased post-operative pain, decreased hospital stay, and identification of previously undisclosed occult hernias which may have been the cause of the recurrence. So recommendation is that there are 2 recommendations from European Association of Endoscopic Surgery and European Hernia Society. One is to operate these patients if there is a previous mesh. You should not try to remove the mesh and then put another mesh. Keep that mesh there and go for surgery for putting another mesh. So once we go through the literature, we have very little literature available about management of these recurrent incisional hernias. Once we go through the literature, that we could see I could retrieve only 47 papers which are only the case series. We don't have any RCT or any retrospect or big study about this management of incisional hernias. So these are the few studies which you can see. Now you can see in the table, number of the cases is very few in these patients. No study, no case series has yet crossed 100 cases. There are just 60 cases, 70 cases. If we calculate the laparoscopic management of these hernias, whether previously you have done open or an IPOM, whatever you have done, we have seen that in laparoscopic management, the complication rate is quite high as compared to the open ones, because this incidence of bowel injury is very high, seroma formation is very high, by recurrence is also quite high, and the mesh, as you already know that we use composite mesh, PTF we can use, or you can use composite mesh. In case of open cases, again, you don't have much incidence of bowel injuries, and wound, of course, wound infection and thromboembolic events are more common in such patients in the recurrent phase. And mesh is, again, you can use proline mesh or you can use a composite mesh. So what is our experience in GMC Anantnag? From June 2023 to May 25, we did around 32 cases of ventral hernia we operated, out of which we had 8 cases of recurrent incisional hernias. Male-female ratio was same, 4 cases in each. Previous surgeries were open mesh hernioplasty was done in 5 patients with recurrence. IPOM was in 2 patients. Open suture repair was in 1 primary suture without this mesh, and median recurrence in these patients was 5.2 years. So this is the case series. The defect size right from 3 centimeters to 7 centimeters. Many patients were done by open surgery, and there were different surgeries right from cholecystectomy up to the radical prostatectomy in 1 patient. And we always followed these patients. Recurrence is right from 1 year to 11 years in these patients. 1 patient was where patient was operated 7 years back and had a recurrence. And follow-up is just from few months, 6 months to 2 years now. Median defect size was 4.5 centimeters. Mesh was composite mesh because we have available mesh in proceed mesh and Parathyroid mesh in our hospital, government hospital. Mesh size was 15 to 15 centimeters in 6 patients, and 2 patients with 20 to 20 centimeter mesh. Complications were seroma in 1 patient. Mean follow-up is 13.5 months, and recurrence till now there is no recurrence. Now coming to the complications, what are the causes of the recurrence? There are 3 main factors which we could see that is the cause of recurrence in these patients. Even if you do an open or you do a laparoscopic procedure previously. One is mesh bulge. If the defect is big, you are not properly covering it, mesh can bulge. So I wanted to show these 3. Second is that there can be displacement of the mesh. You are not put it properly and cover is not more than 4 to 5 centimeters on all sides. And third is that you may miss an open hernia and occult hernia, which can later be the cause of the recurrence. How to go through this video? Yes, it is not working. This is the mesh bulge patient, typical mesh bulge patient. You can see that after removing the adhesions, you could see the defect, a big defect. And once we see inside the defect, you see the mesh, you can see the impressions of the mesh inside. So you don't remove the mesh as per the recommendations. You will close the defect and then put a delicate mesh on this to cover the defect. Now this is mesh displacement. In this patient, we could see just after 1 year we operated this patient. There were previously it was said that composite meshes don't have adhesions. We could find adhesions there. Lot of adhesions, even if where previously it has composite mesh has been put in. You can see just the mesh is on one side and defect is other side. So we again we closed them properly and there was no recurrence. And this is the third one where you had multiple occult adhesions. It was a huge mesh which has been put 7 years back. We could see that contents were stomach, part of liver, and there were 2-3 small defects also. So conclusion is that laparoscopic repair of recurrent incisional hernias seems to be effective alternative to the conventional approach since it could result in lower recurrence and complication rates. When you have the high complication rates in repair of incisional hernia, the surgeon needs to be of high level of experience. That's very important. That point should go to our younger surgeons that you need an expertise to manage these patients. Then there are few limitations in such patients which everybody should know that there is a high complication rate of bowel injuries in the recurrent incisional hernias. One has to be really cautious that we should not cause a bowel injury, and seroma formation is very high. And this one should not try in patients who are morbidly obese and with large defects. Thank you very much.
Thank you, sir, for a wonderful presentation, and we always know that you are doing a wonderful job at BMC Anantnag. Thank you, sir.
So now our next speaker will be Dr. Aditya Kumar, and he will be talking on recent minimal invasive management strategies for divulgation of recti.
Good afternoon. I would like to thank the organizers of Jakasicon for inviting me to talk on the updates of minimal invasive surgical management for divarication. I bring greetings from AIMS New Delhi. So these are the various titles under which I'll be talking about the management of divarication. So what is divarication? It's basically a separation between two rectus muscles. It's common in postpartum individuals. It's a troublesome disease to have. And the main problem is the management is heterogeneous and there is no ideal treatment till date. So European Hernia Society recently defined divarication as a widening of the linea alba of more than 2 centimeters, which can be taken by clinical examination using fingers, and ideally 3 centimeters above the umbilicus. And they have classified divarication based on 3 factors. One is whether it's associated with pregnancy or adiposity, what is the interrectus distance, and whether there is a hernia or not. And this is important in deciding which type of management strategy to use. And a more detailed classification has been given by the German Hernia Society, which includes basically the same parameters. So it has largely been an ignored condition, and that is largely due to the fact that it was done through open approach, and it used to entail a large scar and a lot of dissection. So a study published from Netherlands surveyed 500 healthcare workers, out of which 78% of them encounter diastasis in their daily practice. It was surprising to note that 34% of the general surgeons said that it does not require treatment ever. And 34% of general surgeons also said that there is no good treatment available. And this is largely because most of the diastasis repairs were done through the open approach. However, if you see the patients who were surveyed, 80 to 90% of them did complain and did have problems of abdominal or girdle pain and cosmetic issues, and with around 10% of patients complaining of incontinence, whether urinary or fecal. So with the advent of minimal invasive surgery and the expertise developed over the years, a lot of interest has again regenerated in this field. And it shows that surgery does improve the symptoms that the patient comes with. So these are the various options available. Non-operative options include using the binder, kinesiotaping. Most importantly, it's physiotherapy and core strengthening exercises of the abdomen. And operative was previously, as I have said earlier, largely plication. And now with MAS, there are so many other techniques that have been tried, which I'll just go through briefly. Coming to surgical plication, this is how the open surgical plication used to be done. So a problem with this was that there were a lot of seroma, skin necrosis, surgical site infections that used to occur. And that is why people have largely tried to avoid this surgery in patients with diastasis. However, if you see that even this simple plication used to relieve patients of the pain that they would come to you with. And an alternative for this is doing it laparoscopically. So, this is a subcutaneous onlay aponeuroplasty, which basically replicates the plication, where you create space from the lower abdomen, just lift the subcutaneous tissue, as you can see in this video, from the rectus muscle. The idea is not to go too lateral, not to go beyond the linea semilunaris, so as to preserve the vascular supply of the skin to avoid skin necrosis. And once this soft tissue is lifted from one side, you cross over, go to the other side, and then you reach the. In this patient also had a hernia, a small hernia. Usually one would see that divarications are associated with small hernias. In this, you can see the white pearly layer is the rectus, and the pink tissue on the lateral aspect is the muscle. So the white segment is what the divarication is. And once you are able to lift all of the subcutaneous tissue, you can go on to open up the hernia sac. So this patient had an umbilical, through and through umbilical hernia. And we knew preoperatively that it was just preperitoneal fat which was herniating. So we are using energy there. Otherwise, you need to be careful to take the sac out first and then go on to the structure. So once the dissection has been carried out right from the lower aspect all the way up to the Ziphi sternum, one starts to repair the defect. A barbed suture or a non-absorbable suture or delayed absorbable suture can be used. So we use a delayed non-absorbable suture to close the defect, and then the plication is commenced with. So plication, as we do with open repair, is the same principle. Here we use a non-absorbable Prolene suture, and we usually use two sutures. One we start from subxiphoid to the midline, and the other is then taken from the arcuate line all the way up to the earlier where we finished the suture in the midline. So as to disperse tension, this is just to disperse the tension on the repair. Now, usually mesh is placed if the hernia is more than 1 centimeter, and that is in line with what the European Hernia Society recommendations are for ventral hernia. So this has largely reduced the major problems of seromas, surgical site infections, hematomas, skin necrosis. You just have 3 small incisions in the lower abdomen, and you are able to do a good plication. And this has been shown in various studies now that it has a nearly 0% conversion rate and very low complications, with seroma being the predominant complication associated. The other option, minimal invasive option, is the IPOM plus. So you have already seen videos of the IPOM plus being done. So I'll just show that once the defect is closed, intracorporeally, you can plicate the rectus. So you can see a wide divaricated rectus, which can be plicated using, again, delayed absorbable or non-absorbable sutures. And this patient had a recurrent incisional hernia as well. So once you do the repair, as you do with an IPOM plus, you can put in a mesh over it to reinforce the repair. So again, this procedure has also been described. This was described by a paper by Dr. Palanivellu from GEM Hospital, where he has called it the Venetian blinds technique. So it's basically the plication being done intraperitoneally. E-tape RS, you will see a lot of videos on E-tape RS. Again, same principle. You can go into the rotorectus space and do the same thing. So E-tape again you will see in further videos. So this is a review of the various minimal invasive repairs being compared with open repairs done for ventral hernia, and you can see that the rate of necrosis, skin necrosis and hematoma is nearly 3-4 times more with the open repairs. On the contrary, the seroma rates are higher with the laparoscopic. So the problematic complications have come down, and that is why now again there is so much interest. So coming to the guidelines, recently the European Hernia Society and the Swedish Society has come up with their guidelines, where when there is no hernia and only divarication, it is recommended that it should always be preceded with physiotherapy. At least 6 months of core strengthening exercises of the abdomen should be done, and it should be a shared decision whether to go ahead with surgery or not. And for postpartum women, one must wait for 6 to 12 months before and then proceed with core strengthening and then go ahead with any surgery that has to be done. So this is how similar, the last one was the European Hernia Society, this is the Swedish societies, and it's the same for both the guidelines. And when hernia is present, it becomes much simpler because you have to treat the hernia. So you go ahead with the guidelines as suggested with the Hernia Society. Thank you.
Thank you, Dr. Aditya, for the nice presentation. Now I'm going to call Dr. Kulwant Singh Bau. He's going to present on minimal invasive surgery for pediatric inguinal hernia, a paradigm shift. Dr. Kulwant Bau.
Good afternoon, chairpersons. Namaste to all. And a special pranam to my mentor, my guru in the audience, Professor Charangu. I don't know whether I'll be able to justify my topic in short span of 10 minutes, but I'll try to browse through all the slides as quick as possible. By definition, pediatric inguinal hernia, it's abnormal protrusion of abdominal contents through a defect in the inguinal canal in children. And congenital hydrocele, it's accumulation of fluid in the tunica vaginalis around the testis in children. And both these require some kind of intervention if congenital hydrocele is beyond 2 years of age. And pediatric inguinal hernia is a kind of semi-emergency, needs intervention at any age. Incidence-wise, overall, as high as 4.4% in the population. Males, they are more implicated than females, 3 to 10 times. Most commonly seen in premature infants, right-sided or more, and bilaterality is seen in 10%. Now, the journey of inguinal hernia surgery, especially in pediatrics, this surgery has been performed during ancient times also, some 1200 BC. And there is some evidence in the literature that some medical or surgical management of this entity is described during the era of Sushrata, which is compiled as Sushrata Samhita. And during the first century, a Roman surgeon Celsus, there are some records that he performed this surgery. But the modern inguinal hernia repair surgery, the open era, it dates during the early 19th century when the accurate anatomy and the dynamics of the inguinal canal, they were researched and widely studied and available. And during the same era in 1871, as stated by my guru also in his presentation, Marcy, he described a procedure known as high ligation of an unopened sac through the external ring with ligation of the sac at the deep ring. And this is one surgery which is still practiced by many pediatric surgeons around the globe. But what made the people resort to laparoscopy? If we go back in time, in the first surgery, laparoscopic surgery in pediatric surgery is credited to Stephen Gans in 1971. The term used was peritoneoscopy, when he successfully verified a contralateral inguinal hernia bypassing the endoscope through the open sac while performing an open surgery on the other side. But it was limited to this much only. But when Eric Muhe did the first laparoscopic cholecystectomy, a complete procedure in adults, that opened the doors for other allied departments also, including the pediatrics. And the first laparoscopic hernia repair in pediatric patient is credited to L. Gore in 1997. But due to the fear of injury to the vas and other vital structures of the spermatic cord, it was limited to females only. And after a few years, Monteport and SP2 performed the first laparoscopic hernia repair in males, a kind of IPSI where they incised the peritoneum around the deep inguinal ring and sutured it. And there were a number of procedures described, and notably here performed the intracorporeal Z suture closure, because chances of injuring the vas is high if you are taking all around the deep inguinal ring, a suture below the peritoneum around the inguinal ring. So surgeons modified this technique in their own ways with their own logic, which we will be discussing. But overall, the advantage is chances of detecting a contralateral PPV is very high, and chances of developing a contralateral hernia in a small child, because life expectancy of a small child is very high, and chances of hernia on the other side, if missed, they are high. One can find additional information also, additional entities, femorals or direct hernias or additional pathologies can be detected and corrected during the same sitting. There's reduced injury of vas deferens and cord structure because of the high magnification, everything is under vision. And other things like low wound rate, infection rate, less pain, and overall a better outcome. So many surgeons during the early 20th century, first and second decade, they compared open versus laparoscopic surgery, and with a better outcome and with positive results, inclining towards the laparoscopic approach. Over a period of time, many techniques they were evolved and further refined in different institutions, higher institutions. But after searching, extensively searching the literature, what I could make out for girls, intracorporeal approach is better, notably the laparoscopic inguinal hernia inversion and ligation of the sac, that is Lahel, and Bernia, that is a sutureless technique where cauterization of after eversion of the sac through the deep inguinal ring into the peritoneal cavity, the sac is cauterized and removed. It is not ligated, it's sutureless technique. And for both boys and girls, one can go with various intracorporeal and extracorporeal approaches. Among intracorporeal, there's a pus string suture using either 2 or 3 or proline, polypropylene suture or Vicryl or PDS. Then intracorporeal Z suture to avoid injury to the vas. An intracorporeal purse string with intracorporeal hydrodissection, because putting in fluid in that plane will lift the peritoneum up from the vas. So chances of injuring the vas during that encirclage is limited. And laparoscopic sac resection and peritoneal closure, but removing the sac has its own morbidity because extensive dissection is there. Then there is flip-flap technique where anterior and lateral peritoneum along the deep inguinal ring is incised and a flap is made and it is sutured on the medial side, thus blocking the ring, not closing it. It blocks it. And then came the intraperitoneal hernial sac division and purse string closure, that is IPSI. These were all intracorporeal. Now extracorporeal approaches are subcutaneous endoscopic assisted ligation seal where an incision is made in the one port is placed at umbilical region for telescope and another port for working instrument, and incision is made in the inguinal crease on the ipsilateral side of the lesion, and a suture is passed through it all around the deep inguinal ring and is taken out through the same defect in the inguinal region, and knots are tied subcutaneously extracorporeal. That is seal. And some people did it with sutures, others tried with steel using different kinds of inserting material like Reverdin needle, hook method, endo needle. Some have tried spinal needle. We have also tried peripheral intravenous catheter because it is cheap and easily available in our setup. Then came the laparoscopic assisted simple suture obliteration, that is lasso technique of inguinal hernia repair using epidural catheter with or without hydrodissection. It's choice of the surgeon what to do, which additional modification he or she wants to do, if the person is comfortable with. Then came the percutaneous inguinal hernia repair, suturing with 18 gauge needle, and then someone combined both these techniques, and then came the laparoscopic percutaneous extracorporeal sutures closure and laparoscopic assisted microincision extraperitoneal division and ligation. This is the open era. Injury to the, because whole of the sac is to be removed from the spermatic cord, so a lot of disadvantages are there. Injury to the vas, even stretching of the vas leads to injury to the vas. A big scar, a big incision, painful, more hospital stay, longer hospital stay. So all these things were compensated when people resorted to laparoscopy with reasonable results. See how beautifully the picture is. Every structure is delineated. This is a closed inguinal ring, deep inguinal ring. This is the open deep inguinal ring on the left side with omentum. And sometimes the structure is adhered also. You can detach that structure from the sac under vision. These are open inguinal ring on the left and the right side. And this is IPSI, where peritoneum is cut and is sutured at the deep inguinal ring. 3 ports are required, one 5 mm for umbilical port for telescope and 2 working ports on left and right side just at the level of the umbilicus. It depends upon the age of the patient and body habitus of the child. And this is IPSI, where the important thing is the presence of this medial fold. One has to cut this to see the defect, size of the deep inguinal ring. Here it is being cut, and then we insert the instrument to check for the size of the ring. If it is more than 3 millimeter, then it requires intervention. And all around the peritoneum, it is around the ring, the peritoneum is suture is taken, and the knotting is done intracorporate. That is actually in seal. We pass the needle and thread through the anterior abdominal wall, through an incision in the inguinal region, all around the deep inguinal ring, and close the knot, tie the knot subcutaneously, and this is the final picture. This is Lahil done for small children, small girls, where the sac is inverted and then ligated with an endoloop and cut. And this is the last method, the loop technique. We have done a valley modification as per the previous surgeon, the surgeon who devised it. He used a spinal needle and 2 threads that pass, the red one from 12 o'clock to 6 o'clock. Then he makes a loop of, brings it out, makes a loop. Then another needle is passed 12, 9 towards 6, and is shown in green. It's a single thread. The tip of this thread is negotiated through the loop by a hook, and this thread is taken out, the red one, and it carries with it the other end of the green loop, and forms a complete loop around the deep inguinal ring. Thus, the knot is tied subcutaneously and it closes the ring. We have done a modification in this. We have not used, because since we don't have hook, so we have made another port, one more port, and we have taken the help of the tip of that instrument, and we have negotiated that tip of the green thread to green color thread towards the loop, and it is brought out and knot is tied subcutaneously, thus closing the effect. We have published our data also of 54 repairs, and the results are promising with minor complications only, no major complication, no recurrence in 17 months of follow-up, and we are in process of publishing our review, in form of review article, 200 cases, and we have only 3 recurrences, and we are resorting to seal method because we find it very convenient, because it can be done by 2 ports only, and it is, the knots are tied subcutaneously, and only complication we encountered was transient hydrocele, which goes off.
Dr. Bahu, can you summarize, please?
Thank you, Dr. Kulwan, for your wise piece of information. Now I call upon the stage Dr. Rajni Bharadwaj. Her topic is Female Inguinal Hernia, Why Posterior Approach Matters, TAPP demonstration. Welcome, Dr. Rajni.
Good afternoon, Chairperson, my respected teachers, senior colleagues, and dear students. I'm going to present my talk on female groin hernia, why posterior approach matters. Are we missing something in female hernia? As we all know that groin hernia is traditionally a male disease. And most of our understanding and knowledge about hernia is from the male patient. But in females, the disease is different and potentially more dangerous as compared to male patients. That's why the approach we choose matters a lot. Groin hernia in females are clinically important despite the lower incidence. They are uncommon but critical. Women, they have a higher proportion of femoral hernias compared to males. Missed femoral hernia is a major cause of apparent surgical recurrence. And the choice of surgical approach determines whether femoral canal is addressed or not. If we look at the lifetime risk of groin hernia, it is 3 to 5.8% in case of females, whereas in case of males, it is 27 to 42%. And despite this lower incidence, we can see that 20 to 30% of hernias, they are femoral in nature in females, whereas 3% they are femoral in males. So why is female hernia so different? Because femoral canal is wider, pelvis is wider, There is higher incidence of femoral hernia, and the females they present with the subtle clinical signs like chronic groin pain. There may be obvious swelling, or the swelling may be subclinical, and most of the time, this anatomy, female anatomy itself predisposes to this femoral hernia. So, missing a femoral hernia in case of female is just inviting a future emergency. If we talk about the types of groin hernia, we have indirect inguinal hernia, which accounts for 60%, and it passes through the deep inguinal ring around the round ligament. Then we have direct hernia, which are rare in females, and again they occur through the Hesselbeck's triangle due to posterior wall weakness. And femoral hernia, which is common, it protrudes through the femoral ring into the femoral canal. Now, why femoral hernia matters? Because they are occult and frequently missed at presentation. They are life-threatening and they have high risk of strangulation. If they are untreated, the patient can die, and usually the patient they are more of age and they have associated disease, and if they are left untreated, there is high risk of mortality. Anterior repair leaves femoral canal unexposed, and missed defects, they mimics the surgical recurrence. Limitations of anterior approach. Anterior planes, they does not naturally expose the femoral canal. Subclinical femoral defects, they are difficult to identify anteriorly. And coexisting defects require separate intervention, which increases the complexity of the procedure. And elevated recurrences in women, they are largely due to unrecognized femoral pathology. And this is supported by the Swedish hernia registry and Danish database. They have highlighted the significance of increased strangulation and increased emergency operation in case of females. And they have already highlighted that there are more recurrences following the anterior approach as compared to the posterior approach. And this is talked by Professor Dr. Charangu in his slides also. Now, why does posterior approach matter? This posterior approach, it gives complete view of myopectineal orifice of Fouchard. It detects direct hernia, indirect hernia, and even the hernia which we don't know that existed. That is the femoral hernia. And moreover, a single large mesh, it covers a complete myopectineal orifice of Fouchard. Architecturally, it is superior to targeted patch repair from the anterior approach. And as per the European Hernia Society guidelines on treatment of inguinal hernia in adult patient 2009 and Hernia Search International Guidelines for Groin Hernia 2018, they clearly recommends that there should be no wakeful watching, early intervention, and posterior laparoscopic approach for female groin hernia. Now the question is TAPP versus TEP. They both provide access to the preperitoneal plane and enable comprehensive repair of myopectineal orifice. And they're both equally good surgical outcome, depends upon the expertise of the surgeon and the surgeon choice. But why TAPP over TEP? It provides direct visualization of all landmarks from within the peritoneal cavity, more intuitive anatomy versus narrow TEP working space. Contralateral groin inspection can be done through the same port. Detection of occult femoral obturator hernia before placement of the mesh. Advantages of TAPP in female patient. It has got superior visualization and magnified view of complete myopectineal orifice. Identifies the subclinical femoral obturator defect. One can go for the bilateral inspection as well as repair and other procedures. They can be detected and treated simultaneously. There is lower recurrence rate and obviously all the benefits of minimal invasive surgery, that is less pain and faster recovery. When one is dealing with the posterior approach, one should be very well versed with the anatomy of the posterior groin, laparoscopic anatomy of the posterior groin. And there are critical landmarks which one has to pay attention. That is the epigastric vessels, iliopubic tract, Cooper's ligament, femoral ligament ring, pubic tubercle, vast deferens and spermatic vessels in males, and round ligament and ovarian vessels in case of females. This epigastric vessels, they can uh, define the direct hernia medially and the indirect hernia laterally, and femoral hernia, they are below the iliopubic tract. And one should know, be very well aware of triangle of doom and triangle of pain. As violation of these boundaries, they carry a significant morbidity and strict adherence is mandatory. So just demonstrating a short video on PEPP repair in case of female. After doing diagnostic lapro, Trendelberg position is given and the hernial contents they are reduced. Uterus is identified and elevated, and after following this round ligament towards the internal ring, peritoneal incision is given 2 to 3 centimeter above the internal ring, starting from the anterior superior iliac spine. Peritoneal flaps, they are raised, superior and inferior flaps, they are raised. Then the medial dissection is done and simultaneously followed by the lateral dissection. And if somebody is confused about the sac or not able to detect this sac, one should leave this round ligament, again visualize from the peritoneal cavity, lift it and again visualize. One should avoid working on the same plane. Then again hold the round ligament and look for the lipomas around the round ligament. They are also very common, as you see in case of males also. And these lipomas, they need to be taken out completely, as they may be the one of the reasons for the false recurrence in the post-operative period. So sometimes they are vascular. You can give short burst of the cautery. One has to be very vigilant in using cautery in this area, because we are just working near the triangle of doom, and your electrocautery should be minimal. So these lipomas, they need to be dissected. Can you help me with this? Just fast forward it. So you have to completely take out this and prepare the bed for the placement of the. You have to make a good pockets both medially and laterally in the space of Bogros and space of radius, so that your mesh should land. Now, in case of females, the controversy exists whether you have to divide the round ligament or you have to preserve the ligaments. So both you can do; they have equal results. But in case of young females, you can avoid this, preserve this round ligament, as the sac is very adherent to the round ligament in case of females. As you see in opposite to males, where the sac you can dissect easily, but in females it is very adherent. And if you are not able to separate the sac completely, and there are the peritoneal tears, so it's better to transect the sac. And after transecting the sac, it gives a nice space for placement of the mesh. Polypropylene mesh is used, and it is placed in the medial pocket and fixed in the Cooper ligament. But just before fixing at the Cooper ligaments, you have to take care that there should be no vessel underneath. So after this, you have to close the incision. You can use tackles. You can make use of the peritoneal sutures, and any rent in the peritoneum you have seen, then you have to close it with the use of the sutures. So what are the potential limitations of PAPP? You require expertise. It demands advanced laparoscopy, including intracorporeal suturing. It has a steep learning curve. At least one should be well versed with, for 50 to 100 cases, they should be required for consistent, safe performance. The cost is higher as compared to the open repair, and
serious risk of injury will be there if somebody is not well aware with the anatomy of the posterior groin. One can injure the visceral structures, vascular injury, bladder injury, as they are the important landmark. Now, the special consideration in female TAPP is whether you should preserve the round ligament. So, this is a default approach. Mesh can be placed around the ligament while setting the peritoneum, and that after the completion of the procedure, you can close the peritoneum, or you can use the method of
Dr. Reddy, can you please conclude?
Then you have to, you can divide the ligament, and indirect sac, it need to be completely resected, and femoral canal, it should be assessed properly. Take home messages: femoral hernias, they are more common in women. Anterior approach is insufficient. TAPP covers the entire myopectoral orifice, and TAPP is the preferred approach as recommended by the international based guidelines for female groin hernia. In the end, in women, every groin hernia must be approached with suspicion, explored completely, and repaired posteriorly to prevent what we often miss, that is the femoral defect. Thank you so much.
Thank you, Dr. Reddy, for your wonderful presentation. Now, before we conclude the third session, if there are any questions from the audience for all the speakers, so we'll take up the questions now. I think there is none, so let us conclude the session. Thank you.
Thank you everyone for such an enlightening session. May I request Professor Dr. Ejaz Ahmed Rathur sir to kindly felicitate Dr. Sushant Soren sir. May I request Professor Dr. Raj Rishi sir to felicitate Professor Dr. R.K. Chirangu sir. I request Professor Dr. Neeraj Kaul ma'am to felicitate Professor Dr. B.S. Pathania sir.
It's but Dr. Neeraj Kaul, but
okay, Dr. Neeraj. I request Dr. Shyam Gupta sir to kindly felicitate Professor Dr. Nazir Ahmed Wani sir. I request Dr. Gulzar Ahmed Bhatt sir to felicitate Dr. Aditya Kumar sir. I request Professor Dr. Ejaz Ahmed Rathur sir to felicitate Dr. Kulwant Singh Bhav sir. I request Professor Dr. Raj Rishi sir to felicitate Dr. Rajni Bhardwaj ma'am.
I would now request Professor Dr. Mushtaq Ahmed Chalgu sir to please come on the stage and felicitate our chairpersons for this session. I request Professor Dr. Ajaz Ahmed Rathar sir. Professor Dr. Raj Rishi sir. Professor Dr. Neeraj Kaul Bhatt ma'am. Dr. Shyam Gupta sir. Dr. Gulzar Ahmed Bhatt sir.
Now moving on to the next session of the day, may I have the honor to invite the esteemed chairpersons of this session, Dr. Harbinder Singh Bali, Professor, Department of General Surgery, ESCOMS Jammu, Dr. Talib Hussain sir, is Assistant Professor, Department of General Surgery, GMC Jammu, Dr. Sandeep Bhatt sir, is Assistant Professor, Department of General Surgery, GMC Jammu,
Dr. Gursimran Singh sir, Consultant Surgeon, Max Super Specialty Hospital. Dr. Abhilash Goyal sir, Assistant Professor, General Surgery, AIMS Guwahati, and Dr. Shaukat Ali Bhatt sir, Assistant Professor, General Surgery, GMC Hanwada.
Dr. Vilash here. May I request Iqbal Salim sir to please chair the session.
Good afternoon. I don't know whether a welcome or an unwelcome addition to this wonderful group of people. Let me not hold you back. The first topic that we'll be having in this session is ventral TAPP, tips and tricks video presentation by Dr. Davinder.
Good afternoon, respected chairpersons, senior faculty members, and dear colleagues. I am Dr. Devinder Singh from All India Institute of Medical Sciences, New Delhi. And today I will present on laparoscopic ventral TAPP, the master video with technical tips and tricks. Umbilical hernia is a common surgical entity encountered by general surgeons all over the globe. And in the current era of minimal invasive surgery, there is a plethora of treatment options like IPOM, ETPRS, TAM, SCOLA, and many others. Although IPOM is the most commonly performed technique, but it is associated with certain major drawback like risk of mesh-related complications or increased post-operative pain and higher material cost of tacker and composite mesh. So the current trend is towards performing extraperitoneal repairs, and on the same line, International Endohernia Society recommends pre-peritoneal retromuscular repair for small to medium-sized hernia defects. For the ease of better understanding, I have divided this procedure into 6 basic steps. The first is patient and port positioning. During this procedure, patient is placed supine with both thumbs tucked by the side. Under general anesthesia, patient is fully catheterized, and the port position is much similar to the IPOM procedure. And the only thing which the surgeon should ensure that there should be a distance of 10 to 12 centimeter minimum from the defect to the camera port. Because if this distance is less, then the suturing and flap creation become difficult. Next step is the capno dissection of preperitoneal space using Veris needle. During this step, we place a Veris needle under direct vision in the preperitoneal plane and insufflate the peritoneum, which helps in easy creation of the peritoneal flap. Next step is creation of peritoneal flap with counter pressure by assistant. During this step, we tilt the table 10 to 20 degree left side up, and with counter pressure from the assistant, we gradually start the flap creation. Next is reduction of hernia content. Then we gradually, by counter traction and traction movements, reduce the hernia contents. Finally, the primary closure of the hernia defect is done like in the IPOM plus procedure. During this step, it is recommended to reduce the pressure to 8 to 10 mm so that the facial flap come close without any tension. And finally is the placement of simple polypropylene mesh, which is cost effective, and closure of the peritoneal flap. Now let's see the complete video of this procedure. Here you can appreciate the VisiPort entry into the abdomen. And here you can appreciate that after insufflating the Veris in the preperitoneal plane, the peritoneum is being lifted up. Then the table is tilted left side up with counter pressure by the assistant. The peritoneal flap creation is started. During the initial part of this procedure, it is difficult because the peritoneum is very thin and there is very little cushion of fat on the lateral side. So we should be very meticulous and judicious. By gradual traction and counter traction movements, the flap is advanced. Here the tip is that make the concavity the Caesar towards the abdominal wall, and we have to graze along the posterior sheath. The peritoneum is a single cell layer, so we advise that cautery should not be used. And as we reach the midline, we encounter fat, which gives a safety cushion. This is an avascular plane, so there is no major named vessel and there is very less risk of bleeding. So cautery or any energy devices generally is not utilized. And if it is utilized, it should be done judiciously. If we damage the linea alba by thermal energy, it may result in a 2 centimeter hernia in post-operatively presenting to us as a 10 to 14 centimeter due to thermal damage of linea alba. Now we gradually reach the midline with the fat provides us the safety cushion. We dissect all around 270 degree all around the hernia defect. The hernia is dead at the end because here there are maximal chunks of flap tear and the contents are reduced. And the flap is advanced in all directions so as to ensure at least 5 to 6 centimeter overlap in all around. Then after reducing the neo pressure to 8 to 10 mmHg, the facial defect is closed using a non-observable V-lock suture. At the roof, the backhand suturing makes the job quite easy. And this also reduces the chance of seroma formation in the post-op. We apply a clip so that the suture should not slip. Then after measuring the pocket size, we place a simple proline mesh. As such, this is a confined space and carries very less risk of migration. But for the purpose of extra security, we place 1 or 2 stitches. While taking these tucking sutures, it is advisable that the suture should not be too tight, the knot should be aerial, so as not to crush the tissue, which may cause increased postoperative pain. Then the peritoneal flap is closed using an observable V-lock suture. Here the tip is that take horizontal metal suture and pull the suture in the direction of incision, which decreases the chance of peritoneal flap tear. Then we utilize suction to excrete the gas and the mesh get fixed to the peritoneum. In this video, I have kept a video where there is peritoneal flap tear. It is a worry that somehow if the peritoneum get torn, then what to do? Then we have 2 to 3 rescue procedures. If there is gross peritoneal tears, you can go for TAM or IPOM procedure. Or if there are simple 3-4 rents, you can also close them meticulously using a 3-0 PDS suture. And then the procedure can be performed uneventfully. But these defects, considering as small, should not be left, because through them the bowel will come in direct contact with the proline and may later present with complications. So the definite advantage of ventral TPP or IPOM include less pain, as trachers are not used for mesh fixation, lower risk of mesh related complication, as there is a peritoneal barrier between the bowel and the mesh, and definitely it has lower cost as it does not utilize the composite mesh and tracher fixation devices. The advantage of ventral TPP over ETAP-RS include the extent of dissection is very minimal. In ETAP-RS, we dissect the space right from the Xiphius sternum to the pubic symphysis. So for a small hernia, maybe it is an overkill. And over TAM, the ventral TPP has the advantage that in TAM there is a potential for increased muscle trauma and neurovascular injuries, because we are in that plane and there is increased risk of bleeding. But in ventral TPP, it is an avascular plane. So to conclude, ladies and gentlemen, laparoscopic ventral TPP is a safe and feasible option with a definite advantage of lower cost, less pain, and shorter length of hospital stay. But the limitation of this procedure include longer operative time and a steeper learning curve, but with practice it can be achievable. These are a few of publications published in JMAS, where we have described the technique of how we are performing this procedure. And for lateral hernias like sphygelian hernia, incisional hernia after appendicectomy, the ventral TPP becomes more easier because laterally the peritoneum is more thicker and it is easy to create. Thank you very much for your patience listening.
Thank you, Dr. Ravindra. Very nice presentation. We will take the questions after this talk is over, sir. The next speaker is Dr. Imran Abdullah, and he is going to speak on ETAP for ventral and inguinal hernias.
Good evening, everyone. Thank you, organizing team, for giving me invitation. I will be presenting ETAP for ventral and inguinal hernias. As we all know, hernia repair is one of the most common surgical procedures done worldwide. Laparoscopic approach improve recovery and reduce pain. ETAP approach combines the benefits of laparoscopy and radistopa repair. Why ETAP? It avoids intraperitoneal mesh, gives wide retromuscular coverage, less bowel-related complications, and is ideal for large ventral and bilateral inguinal hernias. Indications vary from primary ventral hernias to recurrent hernias, incisional hernias, as well as inguinal or recurrent inguinal hernias. These are the steps of ETAP. I have just mentioned these steps. I'll be discussing these steps in detail while presenting a video. How to position the patient in ETAP repair, how we place ports, creation of space, crossing midline, dissection of ventral hernia, and in this case, dissection of inguinal hernia, defect closure, mesh placement, how to fix mesh, whether it's fixed or not, and placement of drain sometimes, and controlled desufflation. What are advantages? There is no intraperitoneal mesh, so there are reduced adhesions, less post-operative pain, faster recovery, and excellent for combined ventral and inguinal hernias. But it comes with limitations. It has steep learning curve and requires technical expertise. Initially, it has longer operative time because of less orientation with the retrorectus anatomy. Our patient is 65-year-old gentleman, diabetic, hypertensive, hypothyroid, BMI of 38 kg per meter square, reluctant for bariatrics, presented with supraumbilical and bilateral inguinal swelling from last few years, progressively increasing size, and our plan was ETAP. How to position the patient? In OT, patients placed in supine, table is extended, arms are tucked, surgeon stands on the left side of the patient, camera surgeon to the right of surgeon, and the assistant to the left of the surgeon. Monitor for ventral hernias placed directly opposite to the surgeon on right side of the patient, and once we are going for inguinal dissection, we shift the monitor to the foot end. I'll be discussing diagram A, when ETAP for umbilical and inguinal hernias. B, I won't be discussing. In this case, as it was the periumbilical hernia and bilateral inguinal hernia, initially port A is placed at 10 mm. It can be placed by Visiport technique, going directly into retroactive space, or by open technique. We prefer open technique, but it varies from center to center. After that, one space is created, then one more port B, 10 mm, and port C, 5 mm are placed. And once crossover is done, port D is placed. It is also 5 mm. And in this case, one more extra port was placed, just a mirror image of C, medial to the right linea similaris. For further discussion, I will be mentioning the name of port as ABCD. This is a video after placement of the left subcostal port in the retroactive space. The left retroactive space is dissected with the help of Nemo and blunt telescopic dissection. Once it is done, the port B and port C are placed under vision. After this, the camera from port A is shifted to port B, and port A and C acts as working trocars. Crossover is done at the epigastrium. The medial attachments of the left posterior rectus sheath are divided. Anterior to falciform ligament dissection is done, and the right posterior rectus muscle is identified. It is incised to confirm the underlying rectus muscle. Once confirmation is done, the medial attachments of the right posterior rectus sheath are divided along the entire length as far as possible during the crossover. And the right retrorectus space is dissected. Once complete dissection is done, the port D is placed under vision. After this, camera is shifted back to port A. Now port B and port D act as working instruments. The division of the rectus sheath, posterior rectus sheath is continued on either side. Hernia is identified, reduced. Sometimes hernia is irreducible. We can increase the enlarged defect by incising the linea alba longitudinally, reduce the contents completely, and attachments of the sac with the hernia defect are being divided for the complete reduction. Further dissections continue. The medial attachments of the posterior rectus sheath on either side are divided. Midline peritoneum adherent to the linea alba is dissected. We should avoid buttonholing, but the buttonholes can be closed later on. It creates difficulty in the space creation. Here the posterior rectus sheath should be divided about 5 mm away from the linea alba, otherwise it may result in weakening of the linea alba. Once the retrorectus space is dissected, then in this case, the right inguinal dissection is being done. The space of Bogras is being dissected, and the peritoneum is being separated from the underlying structures. The sac is reduced as there was large lipoma adherent to the sac, so it was reduced along with the sac. Paralyzation of cord is being done. Once it is done, then the redundant part of the sac along with the adherent lipoma was excised so that it doesn't slip under the under edge of the mesh and result in recurrence of the hernias. And this defect was closed with the 2-0 Vicryl. Same procedure was repeated on the left side. I am skipping this for sake of time. One is done, then the anterior defect along with the strengthening of the linea alba was done with the 1 number PBT suture, that is non-absorbable suture coming from the covidian. While strengthening the linea alba, we should not include the muscle in the suture. Otherwise, it results in strangulation of the muscle and the increased postoperative pain. While closing a defect, the suture is being taken from the pseudosac in order to prevent the post-operative pseudo-recurrence as well as the seromas. The entire dissected length of the linea alba is being strengthened. Once strengthening is being done, 15 to 15 centimeter mesh tailored is placed over the myopectomy or suture on either side so that it covers the hernia defect adequately on all sides. Same piece of mesh is placed on left side. After this, these inguinal meshes are fixed at the Cooper's ligament using 20-proline. Separate mesh about 20 to 20 centimeter is being placed in the retrorectus space and covers the entire dissected area. After that, drain is placed and controlled desufflation is done. ETAP is safe and effective technique, combines advantages of retrorectus and laparoscopic repair, excellent approach in combined ventral and inguinal hernias. However, it has steep learning curve and needs expertise. Thank you, everyone.
Thank you, Dr. Brand. So, next section will be.
Good afternoon. If Dr. Ajaz Ahmed Malik from Shefa Hospital, if he is present in the audience, sir, kindly submit a PPT to the IT desk. Thank you.
So the next session will be Dr. Uttam. He'll be talking about Scola ETAP for ventral hernias, expansion surgical horizon.
Thank you, organizers, for inviting me back to AIIMS Jammu. I was here some 4 years back. I started my faculty journey from here. I was first to join this department of general surgery. So my work is almost done. Dr. Aditya presented Scola video and Dr. Imran Khan presented a nice video of ETAP. So I will just try to fill in the gaps. My topic is about ventral hernia, expanding surgical horizon. So abdominal wall reconstruction has moved from open to IPOM, from then ETAP, Scola, and now robotic is being done. Still, all the four types of surgery are widely popular. Each era has evolved by escaping the morbidity of the previous surgical plane. So open repair taught us the cost of wound morbidity and mesh morbidity, while IPOM taught us the price of intraperitoneal mesh and fixation-related pain, both acute and chronic. So the logical evolution was to move into extraperitoneal planes, where we can place a large mesh in a biologically favorable space, preserve abdominal wall function, and reduce both wound and visceral complications. This is where Scola and ETAP truly expands our horizon, escaping the wound and peritoneal morbidity through optimal plane selection. So, about ETAP, we moved into the right plane, deep to the retromuscular space. So ETAP is indicated in almost all the ventral hernias, but it has advantages in large hernias, more than 5 centimeter, incisional hernias, Swiss cheese defect, recurrence hernia, and hernia near the bony prominences. While doing ETAP, posterior component separation and TAR is also possible. And ETAP has superior biomechanics in which mesh is placed in the retromuscular plane, applying gold standard Reeves-Topaz principle. So this is the video. I will try to skip it. French, and this was the position. While doing ETAP, after the reduction of hernia, we cut the posterior rectus sheath. So what actually we are doing? See, hernia was reduced, and then posterior rectus sheath was cut. So hernia was reduced, and then posterior rectus sheath was cut. So actually, we are enlarging the hernia size to make the optimal plane for mesh placement. And this now the big hernia is repaired. So, is ETAP always the first choice? Actually, ETAP needs high expertise where suturing in the roof is a bit difficult, and there is plane-specific morbidity, like sometimes inferior epigastric artery gets injured, and as we have seen in the video that the small hernia after cutting the PRS is converted into the big hernia. So once hernia reoccurs, some 3 centimeter hernia will get into some 15 centimeter hernia. So again, the repair will be very difficult. So actually, so once you enter the extraperitoneal era, the next question is which plane is the best matches the pathology. For small midline ventral hernias with dominant diastasis and cosmetic expectations, the retromuscular plane may be biochemically ideal, but it is an overkill. So this is where Scola offers a beautifully direct anterior solution, a direct, elegant, and anterior solution for pathology driven by midline weakness. So Scola is for the right plane for the right patient. Patient with small ventral hernia and diastasis recti. Scola is best suitable for them. It should be avoided in recurrent hernias, obesity, and complex defects. So patient is positioned in French, modified French position. Preoperatively, defect is marked, and we go into subcutaneous plane over the anterior rectus sheath. Similarly, dissection is done on the opposite side, and then the midline is dissected. While dissecting the midline, we should be very careful. We should be away from the skin of umbilicus, otherwise it may lead to postoperative umbilical ischemia. So when this beautiful plane is created, the hernia defect is closed. And then diastasis is also repaired. The space size is measured and mesh is placed accordingly. And then umbilicus is sutured back with the mesh and anterior rectus sheath. Lastly, 2 drains are placed. So why Scola is excellent for small ventral hernia and diastasis recti? Because it offers a direct linear reconstruction. It preserves retromuscular anatomy. We don't need to cut posterior rectus sheath. And there is superior contour restoration, and suprapubic scars are usually hidden. And for the beginners, the ergonomic is very good. The inferior wall suturing is very easy for the beginners compared to what we do in ETAP, where a superior defect is also need to be closed, and there is a small in this Scola we need shorter of operative time. So what is the evidence of Scola? this is the recent systematic review in which 247 patients were operated. When mesh was placed, there was a zero recurrence. So this is the Achilles heel of the scola procedure. Though seroma rate was high, and infection is also minimal. So the main complication of scola is this formation of seroma because we dissect a large subcutaneous plane. So how to prevent seroma? First, you have to preoperatively you have to mark the area of dissection, which we should not cross beyond linea similaris. This perforator should be identified and should be saved. So here you can see this linea alba, widened linea alba, rectus muscles, and the neurovascular bundle. While dissecting from umbilicus, we have to save a cuff of fat tissue to prevent umbilical ischemia. So the comparison scola versus ETAP. Scola is for small hernia with concomitant diastasis recti. It is not good for obese patients. We place mesh in subcutaneous space, and ETAP we place mesh in retromuscular space. Seroma occurrence is high in scola, but biomechanics is more better in ETAP. So what does guideline says? Guideline says a retromuscular repair should be preferred wherever possible. But don't we think it is an overkill doing ETAP in a small hernia where we cut PRS, and if it reoccurs, it may convert into a very large hernia. So better to do scola in small hernia with diastasis recti, and it is also guideline concordant. So what is the surgeon horizon means matching the optimal tissue plane to the patient pathology. ETAP offers good biochemical repair, and scola offers it's better for small ventral hernia with diastasis recti. Thank you.
Thank you, Dr. Uttam. Thank you very much. Now I would like to invite Dr. Zahid Mohammed Athar. He is going to speak on TAPP for inguinal hernia repair.
Respected chairpersons, my teachers and faculty members and delegates, very good afternoon. Today, I will talk about the transabdominal preperitoneal inguinal hernia repair step by step, the basic steps that are involved in the step. Growing hernia is the most common problem of the modern world. Incidence 5 to 7%, more prevalence in developing countries like India. Rupture of growing hernia is the common performance. Rupture of growing hernia is commonly performed surgery worldwide. Five principal modern era is antiseptic and aseptic hernia surgery, high ligation of sac, tightening of internal thing, reconstruction of posterior inguinal flow, tensionless therapy. Choosing the best treatment, best or the most suitable treatment of inguinal hernia is a true challenge. The best operative technique should have low risk of complication, that's pain and recurrence, easy to learn, fast recovery, reproducible, and the cost effective. The decision also depends upon many factors. The hernia characteristics, anesthesia type, surgeon's preference, training, capabilities, and logistic and patient business. Concluding one single standard technique for all hernia does not exist. The famous quote says, no disease of human body belonging to the prevalence of surgeon requires in its treatment a greater combination of accurate anatomical knowledge with a surgical skill than hernia in all its varieties. The inguinal hernia is the main weak point of anterior abdominal wall and corresponds to the pectineus orifice, embryologically weakened by the passage of spermatic cord in men, inguinal canal, and of the femoral femoral canal. Perfect knowledge of anatomy of the growing hernia is the key to treat hernias. Fouchard has confirmed that all the inguinal hernias passes through a single parietal orifice called the myoperineal orifice of Fouchard, named after surgeon anatomist. This is the myoperineal orifice of Fouchard, that superiorly the origin of IOM and TAN, laterally iliopsoas muscles, medial, lateral is the practice abdominis and pectin, pubipectin and iliotuberous tract, spermatic cord and iliac vessel. The transabdominal preperitoneal laparoscopic hernia plasty requires the preparation of a very large peritoneal flap. To do this, it is very important to know how to recognize and identify the extraperitoneal space of the pelvis. Immediately between the parietal peritoneum and the transverse fascia is the ridge space and consists of variable amount of adipose tissue. Although the inguinal ligament is not visible, however, the Cooper's ligament is visible and palpable with the laparoscopic instrument even in these subjects. This important reference point is located 1 cm medially inferior to the ordinary epigastric vessel. Recognition of this element, in fact, is the basis for the understand the technical steps for repair of all types of inguinal hernia by laparoscopy. Identification inverted Y element and the iliopubic tract that passes horizontally through the deep inguinal ring at the center of inverted Y permit the visualization of 5 areas, that's 5 triangles. These are the 5 triangles of direct, indirect, femoral, and triangle of doom and triangle of pain. Indications are tap approach can be performed in theory for any hernia, even in strangulated incarcerated cases. However, the indication depends on the surgeon's clinical judgment and the skill. The best indication according to his classification are type 3 and type 4 hernias, bilateral hernias, hernias in obese patients, hernia subject with intense physical activity, and recurrence of hernia after open radials. These are the contraindications in prawns, capnoperitoneal, severe cardiopathies, or severe pneumopathies, extensive intra-abdominal adhesions, large scrotal hernias after radical prostatectomy, strongly perforated hernias with intercurrent sepsis. Severe ascites, recurrence of hernia after laparoscopic repair, pediatric patient, pregnancy after second trimester, severe clotting disorders. Preparatory preparation, the patient has to be carefully prepared for the operation. The evaluation of comorbid as well as adequate second preparation is mandatory. Evaluation of operative risk from the point of view comorbid, there is no absolute contraindication for that. Second, a preoperative antiseptic shower is performed on of the intervention. Hair is removed half an hour before the surgery. Urinary catheter always empty the bladder to facilitate the dissection in the rectal space and to avoid the bladder injuries. Patient and surgical team push, and the patient is placed in a supine position with both arms along the body and fixed in the operating table. Frontal nose position 15 to 20 is given with a lateral inclination. I prefer the general answer for the patient as the muscle relaxation improve the surgical maneuvers and the Again, the orotracheal intubation protects the airway from vomiting or regurgitation, favored by the increased intra-abdominal pressure. This is a surgical team position. The team is organized with the surgery on the contralateral side to the hernia to be repaired, and the camera operator is the position on the same side or in the side as the hernia. Pneumoperitoneum and trocar are placed under the strap of the carbon dioxide pneumoperitoneum using the Vass needle. These are the potent 10 mm and 5 mm trocars. Intra-abdominal with the aim of the laparoscopic approval is to identify the anatomical landmark and the site and the type of hernia, direct or indirect, established by the position of defect with the respect to the inferior epigastric vessel and the cord structures. The two dangerous triangles, the vascular triangle and the pain triangle, have to be identified. This is the intra-abdominal view. This is indirect hernia. There is a wide difference in the gonadal. Peritoneal incision. Content of hernia sac equine were reduced with the help of atraumatic bowel forceps. The pre-peritoneal dissection is started at the lateral part of internal inguinal ring and then continued medially and caudally at the level of ridges until the pubis is well exposed. This is a peritoneal incision. Dissection of the lower peritoneal. The aim of this setup is to create the pre-peritoneal pocket to ensure the best position of the mesh. The setup is consisted of three phases. Medial dissection over the ridges space, lateral dissection on the space of Bogra, central dissection over the site of hernia and its hernia side. This is the medial dissection. This is the lateral dissection. The sac dissection is performed using the traction and contratractions, maneuvers, and fine coagulation to avoid the injury of the ductus efferent and the suprametic vessel. The sac dissection always start anteriorly. The sac dissection intraoperative inverted Y mesh place. The mesh should be reached at least the pubic symptom medially and iliopsoas muscle laterally. Inferiorly, it should reach 1 to 2 cm below the pubis and superiorly cover the interior abdominal wall, extending the hernia defect by 3 to 4 cm. The fixation of mesh with the copersulant, lateral fixation of the mesh, and the complete display rolling mesh. What the routine is to close the peritoneal flap with the aid of absolute absorbent trachea. This maneuvers is a fast and cost effective. We also close the flap with a continuous suture, monofilament or 3-0 bar sutures. Peritoneal flap closure. Careful examine peritoneal closure. The trocars are removed under the laparoscopic control. The apneurosis is closed at the umbilical site with the sutures with the absorbent. Intraoperative bleeding is one of the potential complications of TAP. The injury of the deep epigastric vessel, the testicular artery, the gonadal vein, or the corona mortis can cause abundant bleeding, which, if not controlled by laparoscopy, requires the injured conversion to open. Post-operative complaints, these include seromas, hematomas, post-operative chronic pain, infection of wound, rejection or infection of the mesh, recurrence, testicular atrophy, and infertility. That was a short video.
Thank you, Dr. Zahid, for such an informative and engaging presentation. Now, I would like to call upon our next speaker, Dr. Mudassir Shadar, who is going to present the extraperitoneal approach, rationale and technique in modern hernia repair.
Video. Here's what we have used the contenters. Now is the focal placement. Pardon the hernial contenters from the hernia defect. Now, with the peritoneal flap from both medial and lateral dissection. There's a small bleed. Now these are the hernial side, which is separated from the cord suture by traction and counter-traction. By using the small cord tree. Sometimes there is some bleed, we can use a gauze. So, if there is some bleed, now after separating the sac from the cord structure, sac can be dissected. Now we have placed the thigh. Let's have the cycle removed. Now we can place the mesh through the 10 mm procar or placing the tanker that there is a bleed from this, which is controlled by placing the gas by pressure, keeping it for 2 to 3 minutes. The bleed has been controlled by pressure. Now, internal bleed, the peritoneal flap has been closed. If the bleed is from the vessel, we can use a suture by using the figure of 8 to control bleed. Last picture using non-absorbent catheters. Now, peritoneal flap can be closed by using the catheter or the relaxer.
Thank you, Dr. Zahid, for such a wonderful presentation. Now, we would like to invite our next speaker, Dr. Mudassir Nisa Shadar, who is going to present the extraperitoneal approach, rational and techniques, and modern hernia repair.
Respected chairpersons, my teachers, colleagues, at the outset, I'd like to thank organizers for giving me an opportunity to speak in this session. Over the next 10 minutes, I'm going to speak on a topic, extraperitoneal approach. It's a rationale and technique in the modern hernia repair. So why this talk? What this talk will do? It will address why we want to go extraperitoneal. What does the evidence say? How is it done safely? And where is it going at the present? So modern hernia surgery has moved. It has moved from just closing the holes to restoring the planes. Mesh, everyone agrees, yes, you want to put the mesh, there is no doubt about it, but where? It has the question which has always been tickling the hernia surgeons world over. The evolution of hernia surgery has gone from an open repair, which we find that has a high recurrence and wound morbidity. And that's why came the laparoscopic IPOM, which later on evolved to the IPOM Plus. IPOM Plus, where we bridge the gap, is an augmented bridge repair. Without going into the details of the IPOM, it has been discussed by the previous speakers. As you can see, it involves the closure of the defect. We are here to understand the drawbacks, what can happen. The mesh which we place in an IPOM, even though it is a coated mesh, it does not eliminate the risk of adhesions. And once there are adhesions, there are chances of fistula formation. And when there are chances of fistula formation, there are chances of obstruction as well. The mesh can migrate. Yeah. And in this procedure, we use most of the times the tackers. These tackers are costly, and even these tackers are at times the sites where the bow can go and can hook around that. These are the situations which we have found in patients, even though they had a coated mesh in place, which is an evidence that IPOM is not 100% safe. These are the publications, case reports, which show that adhesions do occur. Plus, IPOM has its limitations. The limitations are, there is a large defect, like a 6 centimeter, 8 centimeter defect, you cannot address it by an IPOM. If hernia is at atypical locations, like it is at the angle, appendectomy scar, there is a flank hernia, so IPOM is again not the answer in such cases. And another problem with this is that it doesn't restore the linea alba, because the core concept of hernia surgery now is the functional restoration of the abdominal wall. So the subcutaneous plane, preperitoneal plane, retrorectus plane, these planes have been adopted. So why extraperitoneal? What is the anatomical logic? The logic is to avoid peritoneal cavity. There's a natural mesh placement in the reused plane. There's no bowel contact, as I mentioned. So reduce risk of chronic pain because we don't use tackers. When you put a mesh in a peritoneal or retractus plane, you might not require a fixation at all. There is complete coverage, as the previous speaker Imran showed, that you can even go in the retractus plane, you can go from the ventral to the inguinal area. So it can cover whole area of the abdominal wall. And there's a superior tissue integration because there's a robust tissue reaction which enhances the mesh integration. And of course, the cost effectiveness of the mesh, because we don't need to use the composite meshes, we can utilize normal polyprotein meshes. This is one of my papers that I published in way back 3 to 4 years back, and I'm pleased to share that this was regarding the retroperitoneal repairs. It has almost 8,000 worldwide views and more than 20 citations. It was on the same topic, extraperitoneal ventral hernia repairs. So the world has moved, and there is a tailored approach now in ventral hernias. For the defects up to 4 centimeters, the IPOM is okay. But once you exceed the 5 to 6 centimeter defect, then you have to look for other solutions. So this is the ETAP ventral hernia repair. It has been already discussed by previous speakers. You go into the left subcostal plane. You open up the anterior rectus sheath, secure. You see the white glistening area. This is the posterior rectus sheath. You have an incision, go into the area, do some camera dissection over the area. Below you see the arcade line. And then you put in a first port, which is using a guide, that is linea seminaris. The first port, the trocar enters, and then you start dividing the loose aerial tissue which comes in your way. You stay into the white plane. You divide the PRS for a second port below the umbilicus, and it has to be about 0.5 centimeter below the linea alba. You put in a second port and then start dissecting below. One of the beauties about this technique, the extraperitoneal repair, that is the ETAP, is that even if you get a hole in the peritoneum, this is not an EP repair, this is an extended view. So you have a leverage to do the dissection. You can simply close this defect and go ahead because you have a wide peritoneal space to work, a retrorectus space to work in and to do the dissection. So as you can see, you can easily close the defect without much of the efforts. So the concept of crossover came up. As you can see, the incision in the retrorectus space below the linea alba. This is 5 mm below the linea alba, above the falciform ligament. This patient had a wider defect, about 4 to 5 centimeters with divarication. So you find what's called as a marshmallow sign, where you enter the opposite retrorectus space. You remain flush with the retrorectus, bring down the contents. And this space gives you again a leverage to go down, even up to the pubic area, as was shown by the previous speaker, that even the inguinal area can be exposed to the same space. This patient had a divarication with the hernia, and we are creating a defect even in the posterior rectus sheath. You reduce the tension in the pneumo, suture the linea, the wider, and close the defect using the non-absorbable sutures. Of course, taking care not to take the muscle, but to take the sac so as to reduce the cinema formation later on. Once you are done with the suturing, then you take care of the posterior rectus sheath. One has to be aware of the fact that this posterior rectus sheath is not the strength forming layer of the abdominal wall, so you don't have to tighten it. You just need to close it and put in a large mesh which covers the area. Now this space can be extended if you want to go laterally for defects more than 10 centimeter. If there's a tension on the posterior layer, narrow rectus space, complex hernias, can do a top bottom tower or bottoms of tower. And of course, it has now variants. Now, in some of the cases, I have done ETAP preperitoneal from below and ETAP preperitoneal from above. There is some entity called corona crossover. Due to paucity of time, I couldn't discuss them here. These variants do not compete, but they complement each other. So modern hernia surgeon must understand their applications, benefits, and limitations. There are complications with this extraperitoneal repair as well as compared to interperitoneal. Like there are seroma chances are a bit more because you're creating a lot of space in the area. Plus there are chances of peritoneal tear. But one has to be cautious about it, that it needs structured training and requisite skill to perform these procedures. It demands advanced spatial orientation and preoperative planning. Complex defects may still need TR, robotics, or even open reconstruction. Evidence is quite promising. Comparative high-level data is still much. So what is the takeaway from my presentation? I come back to like my first slide. Modern hernia surgery is moving extraperitoneal. Rationale is better anatomy, better mesh biology, less visceral compromise. Technique, we have to master planes, landmarks, overlap, and low threshold bailout. Message is posterior plane is the principle. TP, TAPP, ETAP are just the tools. Thank you very much. Do you have any questions?
Thank you, Dr. Mudassir, for a wonderful talk and your support on this time. Now we call upon Dr. Shahid. He's going to speak about the complications of laparoscopic hernia surgery.
Respected chairpersons, my seniors, mentors from whom I learned the art of surgery, and dear colleagues, a very good afternoon to all of you. Today, a lot of speaker has talked about all the type of surgeries which are done in hernia, and I am the last one because the complications come last of all. But they are there. Although laparoscopic hernia repairs are gold standard and has more benefits than rest of the surgeries which we have discussed earlier. But I'll let you know one thing, that they do not come without the complications, and they require the knowledge of the hernia surgeries require the anatomical knowledge more than any other surgery which we do. So I will not go into the details of the hernia because all the speakers has already talked about that. Normally, the two surgeries which were done traditionally, we were doing in laparoscopy, traditionally mean only at the laparoscopically, TEP and TAPP. But now the ETAP has taken over the both of the surgeries which were done traditionally, as already Dr. Imran and Mudassir has talked about that. I am going straight away toward the complication part, and they can be classified into on the basis of the time, can be intraoperative, early postoperative, and late. On the basis intraoperatively, we all know that vascular injuries are the hazardous. Bowel injury can happen, bladder injury, peritoneal tears can happen, which can make our life difficult at that time. Early postoperative, we know that hematomas, urinary retentions, postoperative ileus, seromas, although they can be seen in the late period also, are seen most of commonly. Then comes the late complications, which are of more troublesome to all of us. They include chronic groin pain, which remain there for even 5-6 years after the surgery. Recurrence, which is again a problem. Mesh infections, a dreaded complication. Adhesions and obstructions. For that is on the basis of clavin window, which we all know for its use for all the surgeries. And in this, if we say that the simple ones are one which does not require any medication and can go off, like the small seromas or minor bruising over the skin. Then grade 2, in which there are minor bone infections and some urinary tract infections, which require some medication, but again go up in weeks time. Then the grade 3, where there we need some intervention at that time, like we have to explore again or remove the mesh, explantation, or sometimes the drainage of the hematoma or seroma can be required. And the last I'll say, because the fifth one I won't say, and none of us want to see that thing. On the fourth, there are the bowel perforations where we require sometimes resection anastomosis and laparoscopically or need to convert. So intraoperative, I had already talked that, and rest of the speaker has shown, even in one slide of the Zahid, he has managed that very well by putting a pressure over the bleeding point. Mostly the bleeders are from the trocar side, where we enter and the inferior epigastric artery is injured, which can be managed by applying the pressures, or we can use a bipolar electrocautery to control it, or sometimes we need to put in a Foley's catheter to put a pressure over that and it can be controlled, or at the last we need to suture it. But the more dreaded one are the seen in the triangle of doom, or in the, because of the aberrant obturator artery, where we require some extra vigilant. And for me, I will say that we need to convert. For me, conversion may be to open. For me, it's already an open and Liechtenstein, but for my teacher, I know that they will convert it from 5 mm to 10 mm, or sometime maybe change the technique from TEP to TAPP. Then I already discussed the management part briefly. Another injury which can occur because of the trocar is the bowel injury. Initially, it can be seen with the trocar, but nowadays it's rarely seen as we have transformed ourselves and learning curve has increased. Adhesiolysis, because when there is requirement of adhesiolysis and the thermal energy is used, there are chances of bowel injury. Management is that if there are small injury, we can repair it intraoperatively without contamination with the laparoscopic approach only. But if there is a large gut injury and perforation involving more than half of the circumference of the bowel, or there are multiple tears, we need to convert and or either do it laparoscopically with resection anastomosis with laparoscopic assisted technique. Peritoneal tears can be managed. There is a tear in the peritoneum, which we also, while doing TEPP, which can be managed by suturing it. This is another complication of a mass infection. You can see that this patient has presented initially with 3 or 4 surgeries of open. Then there was a laparoscopically mesh placed, but after 6 months, again there was purulent discharge from that. This is then at that time what you will do, you have to explore again and remove the mesh, which is being done here. This is one of the management for the last management. I will say that initially, if conservative is failed, with antibiotic if it is failed, then you have to explore and remove all the mesh which is placed there. Don't leave any part there, otherwise again there are chances of infection and sinus formation or fistula formation. Recurrence is again a problem, and it's seen in almost 1% of cases. Recurrence causes, I will not go to the management part. Why it occurs? Mostly because if there is inadequate space creation, we have not created a whole of the, we have not seen whole of the area like myopectoral orifice. You need to clear it all. And the dissection should, on the medial side, dissection should go at least 2 to 3 centimeters beyond the midline, and below the peritoneal should have been reflected properly, so that mesh should not get reflected back, and on the lateral side also, so that a 15 into 15 centimeter mesh should be placed, because at least 5 centimeter of coverage is required. This is a small video which is showing again the edge. This is sigmoid colon, which has formed the fistula because of the adhesions. Here the dissection is done with the electrocautery to remove it. This is the pocket where the infection and the pus was there, because we had cleared it later on from outer side. This is the loop which is adherent with the mesh.
This is the sigmoid, sorry, no, don't speak it. This is a sigmoid loop, and there is a fistula. We'll remove it completely by doing the dissection. Adhesion, this is done, and there is the opening which was repaired there on the table. Laparoscopically, the opening was cleared and a drain was placed. Then the adhesions. Small bone adhesions are more common, and they are. This is the sinus. The sinus formation because of the adhesions, and the mesh was seen with an infection pocket over there. Along with the urinary bladder, there was a fistula, sinus tract. Sorry, this was not a fistula tract. A sinus tract was found between urinary bladder and the sinus, which will be seen while we will pull it back. The dissection is done by the sharp dissection is done to avoid the injuries to the bowel. It is separated from laterally, and there is a one small loop lower down which we will separate right now. This is the last one which is adherent over there, and then this is the part which was adherent with the mesh. This is a mesh, part of the mesh which is visible there. We are going to remove this loop. Luckily, there was no communication. There was no injury to the bowel. In this one, we were able to separate it completely from the mesh. Mesh is still visible. This last loop was removed. And there was, so it was closed, there was no leak from there. We left it open, and then because it was adherent with the bladder, one sinus was coming from the bladder is being filled with the saline, 400 ml saline was filled into the bladder, and the tract was then opened. It is not in this video. It was opened and then pulled back to see whether there is any communication with the bladder. In this case, it was not there, so it was only a sinus, and we left the area open and kept a drain over there. Here I will show you the sinus tract. The last video, stop after that. The bladder is being filled with the saline, and this tract which we are pulling here, and externally it will be showing us the sinus. This center one, it get pulled back, but there was no communication with the bladder, so we left it like that. We cut it from the skin side, and after 2 months, the wound healed externally. Thank you. The prevention strategies are the take-home messages are to do a proper dissection, make the planes clear, educate size mesh should be placed in that area so that all the hernial orifices are covered. Thank you. These are the zones where we do the dissection of the most and require our precise knowledge of anatomy. Injury should be detected early, assess severity, and repair it immediately. Thank you.
Thank you, Dr. Shahid. I think your presentation takes the cake today because everybody tells us how to do it. You were telling us how you are going to manage my problems. But there is just one point I would like to highlight. Once you have bowel, it's better to use sharp dissection. If you are going to use harmonic, please keep the active blade always towards yourself. That's all. Thank you very much. The other point I wanted to highlight regarding the neurovascular bundle, regarding VTAP and this TAR. The neurovascular bundle is between the internal oblique and the transversus abdominis. The unfortunate thing about VTAP is that certainly you are going to have more perforations in that very thin layer of peritoneum. Otherwise, it's an excellent procedure. Yes, it's very difficult to say this is TARM and this is VTAP, but the results in this case are very good because we are saving on a costly mesh and we were preventing fistulization. Thank you very much. Yeah, we had one more this presentation, but Dr. Ejaz probably has not turned up today. Maybe some other day we'll talk about his presentation. Thank you. With this, we wind up the session. Okay. Any questions from anybody? Sorry. I thought everybody's tired and we would just like to go. Okay. Yes, Shamas is also pointing towards that. Please go ahead.
Thank you so much, everyone, for such an enlightening session. May I now request Dr. Harbinder Singh Bali, sir, to felicitate Dr. Devendra, sir. May I request Professor Dr. Iqbal Salim, sir, to felicitate Dr. Uttam Singh Thakur, sir. I request Dr. Sandeep Bhatt, sir, to felicitate Dr. Imran Abdullah, sir. I request Dr. Talib Hussain, sir, to felicitate Dr. Shahid Anjum, sir. I request Dr. Gursimran Singh, sir, to felicitate Dr. Zaid Mohammad Rathar, sir. I request Dr. Shaukat Ali Bhatt, sir, to felicitate Dr. Mudassir Nisa Shahdar, sir.
I would now request Professor Dr. Fazul Kader Pare sir to kindly felicitate our chairpersons for the session. First is Dr. Harbinder Singh Bali sir. Dr. Iqbal Salim Mir sir. Dr. Sandeep Bhatt sir. Dr. Talib Hussain sir. Dr. Gursimran Singh, sir. Dr. Shaukat Ali Bhatt, sir. There is an executive body meeting at 5:30 p.m. in Hall 2 outside the auditorium. For tomorrow's session, we will convene here at 8:30 a.m. With this, we conclude day 1 of the proceedings. We thank you all.